Good afternoon. Will be in broadcast in Shakeheart conference at the same time in United Arab Emirates in Dubai. And also it's accredited by the Dubai Authority. And I would like to welcome those participation people from the Shakeheart conference. And this program aims to share the experience on the best practices on the optimizing the anti-anginal and heart failure treatment implementation from the current guidelines. And today's lectures also is focusing on tailoring the angina treatment for personalized medical management with hemodynamic and metabolic approach, focusing on the role of the trimetazidine. And I ask kindly all the participants to type their question in the QA. We will have the discussion at the end of the second speaker. So I will introduce the first and then followed by the second speaker. And then we will have a discussion for about 20 minutes. And I appreciate if you type your question in the QA so we can share it with our experience, or with our speaker, sorry. So it's given me a great pleasure to introduce our first speaker for this program, Professor Giuseppe Rosano, London, and he's a president-elect in Heart Failure Association in United Kingdom. We will welcome you, Professor Rosano, for giving the first talk on optimize the anti-anginal treatment from hemodynamic to metabolic. So Professor Rosano, the floor is yours.
Thank you very much, Professor. It's indeed a great pleasure for me to be here today. Unfortunately, I cannot be in presence, and let's hope that next time it will be possible to meet and directly face to face. So what I will do in the next 20 minutes is to discuss the personalized medical management in patients with chronic coronary syndromes and how to implement the chronic coronary syndrome guidelines. Now, we know that the angina is very prevalent and is very prevalent in all populations. We can see that in Asia, in Europe, Latin America, in the Gulf region, you can see that there is a variability, but is around a 5.3 and a 4 person per 100. However, we also have to recognize that symptoms are often undiagnosed and they are unrecognized by the in clinical practice. Now, if we look at the at this study, is the Cadence study, we can clearly see that in 80% of symptoms in patients with monthly episodes of angina were unrecognized. But what is more worrisome is that more than half of the episodes of angina in patients with weekly episodes of angina were not recognized, and more than 1/3 of the episodes of patients with daily angina were not recognized. So that is very important, because if we look at the importance of angina, we see that angina per se is associated with a significant increase in risk of cardiovascular death and non-fatal MI, or even stroke or MI by itself. And that is even more important than the presence of ischemia only. Of course, when angina is coupled with evidence of ischemia, is even more dangerous in terms of future prognosis. Now, when we discuss about coronary artery disease, we tend to discuss on either or, so either medical therapy or revascularization. But we have to consider that throughout the life of our patients, then we can, medical therapy and revascularizations, they tend to coexist. We can see a patient that comes in for the first time and is immediately revascularized, but then has to go on medical therapy. And then maybe during his life or her life, then we'll need to have other revascularization procedures. On the other hand, we can have patients that present for the first time with angina that is well controlled by medical therapy. Then they get revascularized at some point in their life, but then they will still need medical therapy. So basically, it's not medical therapy alternative of revascularization, but they need to coexist in the same patient. Now, the ESC as guidelines on chronic coronary syndromes have depicted different clinical scenarios in patients with stable angina symptoms, patients with heart failure and left ventricular dysfunction with angina, patients were stabilized after an acute coronary syndromes or after revascularization, and also patients with vasospastic or microvascular angina, or even those patients where that are completely asymptomatic, where coronary artery disease is detected at screening. And regarding the diagnosis, we know that we can span from non-invasive testing, coronary CTA, or invasive angiography. And of course, the choice will depend on the pretest likelihood of the disease, but also on what we have available at that time and in our practice. So that is important, but we have to focus on how we need to diagnose our patients. So, and when they first present, we can either do a non-invasive testing or a coronary CTA, and then immediately start drug therapy. So you see that drug therapy is the cornerstone and is the first approach in all patients with angina. Then only if maximal therapy is not able to control symptoms and patients still continue to have ongoing symptoms, then we can refer for invasive coronary angiography. Of course, it comes without saying that if we detect a very proximal LAD and a left main or proximal disease with from coronary CTA, then we can go immediately to coronary angiography. But then even after the assessment, the revascularization, then drug therapy is always central. Another important point is that it's apart from the drug therapy, we have to consider that patients with ongoing symptoms and with minimal coronary disease or absent coronary artery disease, they may have microvascular angina. Microvascular angina can be very prevalent, and especially in some subgroup of patients. But when we look at the guidelines, also we see that there are the 6 different phenotypes, but I think that we rarely are able to depict patients that we see in clinical practice in these 6 phenotypes. So most of our patients have COPD, peripheral vascular disease, diabetes, venous insufficiency that may limit the use of beta blockers or calcium channel blockers. They can have progressive worsening of left ventricular function or heart failure that will contraindicate the use of many calcium channel blockers. Then we can have patients that after revascularization are stable but have left ventricular dysfunction. We have those patients where there is a coexistence of coronary stenosis with microvascular angina. And a group of patients that is becoming more and more prevalent is that of patients with a myocardial infarction of normal coronary arteries, or those patients with ischemia in normal coronary arteries. So we have a lot of other subgroup of patients that are not covered by the guidelines. They're very prevalent and that often are a challenge for our medical therapy. Now, the guidelines tell us, and this is the same in Europe or in America, that we need to use antiplatelets in order to prevent future cardiovascular events. And also it's advisable in these patients to give proton pump inhibition. Then together with the antiplatelets, we need to use the lipid-lowering drugs in order to prevent future events. And of course, using different targets and according to the different degree of risk. Also, what is important for the Gulf region is the fact that although the guidelines focus mostly on LDL cholesterol, because of the degree of risk factors that you see clustering in the Gulf area, is the non-HDL cholesterol is very important and should be addressed. And then, of course, the ACE inhibitors are the only other drugs that are preventative. Now, we see that the guidelines also suggest that beta blockers are recommended in patients with systolic heart failure. That is the only indication for beta blockers in patients with chronic coronary syndromes where there is a clear evidence of prognostic benefit. But apart from patients with chronic coronary syndromes and heart failure, there's no evidence whatsoever that beta blockers may reduce events. So when we discussed about the chronic stable angina pectoris, then we have different treatment objectives. One is to reduce symptoms and prevent cardiovascular disease, and also prevent future cardiovascular events. And also we have to consider that the treatment, the optimal treatment, is considered that treatment that controls the symptoms and prevents the events. So optimal lipid-lowering therapy, optimal ACE inhibition, and antiplatelet therapy. But also, in order to reduce angina, those drugs that are effective in reducing symptoms for that specific patient without interfering with quality and quantity of life. Regarding the medical therapy and the treatment of angina, we see that the guidelines tell us clearly that the medical treatment of patients is often not just one single therapy. Patients require more than one drug, and in order to relieve angina and ischemia. This is a very important point because it already says that we don't have first line and second line therapy, but also is a contradiction to what is said later in the guidelines. So the guidelines say that there's no universal definition of which drug combination is optimal, and that the anti-ischemic drug therapies must be adapted to patients' characteristic and preference. And this depends on the presence of comorbidities, the tolerance to according to the different patient profile, the drug-to-drug interaction, and also the drug availability in the different centers. So regarding the anti-ischemic therapy, although there is a clear recommendation for the use of short-acting nitrates, so the sublingual nitrates for the immediate relief of angina, there is an indication of first line that is in contradiction to what is said earlier on the fact that we need to use two other drugs. And also another problem in these guidelines is that they initially say that you need to start with more than one drug. then they go and say first line and second line, then go in first step, second step, and third step, with a lot of issues on tolerability. Because if we look at what is recommended by the guidelines and we see what is in the product leaflet of the drugs that are recommended, we can clearly see in the SMPC of atenolol, for example, but of any beta blockers, that they should not be used with diltiazem or verapamil. And also that the interaction with calcium channel blockers with negative chronotropic effect is strongly contraindicated. So we see that their recommendation also contrast from within the text, but also there is a contradiction on what is indicated, on what is it is in contraindicated by the SNPC of the drugs. Now, the major changes that we have seen in the guidelines between 2013 and 2019 is the fact that we have trimetazidine that initially was considered as a 2B, now has become as a clearly as a 2A, and as the same level of all other anti-anginal medication. Whilst we see that the combination of beta blocker and CCB is 2B. Now, this is based on the clear evidence of different meta-analysis of all the in all trials that have been conducted in patients with ischemic heart disease, that there's no difference in the anti-anginal and anti-ischemic effect amongst the different drugs. Now, if we look more specifically at beta blockers and we look at the effect, systematic reviews of and meta-analysis of beta blockers, we see that beta blockers in patients with chronic coronary syndromes do not reduce events. But also, they may have some contraindications or intolerance according to the presence of comorbidities. Now, comorbidities are very important because they interfere with the diagnostic pathway. They may aggravate angiogenital symptoms. They may affect the use of treatments. For example, the fact of we cannot use we can not fully use the beta blockers in patients with asthma or peripheral obstructive arterial disease. And we cannot use with other medications. We cannot use, for example, or we have to have caution in using ranolazine in some subset of patients. Now, therefore, if we go at and look at the guidelines and we try to put together what is suggested as first line, second line, contraindication, and different and stepwise approach, we see that the guidelines also tend to identify other subgroup of patients according to the heart rate, presence of LV dysfunction, and blood pressure. But we see that we have other subgroup of patients that are not completely covered by these guidelines. Now, the other important and very important point is that we have to move away from the classical view of coronary syndromes, where we see a very nice, very focal, or in this case, two focal lesions and epicardial lesions, where we can say we go there, we dilate them, and that it's solved. Because it's not that easy, because the coronary syndromes are due to not just the epicardial stenosis, but also by dynamic obstruction of this incredible reticle of vessels that is the microcirculation. And what often happens in one patient is that we may have an obstruction, say, on one big epicardial vessel, but then an obstruction downstream in other areas. Or we can have a lesion on, in this case, like on the right coronary arteries and microvascular angina. And then when we treat the vessel, then we have patients still continue to have symptoms, despite a good angiographic success because of the underlying microvascular disease. So we have to consider the importance of microvascular disease in determining symptoms in patients with angina. And for this reason, together with Professor Ferrari and others, a couple of years ago, we've proposed a different approach to the treatment of angina, where we have the different phenotypes of patients with myocardial ischemia that are due to not just at the stable plaque or the presence of microvascular angina, but also by the presence of vasospasm, endothelial dysfunction, inflammation, and metabolic dysfunction. This has led us to suggest the possibility of approaching the therapy of patients with chronic coronary syndromes according to the different phenotypes, and identifying a core therapy that then should be adapted according to the different phenotypes like peripheral arterial disease, diabetes, chronic kidney disease, the presence of coronary spasm, the presence of COPD. And that led us to come with, for each different phenotype, to give a green, a red, or a white, where green is preferred, the white can be co-administered, and red is absolutely contraindicated. And you can see that then you can basically look at all your phenotypes. You can look at cardiac phenotypes, so high heart rate, low heart rate, normal blood pressure, low ventricular dysfunction, atrial fibrillation, heart failure, or the presence of comorbidities like diabetes, chronic coronary artery disease, COPD, peripheral vascular disease, and so on and so forth. And that enables us to identify very clearly our patient and see which drug are absolutely indicated, which drug are contraindicated. So we can see, for example, how if we take patients with heart failure, we see that we have a clear indication for beta blockers and ivabradine together, and then add trimetazidine as a first step, or nitrate and ranolazine. And that is exactly in keeping to what the guidelines or the ESC guidelines tell us. So the Diamond approach basically expands further the guidelines of the European Society of Cardiology, giving a better personalization. And you can see that in this case, for example, if we have patients with atrial fibrillation, there is indication for verapamil, for beta blockers and verapamil with all the contraindications I highlighted earlier, and then the use of trimetazidine in these patients. Or if we have a patient with high heart rate, of course, we need to use beta blockers and ivabradine, and then we can use trimetazidine and or ranolazine. And you can see that this is exactly in line with the guidelines. Now, however, when we discuss about the antianginals, we have to consider that the antianginals are not all the same. We have beta blockers, calcium channel blockers, and nitrates that are vasodilators. And various studies have shown us clearly that if you combine two anti-anginal medications with a hemodynamic mode of action, you don't see any additive anti-anginal and anti-ischemic effect. It has been clearly proven by the ASIS, TBET, APSIS, and CSEC. So basically, if you give our patient who is beta blocked, you're not going to see any additive effect from nitrates or via calcium channel blockers. And also, we've looked at the evidence that has been generated over the years in the past 50 years of medical treatment, and we performed this meta-analysis and this systematic review, showing that there was no evidence that there's one drug better than the other to be used in combination. Now, it becomes clear that if our hemodynamic agents do not work in combination, we need to find a different approach. And the different approach is the approach that is given by trimetazidine. Trimetazidine is a completely different antianginal medication because it blocks the beta oxidation. By blocking the beta oxidation, increases the utilization of glucose to enter the Krebs cycle through acetylcoenzyme A. By doing so, increases the production of ATP per mole of oxygen. So even when there is a reduction in blood flow, the switch towards the glucose utilization leads to more production of ATP. That, on one hand, is more effective in maintaining contractility, is more effective in reducing myocardial ischemia. But since ATP is generated, there is less release of adenosine. That is the primer for angina. So there is a clear effect on angina through the reduction of the spillover of adenosine and reduction of myocardial ischemia and left ventricular dysfunction because of a greater production of ATP. Trimetazidine has been shown to be as effective as a beta blocker and a calcium channel blocker in monotherapy. These are the comparative studies with trimetazidine and with propranolol. And you can see that the increase, the anti-ischemic threshold and the total exercise time were similarly improved by both trimetazidine and propranolol, and the reduction in episodes of angina were similar in patients receiving trimetazidine or a calcium channel blocker. But I think that this is one of the most beautiful examples on the fact that you need to use a different approach to treat angina. So you can clearly see here, these were patients who were receiving background beta blockade, and then they were randomized to receive either trimetazidine or nitrates. You can clearly see here what I said earlier. So when you give a nitrate, in addition to a beta blocker, you don't see any effect on ischemic threshold, no effect on angina. But when you add trimetazidine to a beta blocker, you can clearly see a significant improvement in time to ST segment depression, so in ischemic threshold, and time to angina. So very clear anti-ischemic effect. And so that tells you that if you have a patient receiving already one anti-anginal hemodynamic agent, then you need to use trimetazidine. The effect of trimetazidine have been clearly demonstrated in the largest study ever conducted in patients with angina. This was the Vasco study conducted in 1,960 patients with angina, all of them receiving atenolol, and they received on top trimetazidine or placebo, and you can clearly see a very significant effect of trimetazidine in ischemic threshold and exercise time. But also something that was very important in the study was that if you double the dose, then you can see even a greater anti-ischemic effect. This is very important because that tells us that we don't know what is the threshold of efficacy of trimetazidine, and therefore in the difficult patients, we can even double the dose without any problem. Another important lesson that we have with trimetazidine, and that is something that you may know very well from your clinical practice, is that the drug is very effective no matter what is the background therapy. Patients with beta blocker plus calcium channel blockers, beta blockers nitrates, calcium channel blocker, you see that trimetazidine always decrease the number of episodes of angina, but also this reduction is progressive. So you see one effect at 2 weeks, 2 months, and the effect of 6 months are even greater. So you need to give the drug some time to work. Now, one other important point was the study that came from the Khmer study that came from Korea, where they looked at the at patients with an acute myocardial infarction that were discharged either on trametazidine or on without trametazidine, and the MACE-free survival probability was much higher and better with trametazidine compared to control. Then this is another important piece of information that tells us how the benefits of trametazidine span from patients with very simple, so patients with just angina, to patients who have angina and are not amenable to revascularization. And we are seeing more and more of these patients nowadays. And you can see that in these patients, the adding trametazidine was effective in reducing by 40% the episodes of angina, reducing by more than 50% the use of GTN, and improved clearly the quality of life. Another important point is that often our patients with ischemic heart disease have erectile dysfunction. And we know very well that they cannot use the PDE5 inhibitors, so like sildenafil or tadalafil or whatever, but also they cannot use the injection of prostaglandin if they're taking nitrates or if they take a vasodilator. Now, we conducted several years ago this study where we put a 48-hour ACG monitoring in patients with evidence of inducible ischemia. We asked them to have a sexual intercourse during the study, the monitoring period, and they were randomized to receive trametazidine plus sildenafil or nitrates. And you can see that when patients take sildenafil in addition to trametazidine, they have a significant reduction in the episodes of ischemia during sexual activity. So that tells us that if we have patients with erectile dysfunction, we can safely give trametazidine. And indeed, in these patients, trametazidine has a compelling, clear indication, as it is very safe and has a very significant anti-ischemic effect. Trametazidine is also very effective in patients with diabetes. This is a study we conducted more than 10 years ago, where we took patients with diabetes who were asymptomatic, or they were thought to be well controlled. And we found that on that 48-hour ECG monitoring, most of these patients had episodes of silent ischemia. And those who were randomized to trametazidine had a significant reduction in the number of episodes of silent ischemia, and a reduction in the total duration of ischemia during the monitoring period. So that tells us that our patients with diabetes, even if they do not report symptoms, they still have silent ischemia, and therefore it's better to use in all these patients trametazidine. Now, more recently, the trametazidine has been tested in order to see whether it was possible to extend the indication in patients with after a PCI. And the AT-PCI was conducted it was a large randomized study that was conducted worldwide. Now, I have to say that there was not a clear and compelling reason to do so, because we know that after PCI, beta blockers do not reduce events. We know that ranolazine in patients after PCI failed also to show any benefit in reducing events, and was associated with some increased side effects. But regardless, the AT-PCI was designed, first of all, to assess the safety of trametazidine. This was a study that was mandated by the European Medicines Agency to assess the safety of trametazidine and also the efficacy of trametazidine added to standard guideline medical therapy in patients who had just had a successful PCI for stable angina and STEMI. So basically, the study was to see whether it was possible to extend the indication in patients who are completely asymptomatic for a prognostic benefit. So it is important to understand what was ATPCI. ATPCI was a study to assess a new indication for trametazidine as a prevention for PCI, after PCI. And was also a study to assess the safety of trametazidine on falls and neurological tremor. The ATPCI was not a study to assess the effect of trametazidine on angina, and was not a study to assess the effect of trametazidine or the anti-cardioprotective effect of trametazidine during PCI, because the study, or revascularization, because the study patients started to receive the drug afterwards. Now, the study, despite showing a trend towards a reduction in cardiovascular death with trametazidine, did not demonstrate any significant effect in patients who are completely asymptomatic. So the insight that we get from trametazidine, from the ATPCI, is that the study was very successful, and there was demonstrated clearly the safety of trametazidine post-PCI. Of course, it couldn't show a reduction in angina, because these were patients without angina, so you cannot treat for something that is not present. So just to recap what we said in this past half an hour, basically there is clear evidence that angina with or without ischemia carries an adverse prognosis. Now, we see that the ESC guidelines on chronic coronary syndromes, they focus mostly on intervention and revascularization, and how to treat patients after an intervention and revascularization, with secondary preventative measures on how to implement antiplatelets, lipid lowering, and ACE inhibition. Now, they also say that the combination therapy should be implemented for the control of angina and myocardial ischemia in patients with chronic coronary syndromes. But we, as I showed you, the diamond approach basically expanded further and allows us to use the same recommendations of the guidelines into a better phenotyping of patients that will basically give us the picture of the patient that we have in front of us, and therefore detect and decide on what is the best treatment for that specific patients, that necessarily will be completely different from the one that in 15 minutes will walk through your door and with the same symptoms. I showed you that trametazidine, either alone or in association with beta blockers, confers a greater anti-ischemic effect than beta blockers alone, as an increased tolerability to anti-anginal medications, has a significant effect on exercise capacity and quality of life, and should be implemented in most patients with ischemic heart disease. I think I'll be happy to take your question later, and I will stop here for the time being. Thank you.
Thank you very much, Professor Rosano, for a very nice, elegant presentation, informative, going throughout the role of trimizidine in the anti-anginal and on the hemodynamic and cellular level, and also very nice information you gave us on the insight from the ATP PCI trial that really was very useful and informative. I ask you kindly to stay after the second presentation, so we'll have sure more question in regard to your presentation, but thank you very much. Now I have the great pleasure to introduce our second speaker, Professor Mustafa Shimmeri, a friend of mine, and he's also a chairman of Cardiac Science Department in College of Medicine, King Saud University Medical City in Kingdom of Saudi Arabia, where he will give us a talk on diabetic angina patient in clinical practice. Before I give him the microphone, I ask kindly to type your question in the QA. At the end of the presentation of Professor Shimmeri, we will have a discussion. So thank you very much for your participation, and now the floor is yours, Professor Shimmery, to address your talk.
Thank you very much, Dr. Musa Akbar. Thank you. Very good introduction. I have nothing to disclose for this talk, that except that we are taking some honorarium from so many industrial companies for the talk or for speaking or for advisory board. So I'm going to talk about the diabetes in the context of atherosclerosis cardiovascular disease and the risk factors. And I will give you a case history for management of stable coronary artery patients in diabetics. Then we will discuss some comparison between pharmacological therapy and the intervention, and brief touch on the trimetazidine and its role in the treatment of coronary artery disease. And then we will conclude. As you know, that already trimetazidine has been exhaustively talked by the Professor Rosano, and I think we have learned from him a lot about the product. Now, what we want to show you that the major things for the development of atherosclerotic cardiovascular disease is the risk factors. And those risk factors, which is very important, in fact, diabetes, hypertension, dyslipidemia, smoking, and other risk factors, where it starts with the atherosclerotic process started by the presence of fatty streaks. Then this fatty streak will take a longer time to develop significant obstruction of the major coronary artery tree. And then that will result in either of the acute coronary syndrome or chronic coronary syndrome with stable coronary artery disease. What I want to say about diabetes, that diabetes, whatever it is, wherever the patient has diabetes, is not anymore low risk for cardiovascular events. That will be either moderate risk or very high risk. So once you have a diabetic patient, regardless of anything else, that the patient is at very high risk or at a high risk or moderate risk. So the very high risk patients, those with already having a target organ damage from diabetes or associated atherosclerotic cardiovascular disease, those patients who's a high risk without a very high risk, those diabetes with 10 years old, without 10 years duration of diabetes or more, and without any target organ damage. And younger patients with diabetes of less than 10 years, and that whether it is type 1 or type 2, that's a moderate risk. So you can observe now that diabetic per se, it puts the person at risk of atherosclerosis, at risk of cardiovascular events, regardless of whether the coexistence of atherosclerosis or no. So this is important because at the end of the day, when you have atherosclerosis with the triggering risk factors, you are going to have atherosclerotic process in the brain and will cause cerebrovascular disease and stroke, or you will have it in the peripheral and it will cause a peripheral artery disease and limb ischemia and amputation, or it will be in the coronary and it will cause a coronary artery disease either in the form of a stable or in the form of unstable acute coronary syndrome of MI or non-STEMI. So that's the process, how the interactions of atherosclerosis and the cardiovascular outcome with the presence of diabetes mellitus. And as we have said, diabetes, if it is there, then you are not anymore low risk. So in our societies, as you know, most of the time the patients with diabetes, they will present late, and you might catch them up only after 10 years of their diabetes development. By that time, they are already very high to very high risk. This is an interesting study that it showed how the myocardial infarction and the stroke will develop as a hazard ratio in patients with a cohort of a huge number, more than 117. This is a nurse study. And then you can see that they included all the participants, and they looked into their diabetes and the correlation to MI and the stroke relative risk reduction. So in the beginning of the recruitment, if they found somebody already diabetic, he is having a hazard ratio of 5 for the development of stroke or myocardial infarction. But if the person has after recruitment, they discover that the patient is diabetes, then he has a 3 or almost 4 hazard ratio risk of relative risk reduction, relative risk for myocardial infarction or stroke. And of course, you can see if there is no diabetes in the beginning, then most probably your hazard ratio is 1. So cardiovascular events is almost always associated with the presence of diabetes, and it will magnify the cardiovascular outcomes because of the presence of diabetes mellitus. And the slides, you can see that it is from more than 350 patients. You can see comparing diabetic with non-diabetes. You can see that the hazard ratio is for the coronary death here, and for the ischemic stroke is so high, up to 2.3 hazard ratio. So it means that comparing diabetic, not diabetes, diabetic patient per se, just having diabetes, he has double the risk of myocardial infarction or stroke. And then diabetic patient is already equivalent to myocardial infarction. This is a patient who has no diabetes, but he has myocardial infarction. And this is a patient who had diabetes, but no myocardial infarction. So they are equal in terms of the outcome. So that's why we say that diabetes is equivalent to myocardial infarction, because they are at the same risk of the outcome or poor outcome. Secondly, that the presence of diabetes is a predictor for frailty in elderly patients. So elderly patient, if he is diabetic, he is more frail compared to the non-diabetic patient. And the frailty, you know, it at work, it play a role in so many aspects of the healthcare and the expenditures of the cost for the healthcare. So that's an important thing, which is important to remember, that diabetes is equivalent to myocardial infarction, even if there is no atherosclerotic cardiovascular disease. This is another study, which is the OSS trial, which showed if you have diabetes with atherosclerosis, your risk of the events rate is too high. The hazard ratio, the relative risk, almost 2.88, almost 3. But if you have either of them, you have diabetes or cardiovascular disease, but not both, they are all equal. So that's again confirming that the diabetes is equivalent to cardiovascular disease. But if you don't have no diabetes, no cardiovascular disease, the event rate, of course, the hazard ratio, the relative risk is 1. So this again emphasizing that importance of having diabetes, as it is equivalent to cardiovascular events. Now, the other important points is that unfortunately we have the inertia of delaying the management of patients with diabetes, whether for the diabetes or for the other risk factors. And this delay of introducing the cardiovascular intervention by treatment of the risk factors is going to harm the patient by the delay. And that's what we call the inertia of physician or the inertia of clinicians. You can see that the most important factors in diabetic patients, not to treat the diabetes per se to get the hemoglobin A1C, because hemoglobin A1C, it will only reduce per 9%, it will reduce only -3 the events. The events will be, or the ratio will be only 3. But if minus, then you will have a -8.2 reduction if you are treating patients with hypercholesterolemia or for LDL. So 1 millimole of LDL will reduce the risk of events by 8.2. And 4 millimeter blood pressure reduction, it will reduce the event by 12.5, compared to the glucose, which will reduce only by 2.9. So that means it is more worth to get control of the risk factors like the dyslipidemia and hypertension, more than you invest on the treatment of glucose per se. And most of the patients in our society, as has been said by Professor Rosano, that they are a cluster of risk factors in each patient. And I am sure if you ask yourself how many patients I am seeing, they have only one risk factor. I think that's not existing and negligible. Even if you have one risk factor for somebody, you will find him obese. And that's by itself is enough to indicate that there is a multiple risk factors. So I will introduce to you a case, which is a patient of mine, 55 man who's a smoker and stopped 18 months ago. He's diabetes for 20 years on oral hypoglycemic agent. He's hypertensive for 4 years. He had history of chest pain 18 months earlier, and he was on treatment, but developed worsening of his chest pain, and he came to cardiology clinic. Examination was 140/90 blood pressure, and the heart rate was 76. His weight was 80, and the remaining exam was normal. So he's an average body built with a risk factor of being male, long-standing diabetes more than 10 years, and ex-smoker, hypertension. The risk factor for this patient, and then his investigation revealed that hemoglobin is 13 and the renal profile, liver function test, cardiac markers was normal. So the patient was treated by another hospital with anti-anginal therapy, but unfortunately he continued to have the chest pain, and he came to my clinic. The time I have done his ECG, you can appreciate that he had the distal lead ECG. His heart rate is around 76, but still there is a room to reduce the heart rate, and there is diffuse ST segment changes in the anterolateral leads. So having him symptoms still there, and he's having those multiple risk factors, I optimize the medical treatment, but we send him for coronary angiogram. And this is what you can see from the system, that you can see this coronary artery tree. You can appreciate how this is the left anterior descending artery, which is the most important artery for the coronaries. And this is the left circumflex artery, which is obtuse marginal branches. You can appreciate that this is a dominant angiogram, left dominant system, because of the PDA coming from the left circumflex. You can see that there is no point where you can think of revascularizing this patient. This is all diffused from the beginning of the LAD up to the end, and from the beginning of the circ up to all branches of this. So the patient was not amenable for any relieving his symptoms by revascularization. What I want to tell you at this stage, that the medical treatment and percutaneous revascularization for patients with stable coronary artery disease is nothing to do with vital. They are all for symptoms relief. And it is none of this for the treatment or for prognosis, apart from if you have a proximal LAD disease or left main disease. That's a category where you might change the cardiovascular events and mortality. This patient, he was on beta blocker, bisoprolol 10 milligram, calcium channel blocker, amlodipine 5, nitrate, aspirin, rosuvastatin 10 milligram, lisinopril 10 milligram, and in fact, I added for him trimetazidine. And the patient, he was put on 35 milligram twice a day trimetazidine in addition to this. You can appreciate that the trimetazidine has no hemodynamic consequences, and it can be introduced with any one of the medication. There is no drug-drug interaction with any one of the drugs used in cardiovascular or diabetic arena. So this patient, he went, but after that, he went to another hospital, and in fact, in another country, where he underwent another coronary angiogram, and then they, of course, before doing angiogram, they did a lot of tests, and he spent about 60,000 Saudi riyal, and then he came back again with no changes, but again continue to have from time to time exertional angina. So having those information, I told him from our side, we have only the medication, and this is the only medication you are going to have, but there we have to maximize the medicine up to controlling the blood pressure, the heart rate, and control the lipid profile in your case. And then if nothing, then we have some other sort of angina relief, like sympathetic denervation or pain management or whatever. And you can observe that this patient is only 55 years. As you know, that most of our patients in the Gulf area, they are dying 10 years earlier compared to the Western country. So you can appreciate that most of the drugs, if they are used in the setting of heart failure, or they are used in the setting of myocardial infarction or acute coronary syndrome, there is a mortality reduction and there is cardiovascular event. But in case of the stable coronary artery disease, they are only for the relief of symptoms. I can challenge you that there is no single drug that can be used in treatment of a stable coronary artery disease has any impact on mortality, whether it is total mortality or cardiovascular mortality. So it is very important to embark on lifestyle modification, improve ischemic symptoms. You might go for the ischemic or myocardial revascularization if it is amenable. We know that prognosis might improve if you have a left main or proximal coronary artery disease to be fixed. But overall, don't forget that to treat the patients overall and to tailor or personalize the treatment for your patient depend on the patient case. Again, this patient came back after about 24 months, and then he told me that I went to somewhere in a nearby country, and then you can see that they threw a metal in the circumflex. I don't know how this interventional cardiologist thinking. He left all the LAD, he left all the problem in the OM, he left all the diffuse, and then he throws a stent of 2.25 by 15 millimeter drug-eluting stent. He threw it here, and then he said to the patient that you have to stuck to the clopidogrel and aspirin for 1 year. The time he came to me, he said, I have been through the another angiogram, and they bought for me the AMA. The AMA means stenting. And you can appreciate that, as we have said, that the stenting, we are stenting him, but we don't know what we are doing. Where the problem or where the pain is coming, the symptom of angina coming from where? The patient has diffuse overall coronary trees. You are throwing the stent here only for the sake of satisfying yourself or satisfying your patient. This is a crime. So we have to be careful not to send the patient for interventional cardiologist if the patient has no amenable lesions for stenting, or there is no hope from complete revascularization to reverse the symptom of your patients. So here I'm trying to compare for you the treatment with medical therapy and intervention for stable coronary artery disease. In the past, in 2005, 2017, there was a COURAGE and the BARIT-2 diabetics trials, which have shown that there is no evidence there is no difference between revascularization by any means or by medical therapy. So we know by this all the studies that there is no difference between the drug therapy and the intervention. So don't rush to the intervention if there is no prognostic lesion the patients will be fixed for. And if the patient has diabetes with those diffuse atherosclerotic process, as you can see, probably better not to touch. And this is the outcome, the survival for coronary artery bypass, survival for PCI, survival for freedom from cardiovascular event. There was no difference between the two in both BARIT trial and in the COURAGE trial. So recently in 2019, the ischemia trials came out where they bought a patient for stable and coronary arteries for revascularization or for angiography and angioplasty or surgery, and patient for medical therapy. Again, it showed that there is no difference between the medical therapy and the intervention. This is yellow by medical therapy and routine invasive therapy by blue. There is no difference. And this is almost, I think so, but I think it is the last chapter in the revascularization process in patients with a stable coronary artery disease who does not have a prognostic lesion like left main or proximal LAD. So the goal of our treatment is just to prevent death by revascularization or by drugs in case of unstable coronary artery disease or myocardial infarction, and then optimize health status by the quality of life, and of course revascularization when it is required, when it is appropriate. So in bottom line, medical therapy relieves symptoms. Medical therapy might prolong life, but it is depend on which patient we are introducing the treatment for him. So just touching on the demand supply mismatching in case of the patients like my patient who had a lot of the underlying coronary artery disease, diffuse disease. This patient, they have a problem with the angina secondary to low oxygenation. There is no enough oxygen. And because there is no enough oxygen, the patient will develop the chest pain as a result of ischemia in the territory of the area of ischemia. So the drug is, as we have said, the drug is acting. All the drugs, they have the similarity between relieving the symptom. And the unique trimetazidine, it works in the cellular level. And this is where is the interesting metabolic work, where it will work in the cell, similar to most of the modern medicine that people going for genetics and for cellular medicine. So that the mechanism of action of the trimetazidine is a very interesting mechanism of action. For the first time, metabolic approach, reducing the cardiac symptoms in patients with stable coronary artery disease. Since 2012 up to 2016, the guideline, European and American College of Cardiology, addressing the benefit of trimetazidine in patients with stable coronary artery disease at a different level of evidence like class. And then recently, as Professor Rosanna showed this slide, 2019 is almost class 2-1, class 2A for the patient who has been on treatment, and they are almost equal to beta blocker and calcium channel blocker and the others. And it is very important to emphasize that this drug is really safe, no drug-drug interaction. And I will tell you from my humble experience, but those patients, we introduced the drugs since 2013 in my hospital, and since then, if we come to stop the medication, we can stop any medication from the patient, but you cannot stop trimetazidine because the patient will fight for you because he feels that this drug is doing something good. So to conclude, trimetazidine different from other anti-angina because it works at the cardiac cell. It does not alter the hemodynamic, neither the heart rate nor the blood pressure. It has no metabolic side effects like hyperglycemia or hypoglycemia or hypertriglyceridemia. It has been tested in more than 5,000 patients worldwide in 29 trials. It provides a clinical relevant to addition and a benefit of combining with other medication for treatment of patients with stable coronary artery disease. Here, just I want to show you the mechanism of actions. Normally, the glucose pathway is the usual pathway in the normal situation where it produces the ATP and the energy for the heart to contract. Now, when you have ischemia, the two processes going on at the same time. But this process is speed up, meaning that there is a shift from the glucose pathway to fatty acid pathway. And then in the fatty acid pathway, it is very costly. You need a lot of oxygen to utilize this fatty acid pathway. So what trimetazidine came to block this pathway and to allow only the glucose pathway, which is a very cheap from the oxygen consumption point of view, to produce good amount of ATP for contractility. So the shift of during the ischemia, both process to produce ATP is there, but the glucose will be slowed down and the fatty acid will be speed up, but that will be a very costly in terms of energy consumption. So the drugs come to block this enzymatic pathway from the fatty acid area and then allow only the glucose pathway to go and to bring for us the energy for contractility and for relieving the symptom of the patient. This is where the trimetazidine block the enzymes in this fatty acid pathway. Again, similarly, just the trimetazidine block the free fatty acid pathway for production of the ATP from the glucose pathway. And then, as I have said earlier, that we have trimetazidine has probably more than one mechanism of action. as it is a metabolic process with working at the enzymatic and cellular level. Maybe it has a vascular muscle cell proliferation prevention or reduction. It has reduced insulin resistance. It has a adiposity increase, adipoectin, which is fighting against the deposition of fatty fats, and it has some anti-inflammatory. Fatty acid oxidation, as I have said, it is reduced. Oxidative stress reduced. Mitochondrial function improved. And vascular endothelial function. So that's why in addition to beta blocker, or in addition to that, you might have that chance of increasing the energy of ATP by 33%. And that will relieve your patients from the ischemia in the situation of ischemic heart. As you can see, the beta blocker will reduce the energy demand by reducing the heart rate, but the supply will be increased, the oxygen supply or the energy supply will be increased by trimetazidine. The combination of both is ideal if there is no contraindication for beta blocker. So this is my last slide, and I will conclude that diabetes is a major risk factor for atherosclerotic cardiovascular disease. Diabetic patient is not low risk patient, it is moderate to high or very high risk. And intervention to control the risk factors are paramount important in the situation of diabetes and in our society where the cluster of the risk factors there. For the first time, trimetazidine is included in the algorithm of risk guideline of American College as a second line, and similar to other drugs like in the combination of beta blocker or in isolation without beta blocker. Ischemic heart disease may result from a number of mechanisms, including atherosclerosis and microvascular and coronary vasospasm and platelet dysfunction. So that's why you have to work in more than one area to control the risk factors and to take care of the vasculature. Addressing the energetic origin of ischemia is very essential, and I love to see this trimetazidine as a part of our formulary to treat patients whom we have the very difficulty of getting the control their ischemia. However, I have some anecdotal experience of treating some of the different type of ischemia like vasospasm, bridging, and sometimes we have the microvascular disease. We are giving them as well trimetazidine, and we see some clinical response from the patient. Thank you very much, and then I will leave the floor for our chairman, Dr. Musa Akbar.
Thank you very much, Professor Shimmery, for a very nice presentation and overview of the role of trimetazidine in especially in diabetic patient with your nice case presentation. So we will open now. We have about 20 minutes for discussion, and I will address the first question to Professor Razzano, and then I will see the opinion and experience of Professor Shimmery. Professor Razzano, patient who labeled by a cardiologist, interventionist who do the coronary angio, that this patient is a syndrome X, and then with no obstructive lesion, the coronaries, otherwise normal epicardial coronaries, he could not demonstrate a vasospasm during his procedure for reason or another, but he labeled as syndrome X. So does really the trimetazidine has a role in these population?
Yes, I mean, it works in patients with microvascular angina. It works pretty well. What is important is that when we get the label of syndrome X or microvascular angina, if possible, if we can look ourselves at the angiogram, because sometimes you can see the hallmarks of syndrome X and microvascular angina. So the very tortuous vessels or the slow runoff. If you get those patients, those are the patients that will benefit. If you see, say, normal smooth vessels with normal flow, I would rather look for other causes because then any other anti-anginal is not working. But in those with true microvascular angina, or either that we see with the tortuous vessels or slow runoff, or those patients where, say, a provocative test has been performed, then in those patients, trimetazidine is working very well. And what is important is that if they have high heart rate, it is always better in these patients with clean coronary arteries or near normal coronary arteries to avoid beta blockers to reduce the heart rate, because beta blockers can have a detrimental effect on the microvasculature, and they can also induce some vasospasm. So trimetazidine, and if we have to reduce the heart rate, then use the ivabradine to reduce the heart rate.
Dr. Shimmery, do you want to comment in Syndrome X? Have you used it in your experience?
Thank you very much, Dr. Musa. I'm sure you are opening a very active window in the literature about microvascular disease. And I think diagnosis of microvascular disease nowadays is very difficult. It has to have a special, laboratory, special setup, special interest in terms of physicians to be able to confirm that we are dealing with this type of microvascular disease rather than the other type. We are all, as you know, that you are one of us as interventional cardiologists, that we are dealing with an epicardial large vessel. If it is affected, we can fix it. But some of our patients with stable coronary artery disease, they come back despite fixing their coronary. They are coming back with the same symptoms, or at least symptoms is still there, but is less than before. We used to tell them that this is maybe the Mittal causing some irritation for your heart, and then you will improve later on. So in that sense, that I agree that sometimes with this metabolic mechanism it might work, but adding it to difficult patient to respond to the usual treatment, I think it is worth. One of our colleagues having a patient with very difficult to treat vasospasm. She is only 35 years old lady, coming almost every week to the emergency room. We tried with her everything, and then including ivabradine, trimetazidine, we did all. We added trimetazidine, again, some improvement, but this case is different because it's vasospasmatic clearly. For the microvascular disease, thank you for bringing this question. I think it is an area going to flare up in the literatures, and we will be able to know better about it, and then we will find some of our physician who's more interested to work on it. But Professor Rosano, I think he works with this trimetazidine with Professor Ferrari, and they have more experience in a different type of indication for the trimetazidine.
So back to you, Professor Shimmery, patient with diffuse vasculopathy, diabetic. You show it very nicely by angio. And diabetic, diffuse vasculopathy with cardiomyopathy, less ejection fraction in 40s, and then he's not amenable to any revascularization. Do you think that the trimetazidine will help, one, in improving his ejection fraction if he uses it, and in improving the symptoms, especially the ischemia, giving the vasculopathy nature for this vessel?
Yeah, thank you very much. Dr. Musa, you know that because of the multiple, the cellular level, it works at a mitochondrial level, and I have shown the array of effects of trimetazidine in different levels of the vasculatures. I will believe that there will be some improvement, definitely not only in terms of the symptoms, but as well as in terms of utilizing the energy and probably the recovery of the myocardium. But I think purely, I have been across some of the reports that trimetazidine improve the ejection fraction in some conditions. But I think Professor Rosano probably will answer this question in terms of ejection fraction in particular.
Professor Rosano, could you comment? There is some small studies showed that there is an improvement in ejection fraction giving trimetazidine, I think 3 months or more. There are one of the study I showed, I have seen it in the literature. So in this particular patient that Dr. Shimmery has presented vasculopathy, diabetic, and with low ejection fraction, you believe that the trimetazidine works in both directions, might improve the ejection fraction and also reduces the amount of recurrent angina in this particular patient?
Yeah, absolutely. I mean, we published now 25 years ago the first study on in patients with dilated diabetic cardiomyopathy, most of which were patients similar to the ones we've seen during the case. So, and we've reported that there was a significant improvement in left ventricular function. After our study, several other studies have shown similar effects, and there have been recently 3 meta-analyses of all studies with tremetazidine clearly showing that there is an improvement in left ventricular function and in exercise capacity in patients with diabetes and cardiovascular disease, but also in patients with diabetes alone. So there's a clear, a very good space. What I always say in these patients, also something that is always useful to add to tremetazidine is something like fenofibrate, because in your, especially in the Gulf area where the non-HDL cholesterol is very important, and we have data also from say the Fields and Accord study that showed that in patients like those that we've seen, there is a clear effect on the microvasculature as well. So it's for these patients, I would go for tremetazidine for the benefit on left ventricular functions and symptoms, but also metabolically, I would optimize them with
Good evening. This is my great pleasure once again to invite you and welcome you all on this second day of Shakeheart 2021. Uh, Many of you would have attended yesterday's sessions, and I'm sure you must have found them exciting and interesting and with some take-home messages. The next coming up session is also very power-packed session. We have stalwarts speaking here in this session, and we have one speaker from US, one from India, and one from UAE. All are very, very established speakers, wonderful friends, my mentor also at some stage. So I'm very pleased to have you all. I will introduce the moderators of the session, and then moderators will take on further. So here to moderate the session, we have Dr. Rajesh Rai Pancholia, a consultant interventional cardiologist in Dubai, UAE for a long time. And we have Dr. Rupesh Singh, another prolific young interventional cardiologist, a wonderful boy, wonderful person, good doctor. He will be the one who will be moderating. And we are also expecting Dr. Praveen Chandra to join anytime. So I hand over the floor to you, Dr. Rajesh and Dr. Rupesh. Dr. Rajesh, you can welcome the first speaker and we can take the proceedings forward. Thank you.
Hello, Dr. Mittal. Thank you for the invitation for this wonderful meeting. And without wasting any further time, I would like to introduce the first speaker, Dr. Brajesh, who is a world-renowned interventional cardiologist based from USA. And sorry,
So Dr. Shawl is actually
Yeah.
in the business for more than 35 years, I suppose. He's a pioneer in intervention
Yeah.
cardiology. He's the director in Washington Adventist Healthcare. He is also chairman of Heart Center in Zuleika Hospital. He keeps visiting Dubai, and we had met him first time personally in New Delhi when I was a kid in cardiology. So this is how it goes. So thank you, and we welcome you, sir. And your lecture starts now.
All right.
So thank you.
Greetings and good morning from Washington. Thank you, Dr. Mittal, for your kind invitation to speak on improving outcomes in high-risk interventions, current additional therapies. I have nothing to disclose. Which patients really need additional therapies to improve outcome? I mean, use of a hemodynamic support. We're talking patients with complex coronary artery disease, patients with multivessel and left main coronary disease, patient with hemodynamic compromise, a depressed left ventricular ejection fraction of 35% or lower, as well as patients with acute myocardial infarction with shock, cardiac arrest, severe left ventricular and right ventricular failure, complex subset lesions, valvular disease, as well as prior surgery, in addition to comorbidities. When you have this kind of population and you use hemodynamic support for high-risk intervention, we call it protected PCI. Now, what are the approved percutaneous left and right ventricular devices available which might improve the outcome? We have right now, as we know, intra-aortic balloon pump, ECMO, tandem heart, Impala support devices, as well as Impala RP for right ventricular failure. Now, what kind of hemodynamic support you need in the cath lab? Really, it depends on what kind of patient you are dealing with. If you're dealing with a patient with, mild hemodynamic compromise, slightly low blood pressure, volume under volume function, and then you may use some volume expansion or inotropes for a short period. But if you're a patient, what I call intermediate risk patient with hypotension, cardiac shock, then without any pulmonary involvement, we may be talking using a balloon pump or Impala 2.5 or Impala CP in such cases. But if you have a high-risk patient, patients with severe ventricular failure, with unstable rhythm, patients who undergo cardiopulmonary resuscitation, chest compressions. In that subset, you need to use either Impala 5.0 or 5.5, but more likely an ECMO in such situation, particularly if patient is hemodynamically very unstable with unstable rhythm, as well as requiring chest compression. This is an example of an Impala support device here. Basically, this device comes in 2.5 or CP, which is up to 4.5 liters, Impala 5.0, 5.5, and recently introduced right ventricular support Impala. Impala device basically increase the coronary perfusion pressure. It is active LV unloading, particularly when you use ECMO. It reduces the myocardial oxygen demand. It increases the oxygen perfusion to the organs, and Impala RP for RV failure. And these devices can be used for extended periods, even up to 2 or 3 weeks. This is just showing here Impala CP. You use a 14 French sheath, and basically over the wire, you cross the aortic valve, and this is the inlet. You can see it sucks the volume from the left ventricle in the aorta, irrespective of the LV function. It increases end organ perfusion and protects kidneys from acute injury. This is Impala RP for RV failure. It can give you up to 4 liters of volume. Basically, it inlet is in the inferior vena cava, goes across the right ventricle into the pulmonary artery. It can be used, actually, you can use both Impala RV or Impala LV in a biventricular failure, even for many days and weeks. For these sick ventricles, they need healing process, I call it. Now, when you use an ECMO, we know the ECMO, they canalize in the right atrium and in the common femoral. It can augment cardiac output up to 4.5 liters per minute. It can be used to support the circulation up to several weeks, and it does not require a stable rhythm for optimal function. This is an example of a patient where I had to use an ECMO as a 60-year-old woman with a STEMI coming to cath lab. On the way to cath lab, she arrested. We're doing CPR on her. She was immediately put on ECMO. This is the cannula in the right atrium. And of course, with ECMO, she was hemodynamically stable. We did angiography from the contralateral groin axis, and interestingly, a clean left coronary system. What she had a occluded right coronary artery, which was intervened, and this is very preserved LV function post intervention. In fact, patient was taken off ECMO in the cath lab and was discharged 3 days later. This is another case example of a patient, 64-year-old woman with severe aortic stenosis, 3-vessel coronary disease, severe left ventricular dysfunction with the ejection fraction of 20%, presents with non-STEMI and heart failure, was initially recommended to go surgery because of the high-risk nature, was referred to me for a supported intervention. This is her baseline echo. You can see here severe LV dysfunction, ejection fraction appears about 20%, and has a critical aortic stenosis with a mean gradient of 53, value value of 0.9. So you can see she has multiple 3-vessel disease, right LAD and SIRC. So as I said, she was very unstable. She was taken to the cath lab. Blood pressure at that time with minimal inotropic support was 90 or 50, heart rate 120, but alert and awake with evidence of heart failure. So this is the wire on which we put the Impala. So what we did is we landed the Impala tip just above the aortic valve. She had the balloon valvoplasty for her aortic stenosis. Post valve, she became hypotensive, but the Impala was there. It was started with immediate marked improvement on Impala, blood pressure to 120 or 70. You can see she's in sinus rhythm, and she's hemodynamically stable. After a balloon valvoplasty for her aortic stenosis, she underwent 3-vessel intervention, first to the right coronary artery, next to the mid-LAD, and as well as to their submarginal PCI was done. So she had balloon valvoplasty, 3-vessel intervention. She was discharged actually 3 days later with an echo ejection fraction of about 35%. Now, since she has aortic stenosis, we did just the BAV. She returned later, 2 months later, for elective TAVR or TAVI using SAPIEN 3 valve here. And this is post-valve replacement, excellent results with no aortic regurgitation. And look at here, 1 month post-TAVR, marked improvement in her ejection fraction, about 45 to 50%. And you can see the same patient before. Here is on the left side, very severe LV dysfunction. This is following balloon valvoplasty, 3-vessel coronary intervention on Impala, and then TAVR. And you can see marked improvement in the ejection fraction. Now I'm going to show you another case which was done recently. I call this aborted surgical rescue. This patient presented first with STEMI, inferior STEMI with stable hemodynamics. He was taking the cath lab, inferior STEMI, had an occluded RCA, but critical left main and 3-vessel disease. So since she has still ST signaling elevation, the operator did the PTCA to the RCA and then referred to surgery with stable hemodynamics for urgent CABG. But as you'll see in a minute, she was referred back from surgery for an intervention as patient sustained a cardiac arrest after sternotomy, had open cardiac massage, was put on central ECMO. And you can see here, this is the initial film, initial angiogram when he had inferior STEMI, occluded RCA. And you can see very tight left main lesion with the critical LAD and diffuse disease LAD. Circ looks again very diffuse disease, but a tight left main in this view. And so, as I said earlier, she was having ST elevation. She had just the plain PTCA of the RCA, and a balloon pump was put in before she went to surgery. Before he went to surgery, you can see here in the OR, they did a TEE at the time of surgery, severe LV dysfunction, barely 10 to 15% ejection fraction. Now, as I said earlier, the chest was open. She had cardiac arrest, and you can see here he was put on central ECMO. This is the venous cannula. This is arterial cannula. You can see here barely minimal motion of the heart. So naturally, with cardiac arrest on central ECMO, severely depressed LV, she was returned back to cath lab for intervention. This is basically surgery was aborted and was referred back to cath lab. This is the OR patient with getting ready to go down to cath lab. And this is patient back in the cath lab from OR, getting ready for intervention, remaining on central ECMO, as well as previously placed IABP, which was put in before this patient went to surgery. So you can see here a lot of surgical equipment. I first want to check the right coronary artery. This had totally occluded, but remember, this patient had cardiac arrest in the OR. So anyway, the first thing what we did was we opened the RCA, put a stent in the RCA, very nice results. Some collaterals with the diffuse disease circumflex. Next, attention to the left main. You can see very tight left main, arterial LAD, and diffusely diseased LAD. I don't know how they could have been able to bypass this LAD. Anyway, we did the intervention to the left main LAD and all the way down to the apex, and we got very excellent results of the LAD. Circ was small, we left it alone. And since patients on ECMO, they can get LV dilatation, you need to unload the ventricle. So Impala CP was put from the contralateral femoral access, Impala here, after intervention to left main and RCA. You can see here, this is basically patient is back in the ICU. What was done is patient went back to OR, the chest was closed, central ECMO was closed, and peripheral ECMO was started, and we continued the Impala. This is the Impala device. So basically, we want to give rest, a real rest to the heart, let it recover. So you can see the EKG post complex intervention while still on ECMO and Impala support. Really no ST elevation now. And you can see a remarkable improvement in the LV. This is after being on ECMO and Impala for 10 days, marked recovery of the ventricle. Now I'm going to show you the next case using Impala as a bailout. There's a patient who's 75 with the left main and three vessel disease, but normal LV function and normal right, who had severe COPD, so he was sent for multi-vessel intervention left main. So this is his cath films from other hospital. You can see here small right coronary artery, but non-obstructive disease, has tight distal left main, ostial LAD, ostial circ, as well as circ OM bifurcation here, and an LAD lesion here in the mid LAD lesion here. Mid LAD lesion here. So since we are doing a complex PCI, we did not put any hemodynamic support. We just put a 5 French introducer sheath in the left common femoral just in case. Well, patient was undertaken for PCI. You can see here same angiogram, no change. Distal left main, proximal LAD, mid LAD. And the circ OM bifurcation. So first we did the circ OM bifurcation here. You can see we got very nice results, provisional. And then while we are planning now to the left main, you can see some haziness in the left main area. Patients start having chest pain, shortness of breath, cannot breathe, marked ST7 depression on monitor leads, with a drop in blood pressure to 70 or 50. Now, at this time, you want to stop doing an intervention, but do not lose the access of the LAD and circ. So we went from the contralateral groin. We already had a 5 French introducer sheath, and we put an Impala device from the left side. It may be interesting to note that this patient's LVDP was 40 millimeters of mercury. Patient, once we put the Impala in, he's stable like a rock with a marked improvement in the blood pressure, pain-free, with no ST segment changes. Now, patient stable, and we proceeded doing distal left main, ostial LAD, ostial circumflex, and the kissing balloon at the end. With IVUS, I think the area was over 11 millimeters square, which is great in left main stenting. And you can see post PCI excellent results of the left main bifurcation, LAD, and the circ OM bifurcation. Again, this is a pre-picture showing distal left main, proximal LAD, circ OM bifurcation, and post looks excellent. All 4 areas was intervened, and complete revascularization was achieved. And it's a follow-up angiogram. This case was done about 9 years ago. We don't do any more follow-up angiograms. This was done. So I'm going to quickly share with you the PROTECT 2 trial, which was a randomized trial between the intra-aortic balloon pump and Impala in patients with unprotected left main, or the only patent vessel with an ejection fraction of 35% lower, or 3 vessel disease with an EF of less than 30%. You can see here the primary endpoint was the MACE at discharge in 30 days. You can see at 90 days, there's a marked reduction in the MACE in patients with Impala supported intervention versus balloon IABP supported intervention. It was interesting to note in the PROTECT 2 trial, Impella reduced MACE with more complete revascularization. You can see here, if you did one vessel intervention in a 3-vessel disease, there was not much difference between IABP and Impella. But if you did a complex 2 or 3-vessel disease with Impella supported intervention, there was more complete revascularization, and there was much lower MACE, 44% reduction in MACE with Impella supported coronary intervention. Also, you can look here, death, stroke, and repeat revascularization was also lower with Impella supported intervention. I think part of the reason is when patients stable on Impella with stable hemodynamics, the operator is less anxious, and you can do a better job and better revascularization and more complete revascularization because the patient is stable. We also found in the PROTECT 3 trial, which was 469 patients, again showing the same results, that when you use Impella supported intervention, there's less MACE at 90 days. That was the primary endpoint. Now, what was also interesting that, as I said earlier, when you use Impella, it increased the cardiac output, increased the peripheral perfusion, and there was less kidney injury in patients on Impella than on balloon pump. So I'd like to conclude that in selective high-risk patients undergoing complex interventional procedures, additional support techniques or additional support therapies like ECMO and Impella devices appear to improve the outcome. It also, I like to also conclude that in patients with severe hemodynamic compromise, I mean when patient requires chest compression or are in severe failure with unstable rhythm, ECMO appears to give you the best support. Current data, as I showed you from the PROTECT 2 and 3 trial, it supports the use of a left ventricular assist device like Impella during high-risk coronary intervention. Also, patients with stable hemodynamics on Impella will likely receive complete revascularization, thus better long-term outcome. I may want also end this talk by saying that combination therapies that can be used for weeks, like ECMO and LV Impella for unloading, as well as Impella RP for right ventricular failure, are emerging therapies for very severely compromised LV and RV failures, where survival in the past has been very poor. Thank you very much for your kind attention. Again, thank you, Dr. Mittal, for your kind invitation.
Such great outcomes. So congratulations from our side for the showing such cases. And now we are coming to our next topic, which is the conventional and concurrent therapy for heart failure, changing paradigms. As we know that in the last 5-6 years, there available have two new molecules, particularly ARNI and SGLT2 inhibitors, has remarkably changed the outcome of the heart failure patient. And to cover all these things, we have Dr. Hani Sabur, who is a basically international famed cardiologist. Currently, he is the staff physician at Heart and Vascular Institute, Cleveland Clinic, Abu Dhabi. He is prolific orator, and I have privileged to share with many meetings with him, and it is nice to hear him. So I kindly invite Dr. Hani Sabur for his topic.
Hello, my name is Ali Sabor. It's my pleasure to be part of the Shakeheart conference and present to you heart failure in 2021, conventional and concurrent therapies. Never too early and never stable. The purpose of this talk is to discuss overcoming lethal clinical inertia in heart failure, given that there is no such thing as a stable heart failure meeting. These are my disclosures relevant to this presentation. Heart failure with reduced ejection fraction is a progressive disorder whereby cardiac structure and function deteriorate over time. The silent yet progressive nature of HFrEF contributes to the increased risk of death. Hippocrates described this thousands of years ago, where the flesh is consumed and becomes water, the abdomen fills with water, the feet and legs swell, shoulders, clavicles, and chest and thighs melt away. As you see on the right-sided figure, there is massive volume overload. However, this belies an error in how we often manage these patients. The water tank hypothesis, or the myth of diuretics in treating heart failure, is a frequently done error in the management of heart failure patients. In fact, diuretics and fluid management does not uniquely save lives. The heart failure patient is not merely a water tank, and the treatment of heart failure with reduced ejection fraction is not about fluid management nor about diuretics. Coming back to this point, the heart failure patient is not a passive water tank that you drain on and off using diuretics only. It is about guideline-directed medical therapy. In fact, it's very well recognized that the chronic NYHA functional class 2 who has mild symptoms actually has a worse prognosis. In the Paradigm study, those patients on enalapril, 45% died due to sudden death, even though they had minimal signs or symptoms of congestion. And coming to the entry point into this algorithm that was very nicely described in the recently updated guidelines, it's very important to realize that an acute decompensation of heart failure implies the risk of not only rehospitalization, whereby 20% of patients will be readmitted within 30 days, but up to 50% of the patients will be readmitted within 6 months. So entry into the hospital is a very important part of the diagnostic algorithm. Most importantly, though, is that the mortality after discharge has not improved in the past decade. 36% of patients in the ADHERE registry die within 1 year, and 29% of the patients in the National UK Heart Failure Registry also die within 1 year. Why is that? When they are admitted to the hospital, they are under our care, we have guideline medical therapy, and we have guidelines. The natural history of acute and chronic heart failure is progressive. With the acute event and the initial myocardial injury, the first decompensated heart failure and later decompensated heart failure episodes lead to a direct reduction of myocardial function, progression, and death over time. So it is important to start as early as possible and aggressively as possible with guideline-directed medical therapy. We also do not have a shortage of evidence-based medicine. And here is a summary of all of the clinical trials that have been positive in the treatment of heart failure with reduced ejection fraction up to 2019, and of course beyond that. So we start with the utilization of ARBs, beta blockers, and the addition of ivabradine, as well as eplerenone. Of course, we have the landmark Paradigm study, and very recently we have the use of SGLT2 inhibitors, which are DAPA-HF, and more recently the Emperor-reduced heart failure study. In addition, we have device therapies and CRT, which have also contributed significantly to the survival and reduction of mortality morbidity in the heart failure patients. In fact, if you look at the optimal implementation of evidence-based therapies using ACE inhibitors or ARBs, beta blockers, aldosterone antagonists, CRT and ICD, and then consider an additional benefit of adding ARNI to replace ACEs and ARBs, we have a potential impact of 70,000 lives saved per year with conventional guideline-directed medical therapy, and an additional 30,000 or 28,484 to be more precise, potential lives saved per year significantly out of the entire US heart failure population by following conventional guideline medical therapy and then the addition of ARNI. Now, I borrowed this slide from Professor John McMurray, who's one of our leading lights in heart failure cardiology. If you look at the baseline therapies in heart failure, the conventional therapies, as it were, ACEs and ARBs, were proven from Consensus, SOLVE, and CHARM. You have beta blockers, which is CBIS2, Merit Heart Failure, and Copernicus, specific beta blockers, and MRAs, which is RAL's emphasis, and the use of MRAs therefore became standard. Additional therapies were identified in more recent clinical studies. SHIFT study identified the use of ivabradine, Paradigm-HF, which is now more than 5 years old, and SGLT2 inhibitors such as DAPA-HF and Emperor-reduced, added onto or substituting ACEs and ARBs in the evidence for neprilysin inhibition. So this leads us to the new 5 pillars of HFrEF therapy in 2020 and beyond. So ACEs and ARBs substituted with neprilysin inhibition, so ARNI, which includes an ARB, as well as beta blocker, MRA, and SGLT2 inhibitors. And initially this was SGLT2 inhibitors in diabetics, and now it's in all patients with heart failure. Leads to a substantial reduction of mortality and morbidity in patients with heart failure-induced ejection fraction. In terms of actual incremental clinical outcome, and you'll see here, starting from the SHIFT study, where the majority of patients were ACEs and ARBs, beta blocker, and MRA, an additional 10% reduction of all-cause mortality and a 25% reduction of heart failure hospitalization. In the paradigm study, 100% of patients were on high-dose enalapril, beta blockers 93%, and MRA, an additional 20% reduction of cardiovascular death and all-cause mortality. DAPA-HF, which added dapagliflozin to ACE, ARB, and ARNI with beta blocker and MRA, an additional 17% reduction of all-cause mortality and a 30% reduction of heart failure hospitalization. So we're talking about increments on top of conventional therapy on the right side here. This has led to the current, very recent update from the ACC for the decision and consensus pathway for optimal heart failure treatment. This was very recently published and takes a very practical and also evidence-based approach to the best medical therapies in the heart failure patient. And of course, these are heart failure patients who have manifested with reduced ejection fraction and have symptoms. And the starting point, the baseline, there's no discussion about this one, is that we have to use RAS blockers with ARNI preferred and evidence-based beta blocker, which includes carvedilol, metoprolol, and bisoprolol, in addition to diuretic as needed. Now, if the patients have a consistently elevated heart rate during sinus rhythm on maximum beta blocker, addition of ivabradine is recommended. In patients who have a GFR above 30 and a potassium below 5, an MRA is added, like aldosterone or Pleronol. In patients who have, again, GFR criteria above 45, on top of ARNI, beta blocker, and diuretic, in parallel to aldosterone antagonist, SGLT2 inhibitors are added. And in patients who are African or African American, in spite of beta blocker, ARNI, aldosterone antagonist, and SGLT2, add hydralazine and isosorbate dinitrate. Finally, diuretics are adjusted for persistent volume overload. They are not going to impact mortality and morbidity. And in the discussion and the text, it's clear that ACEs and ARBs should only be used in patients with contraindications for some reason, intolerance of ARNI for some reason, or very clear access issue like financial issues. Because it's clear that over the last 6 years, many studies have shown the superiority of ARNI above ACE and ARB therapy. And this was specifically described, this is what was described in the text, as a direct approach to ARNI, initiation of ARNI de novo without prior exposure to ACE or ARNI from the Pioneer heart failure study. And because of that evidence, direct to ARNI approach is now recommended. And also, when recommending to initiate an ARNI, either as a switch or de novo treatment, to follow the patients for titration and possible side effects. Now, ARNI has a specific, unique advantage in that it targets the RAS system. By containing valsartan, it blocks the angiotensin II and therefore decreases fibrosis, sympathetic tone, aldosterone, and hypertrophy. In addition, by blocking natriuretic peptide breakdown, there's more natriuretic peptide to be naturally available, so we get more vasodilatation, less vasopressin, less aldosterone, less fibrosis, and also additional diuresis, and also reduces the counteractivation of the sympathetic nervous system. So it also acts in many different pathways. From the paradigm study, this is sort of a global summary of the paradigm study and the use of valsartan sacubitril over enalapril. There was a 20% reduction, 4.7% absolute, the number needed to treat of 21, reducing the risk of death or hospitalization, reducing by 20% the risk of sudden death, 16% of all-cause mortality, 23% fewer heart failure admissions, and 18% fewer ICU stays. Significant reduction if sudden death occurs early and is consistent over the course of the study, 20% compared to high-dose enalapril. In addition, the reduction of heart failure hospitalization was seen even after 30 days. Look here, this is 30 days after randomization, by almost 40%. So the effect is profound, robust, and early in terms of hospitalization. So the additional benefit, of course, is not compared to placebo because the entire study was on high-dose enalapril. So adding 18% to the 20% from ARNI leads to a very robust 38% reduction in mortality. Of course, we don't have placebo in heart failure studies anymore. In terms of quality of life, all of the quality of life parameters were significantly reduced from a patient standpoint. Physical limitation, social limitation, symptom score, and symptom burden were reduced as well across the entire time of the study and in every single age group. Now, more recent data from the Evaluate and Prove clinical trials showed a significant reduction of the volume of the myocardium, in other words, reverse remodeling, and systolic and diastolic and left atrial volume index compared to high-dose enalapril. And from the Prove study, the majority of patients had an improvement of ejection fraction. The median increase of the ejection fraction was 9.4% by 12 months, and at least a quarter of the patients had a 13% increase of ejection fraction at 12 months. In addition, the volume indices were also significantly reduced, as you can imagine. This effect was very robust with the Entresto patients, including patients who were ACE and ARB naive and de novo. So those patients who were de novo had an ejection fraction improvement of 12.8% points over the course of the study. And this was seen even in the patients not reaching the target dose and patients who were not as sick with a lower NT-proBNP. The treatment-naive patients, however, had the greatest benefit, but all of the group had a significant improvement of their ejection fraction across the study. In the hospital setting, and this is the most important, early initiation of the guideline-directed medical therapy with ARNI was seen and studied and published in the Pioneer study. And here we see a tremendous reduction of the NT-proBNP by almost 50%, starting within 1 week and up to 8 weeks compared to the placebo arm here. And the risk of CV death or rehospitalization was reduced by almost a half, and it initially starts within 2 weeks and continues up to 8 weeks. So it has a direct impact when you start the ARNI early and not late. Compared to ACE inhibitor, irrespective of prior heart failure history, the valsartan sacubitril produced a 73% reduction of NT-proBNP from baseline, and in the patients with worsening chronic heart failure, an additional from 20%, an additional 40% reduction of the heart failure NT-proBNP from baseline. So whether it's early or late, whether it's de novo or switching, I think it's very important to realize that this is a very potent reduction of NT-proBNP. And again, in the Pioneer study, and we've sort of seen this, in patients who were treatment naive, who were initiated at the time of hospital discharge, the reduction of the clinical endpoint was reduced by about 20%, again, starting very early and continuing late. And in patients who were on ACE and ARB compared to enalapril, again, there's a significant difference, but it takes a little bit longer to show its effect. The original paradigm study proved this point, that you need to have comprehensive RAS blockade with the addition of neprilysin inhibition in order to reduce death from any cause or heart failure hospitalization. The Pioneer study was driven by an inpatient workflow where the patients were enrolled at the time of either hospitalization and up to 10 days after initial presentation, but within the hospital setting. So this is an in-hospital initiation of therapy. In terms of safety, worsening renal outcome, hyperkalemia, hypotension, and angioedema was no different than initiation of enalapril. So very safe and effective in terms of the safety. But as we saw, there is a 40% reduction of heart failure rehospitalization within a month of treatment and going out to 56 weeks. and CV death or rehospitalization, again, within a month, 28 days, and continuing for the entire 56 weeks of therapy. So initiating RNA in the hospital is something that is now incorporated in the guidelines due to evidence-based medicine from Pioneer as well as the older transition study, safe and effective, and monitoring is more efficient in the hospital setting anyway, where you monitor the patient's blood pressure, caution when the blood pressure is less than 100, switching fairly early in the course of hospitalization before the patient becomes hypotensive, before you have over-diuresed them, and before the patient is completely dry. If the patient is on an ACE inhibitor for decompensated heart failure and you're going to switch them, you need a 36-hour washout. Recommendation is switch to the ACE to an ARB such as valsartan as a bridge, and then sacubitril valsartan at the time of discharge. Discharge is a very important and has to be a structured process. It's not, thank you, here's your prescriptions, go home. The effect of nurse-driven outpatient clinics, or even heart failure clinics in general, which can be generalized, is the likelihood of heart failure readmission is significantly reduced if the patient has a specific driven point of care within 5 to 14 days, preferably 7 days after discharge, to be seen in a heart failure outpatient clinic. And this is the effect on rehospitalization reduction in patients who are directed to the outpatient clinic within that time frame. It's significantly different. And the early readmission process is needed and has to be under discharge planning. This is as soon as the patient is stabilized. During the admission, we're also giving the patient information and education for self-care and outcome in terms of medication and diuresis and whatnot. In addition, those patients can have an early physician follow-up discharge showing a 30-day reduction in readmission. So, do we have a plan for heart failure medication titration? Has a specific appointment been scheduled and telling the patient the importance of this? Has there been communication to the outpatient clinic? And is there follow-up planning for a defibrillator or device as needed? So as we wrap this up, there is no such thing as a patient with truly stable heart failure, as most of them will die suddenly, even in the absence of congestive symptoms. HFrEF patients are often considered clinically stable on maximum treatment, no physical signs and symptoms suggestive of worsening cardiac function, but still, sudden death is a possibility without guideline-directed medical therapy. Heart failure is a progressive disorder, and the ongoing cardiac, structural, and functional deterioration can be seen in patients who are either asymptomatic or mildly symptomatic. So it is our responsibility as physicians to use concurrent, multimodality, guideline-directed medical therapy at maximum doses, including the 5 agents that we mentioned previously, including valsartan, sacubitril, preferably over ACEs and ARBs, beta blockers at maximum tolerated dose, SGLT2 inhibitors, MRAs, diuretics, and devices as a means to reduce mortality and morbidity in our heart failure patients with reduced ejection fraction. And thank you for your time and your attention.
Dr. Rajesh, unmute yourself. Dr. Rajesh, can you unmute?
Yeah, it is unmuted now.
Yeah.
Can you hear me?
No. Yes, please.
I'd like to thank Dr. Hani Sabur for the excellent talk. And our next presentation is on non-surgical valve therapies in 2021, which will be Dr. Praveen Chandra, who is a renowned cardiologist and chairman of interventional cardiology at Medanta, Gurugram in India. He has a lot of experience in TAVI procedures. I'll hand over to Dr. Praveen Chandra for the non-surgical therapy 2020.
Hello, this is a wonderful moment that I'm sharing my thoughts on the new horizons of cardiology, and that is on the structural heart therapies, which I'm considering as one of the new changes which has happened in the field of cardiology. So what are these new changes? The new changes are TAVR, TMVR, LAW, MitraClip, TTVR, PVL closure, etc. So these are some of the new terminologies which many of you may be aware of, some of you may not be. So let me just take you through this small presentation, because as interventional cardiologist, as you already know, we have started from heart, and then we move to the carotid artery interventions, the renal artery interventions, the leg peripheral arterial interventions, and so on and so forth. But all these were so effective in a way that it practically replaced the surgical treatment of these occluded arteries everywhere in the body, be it the bypass surgery or the carotid endarterectomy or peripheral vascular surgeries. Everywhere, the treatment of intervention has really made a big dent, actually, in the in the relief which it comes to the patient by these interventions. So moving from the success of coronary and peripheral arterial interventions, now cardiology has moved even further deeper into the heart valves. In fact, we were treating the heart valves by balloon mitral valvuloplasties for many, many years, but we were not doing anything further than that. However, now I am going to share with you that now we can replace the valves, the heart valves, by interventional therapies. And these are known as transcatheter valve replacement or valve interventions. So for the aortic valve, for the mitral valve, for the pulmonary valve, and for the tricuspid valve, all these valves now we can treat. And as you will see here, that for the mitral valve, we do MitraClip, mitral annular ring as a repair technology. And for replacement of these valves, we can do mitral valve in valve replacements. In those patients where the valve has already been done surgically, where the second valve does not need to undergo a redo valve surgery, here we can do a transcatheter valve replacement. And now we are also embarking on the native valve replacement for the mitral valves. So the mitral valve is typically covered in both ways for mitral regurgitation and mitral stenosis patients. For aortic valve, for aortic stenosis patients especially, the aortic valve can now be replaced through a new procedure known as TAVR, as you are seeing here. And for those patients who have already received a valve through surgery, especially the bioprosthetic heart valves, if these valves start failing by the end of 10 years, 12 years or so, now we can do this transcatheter valve and valve procedures without doing a redo valve surgery, which is very high risk. Then third, moving to the tricuspid valve, we can do a bicable valve. Tricuspid bicable valve is available, and also a tricuspid clip, which can be done to these patients for tricuspid regurgitation. For pulmonary valves, the percutaneous pulmonary valve replacements are now available, especially for the congenital heart patients, where there is free PR, where previous surgery has already been done, we can replace these valves. The paravalvular leak closures, which is those patients where a mitral or aortic valve has been replaced already. In these patients, when they start leaking after a while, after these surgeries, then now we can do a second transcatheter procedure and avoid a second redo surgery in these patients. The last thing which I'm going to share with you is the LA appendage closure, which is a new technique of closing the LA appendage without doing any surgery. And these procedures are known as Washman or amulet procedures, again done through transcatheter techniques for prevention of stroke in atrial fibrillation. So this is the entire spectrum of structural heart therapies, and I'm glad that we are now able to do all these procedures quite regularly in our centers in India, and it is helping many, many patients. So let me first take you to the aortic stenosis. And as you already know, that aortic stenosis is a fairly common problem. And we have started, once we started looking for these patients or these disease, we find more and more of these patients. So here what happens is the aortic valve becomes calcified over a period of time, fibrosed, and becomes almost immobile, as you can see here, compared to a normal aortic valve. And with this, the narrowing of the opening of the valve becomes very constricted, and that leads to various symptoms of angina, heart failure, and syncope. So in these patients, the standard treatment up till now was surgical aortic valve replacement, be it a mechanical valve or a tissue valve. But all these had their own problems. One, of course, is open heart surgery, and the second is their valves had to be, having their own specified, lifespan, especially for the tissue valve, it is about 10 to 12 years, and then the patient had to go under second surgery. And then for the mechanical valves, lifelong anticoagulation. So that is one of the problems. And that is why we also call that aortic stenosis is one of the worst prognosis among the heart disease patients, worse than even metastatic cancers. Because if severe aortic stenosis, you can see severe inoperable aortic stenosis, the survival is minimum compared to brain cancer, lung cancer, breast cancer, or ovarian cancer, which means we need to treat. And that is now being reflected in the slide which you are seeing here, that the treatment trends are changing. Around the world, in Germany, in United States, everywhere, the number of TAVR procedures have already superseded the number of surgical aortic valve replacements. So you can imagine how fast this technology is growing, and you can see that a large number of studies have been done already for proving that this therapy does good or not good. So the first trial was done in the patients who were absolutely high risk patients where surgery was not an option, where TAVR was found to be superior to medical therapy in patients with severe aortic stenosis. And that was the starting point. This was done with the two valve types of valves, the balloon expandable valve, which is the sapien valve, and the self-expanding valve, which is the core valve. These are the two types of valves which were studied. Then it was further studied in high surgical risk patients where surgery could be done, but with some high risk. And here also it showed that TAVR was as good as surgery in these high surgical risk patients. So when we got such good results from high risk patients, we moved on to intermediate surgical risk patients, where again it was shown to be effective, as good as surgery. And then, of course, many patients were studied in low risk patients, low surgical risk patients, even younger patients. And over the years, we have seen from various registries and now with the studies which have been published that this therapy is effective even in low risk patients and has been approved in Europe and United States and is being used worldwide for this indication. So what are the complications of this treatment, TAVR procedure, compared to SAVR? Here you can see that the chance of having a paravalvular leak may be slightly higher with TAVI, but now it has come down dramatically with the improvement in technique and experience, whereas the incidence of pacemaker implantation is also slightly higher with compared to SAVR, but has no effect on the survival of the patient. But the most interesting thing has been found out is that over a period of 3, 5, and 10 years follow-up, the gradient across the valve remains very constant, which means that this valve is a very durable valve. It works very well over a long period of time, and it is even better than surgical valves in many such situations, where because the mean gradient remains very low across the valve over a period of time. So basically, we have two types of valves. One is the self-expanding valve, which is this one, and the second is a balloon expandable valve. Both these valves are effective in all these studies, which I've already shown you, compared to surgical valve replacement. So it was approved in 2016 in US and Europe, and now it is available worldwide. And these are the types of new generation of valves which are being studied now and are going to be available very soon. But certainly, a lot of this is already, happening now, and many countries worldwide have already adopted this technology. The future of this technology is such that probably in aortic regurgitation patients, in very young patients also, probably it will be used. But the trials are going on with very low risk and young patients where the study is going on. So in the end, I must say that TAVR has already, I think it is already established procedure, and it is a very well documented procedure where it can be done in patients with severe aortic stenosis. So how it is done? Basically, the main key is that we have to do imaging, and imaging is done first by echocardiography. On echo, we diagnose whether this patient has severe AS or not, and then we do CT angio, CT aortogram, to find out what will be our access, how will we do this procedure, what will be the size of the valve. Everything is decided on the CT scanning. So basically, in these patients, this is how we do this procedure. As you will see here, this is the animation where a puncture is made into the femoral artery, and through this femoral artery we put a sheath, and through this sheath we take the valve inside eventually, which goes inside the heart across the, this is the valve which is mounted on a catheter, and this catheter actually goes into the heart through the femoral arteries, or sometimes now even we do from the carotid arteries or the subclavian arteries. So that is how this procedure is performed. It is fairly simple now. No anesthesia is given during the procedure generally, and it is a local anesthesia only, which is given at the puncture site, and we close it off with a perproglide technique where there is nothing to be seen, no cut, nothing, no stitch, and this is the kind of small hole which we see percutaneously, which is done. So then the patients are generally shifted to the wards in day one if everything is okay, and then they are discharged in about mean discharge is about 4 to 5 days time. So this is the best part of this whole thing, that the morbidity with this procedure is very, very low. And hence, today I can say that it has been approved, and low surgical risk patients, intermediate surgical risk patients, high surgical risk patients, and prohibitive surgical risk patients suffering from symptomatic severe aortic stenosis. So this is the latest recommendations, and these are the the summary of the trials which have been done in these subgroup of patients. So the procedure is very good. The only drawback of this procedure is it is a costly procedure. Generally, it costs about 25 lakh rupees for a particular patient, but now with the Indian valves, it has become a little cheaper, and we have, it is almost half the cost of the valves which are imported valves. So, and these valves have also been studied quite extensively, the Hydra and the My valve. These are the two types of valves which are being produced in India and are working quite well. Here you can see that in one of the patients, this is the Indian valve which is being deployed in this patient with severe aortic stenosis, and the patient is conscious. He is being, treated by this procedure, and he will be discharged in 2 to 3 days time. You can see there is no leakage, nothing, and the patient is doing fine well. And the clinical follow-up at 1 month, 6 months, all shows that the gradients are very constant, no increase in gradients, no leakage, nothing. So it is a effective procedures. We have done now more than 250 procedures, and the success rate has been quite high. And our follow-up has been maximum up to 8 years in my own series, but worldwide the follow-up has gone up to 15 years now, with symptomatic improvement in breathlessness from NYHA class 3 to 4 to NYHA class 1, marked improvement in quality of life, no cardiovascular mortality in our series, and no valvular or paravalvular leakage were seen. These are the kind of patients which we treat. You can see 80 years, 89 years, 90 years, 70 years, sometimes even younger patients, as you can see, 50-year-old patient who has been treated with percutaneous valve replacement. So these are our follow-up of these patients who in various shapes and sizes were looking very good. And so I must say that TAVR has become a standard of care after the early learning phases. Now a decade later, it has become as one of the powerful therapies in patients with severe aortic stenosis. So that was all about aortic valve disease. Now a little bit about the mitral valve. The mitral valve is also replaced, and especially I'm showing you one of the cases which we did many years ago on a patient who already had a mitral valve which was malfunctioning now, which was known as bioprosthetic heart valve dysfunction, and the valve was degenerated. In this patient, the second surgery was very high risk, so we did a valve and valve procedure. You can see very well a valve is being implanted into a previously surgically operated valve. And soon after that, the patient was discharged in just 1 to, I think it was 1 day only, because it is a very simple, nice procedure. And this is a elderly female who was treated with this percutaneous valve technique. Then moving on to the alternative for oral anticoagulation for reduction of stroke in atrial fibrillation, one of the very effective procedures have been left atrial appendage closure. And in here, what we do is we try to close this aortic left atrial appendage, because this clot can move out and go into the brain. So that is why we have to prevent this clot. Otherwise, if it goes into the brain, it will lead to a definite stroke. So the way to treat is to give them anticoagulation. But the problem is every patient will not tolerate anticoagulation. Every patient would not like to take anticoagulation, and every patient may not have no bleeding complications with anticoagulation. So in these patients, we put this device, which is known as the Watchman device. You can see here, there is another device which is known as a amulet device, which is also used. And here you can see that we are doing a left atrial appendage occlusion with Watchman device in a patient who already had a TAVR. So 1 week back, we did a TAVR, and then we are doing this because she was not tolerating anticoagulation earlier. She came with bleeding, so we are doing this procedure, and after that, she was discharged and she is doing fine. For mitral regurgitation, now just to give you a snapshot, we are doing this mitral clip procedure, which is very effective, and again, percutaneous in nature. So this is the mitral clip procedure, which is done through a transfemoral venous route. And in this patient, already we had given a biventricular pacemaker. We had given all the kind of therapies, but still the valve was leaking. So here you can see that the clip is being positioned, and this clip is positioned across the mitral valve, leaking valve, and then closed. For tricuspid valves, we have another therapy known as tricuspid bicable valve implantation, trick valve. And here what we do is we put, and this is one of our patients where we did a lot of things for this patient. This patient was having severe tricuspid regurgitation, which was increasing. In the 7 years of follow-up, we found that it came from mild to severe. And here what we do is we put a valve in the SVC and we put a valve in the IVC. So what it does is that the TR which is happening does not get transmitted to the liver or into the brain, and hence the symptoms improve. This is the patient who received a tricuspid valve without any surgery. As you can see here, he had earlier surgery for the mitral valve, which was already doing fine. So all this is possible by a heart valve center, by a heart team approach, where the cardiac surgeon, the cardiologist, and anesthesia and a clinical cardiology team all is on site to take care of these patients, and that is a class 1 way of attending to this intervention in these patients. So finally, my dear friends, in our institute, the Medanta Institute of Structural Heart Disease and Valve Therapies, we have now been able to do quite a reasonable number of TAVI procedures, TMVR procedures, LAO procedures, PVL closures, and MitraClip for these patients of aortic, mitral, and tricuspid valve disease. Thank you very much.
So thanks, Dr. Praveen sir, for the excellent talk, giving you the all details about the structural heart disease going on the Vedanta, including TAVI and mitral valve replacement and obviously lateral occlusion and all the things. And just to proceed for the this discussion session, there is only one question, and I think this is directed to Dr. Hani. That what are the recommendations to stop heart failure therapy after complete recovery of ejection fraction? I think the question is that if someone is having dilated cardiomyopathy or something like that, and he is on the standard therapy, and if he recovered fully, then what is the guideline suggestion that whether we have to continue therapy, hernia, and these things, or we have to stop? There is any uh, suggestion for that?
Yes, thank you very much. This is a very interesting question. It comes up a lot in these meetings, and actually there is an evidence-based to answer this question rather than just the consensus opinion. So this phenomenon of recovery is very rare. Complete recovery or reversal of LV remodeling to normal is seen essentially in postpartum cardiomyopathy, and also in patients who are maybe post-viral, early post-viral myocarditis.
Yeah.
So in that situation, it's generally not a cardiomyopathy in the true sense, right? This is a temporary situation which recovers. Most patients who have LV dysfunction, as we saw from the various studies, improve their ejection fraction. Some of them normalize, but this is quite unusual in the true sense of recovery. And there have been lots of registries that look at true recovery. Now, Javed Butler actually presented this data in 2018 at the ESC meeting. In patients who recovered, there's a cohort of patients who recovered and they either had down titration of their beta blocker or down titration of their ACE, ARB, and ARNI. So, in fact, the risk of heart failure hospitalization and reversal again of reduction of ejection fraction was almost 67, 68% in patients where the beta blockers were stopped or down titrated. So I think this kind of approach is somewhat frowned upon by the guidelines, and individual patients should be monitored very closely. I personally don't do this unless there is a very clear reversible cause. So, for example, a patient with tachycardia-induced cardiomyopathy, LV dysfunction, AFib ablation is done. After a year of therapy, we repeat the imaging, no AFib. This is basically a reversible cause of cardiomyopathy. I generally keep patients with their ejection fraction reaches 50%. I keep them on the triple or quadruple guideline-directed medical therapy, and then we reassess. If there's a compelling reason to stop the medications, for example, side effects or so on, that's reasonable. But just simply saying the patient has recovered, I'm going to stop the medication, unless there's a clearly identifying precipitated cause like AFib, pregnancy, or some sort of inflammation is gone, I would not do that.
Yeah, I think we agreed that majority of these patients who fully recover either have some, you can say, precipitating factor, either hypertensive heart failure or post-viral myocarditis, or sometimes, as you told, postpartum myocarditis. Then the ball game is different. Otherwise, they require indefinite therapy. Only thing what we have observed that, yeah, some patients we have planned for ICD, but after ARNI therapy of 6 months or this thing, we have seen remarkable improvement in the EF touching like 40% from starting 24, 25%. Then we defer the ICD therapy. But ARNI and this thing we are continuing for that.
It's an outstanding comment. So, as most of you know, I'm also an electrophysiologist. So, our implant rates for prophylactic ICD has decreased remarkably
Yeah,
since
this is true.
quadruple therapy has been effective. I mean,
Indeed.
the average ejection fraction does increase. So, at this point, what we do is we step up all the therapies, wait for at least 3 months, look at the ejection fraction. And most of these patients are fortunate to get their EF above 45%, which relieves us of the need for an implant, battery replacement, cost of to the healthcare system, cost to the patient, need for replacements in 9 to 10 years. So I think this has really been sort of a very exciting time in heart failure.
Yeah, I have a question from Dr. Shaul. Dr. Shaul.
Yes. Yeah.
You have shown some amazing cases. So I have two questions which are related to each other. One is, out of, let us say, 20 cases in a year, you meet with such kinds of situations, very hemodynamically compromised. What is the success rate? And do you really see any difference in the success rate since we have the new devices like Impella and ECMO?
Oh, there's no question that because we are now really taking care of patients in much earlier stages. We don't wait till they are in cardiac arrest, refractory heart failure. I think if you have a patient you put in a controlled situation, either Impella or ECMO, and have an anatomy which is ideal for intervention. You see, what I've learned over the years, if you take somebody who's not great for intervention, there's no point in putting a hemodynamic support. What hemodynamic support will allow you to keep them stable, the operator is very comfortable, the team is comfortable, then you can do a procedure. There's no question our survival is much better by early institution of these support devices and have an ideal anatomy for intervention.
Okay. I remember you used to say that your success rate was anyway very high even in the earlier decade back.
Well,
And
let me give an example. We looked over 23,000 interventions. How many had a cardiac arrest and cath lab? There's 56 people out of 23,000 cardiac arrest. I'm talking chest compression, refractory. They were all put on ECMO, treated the underlying condition. The survival was 69%. But the key thing was the early institution and treating the underlying problem which led to cardiac arrest.
Yes.
I have a question for Dr. Praveen Chandra. Dr. Praveen Chandra?
Dr. Chandra, can you unmute yourself?
I think we can't get him online now.
May I ask a provocative question?
Yeah.
Is there any role left for surgical AVR?
Yeah, that's what my question was to Dr. Praveen Chandra,
So
because he
Dr.
has
Shawl can
covered
answer this.
all the
Dr.
risks.
Chandra is not here.
So if you can highlight, if we can't get Dr. Praveen Chandra online,
I think
I
better
was
something
wondering,
for
was there any
answer.
role in 2021 for surgical referral aortic valve replacement?
You're asking me?
Yeah, we
Yeah.
are
Yeah,
asking.
Well,
you can answer, yeah.
well, let me tell you, we have just have the guidelines for TAVR, just published 2 weeks ago. The question was between the age of 65 and 80, we should have either procedure, and the patient should be taken into consideration his consent. If it's under 65,
Yes.
since we don't have a long-term outcome, surgery will be still number one, unless they are high risk. But if you are age 80 and above, TAVR is the treatment of choice.
Thank you.
Thank you.
I think
Thank you.
to conclude the session here, I would like to thank all the speakers for the excellent talks and the comprehensive coverage of all the topics. Thank you very much.
Thank you, Dr. Mittal, for a
Thank you.
wonderful
Thank you.
meeting, and I learned a lot.
Thank you.
Thank you.
Thank you.
Thank you
Thank
for
you.
inviting me. It's outstanding.
Thank you. Good evening. Welcome for the next session. I'll quickly introduce our moderators, and then moderators will take over from here. We have the pleasure of having Dr. Tan from Singapore and Dr. Amrish Agrawal. I'm not sure I can see him here. Yes, he's here. Dr. Amrish, good evening. Good evening. And we also have Dr. Jairam from Abu Dhabi. He's an interventional cardiologist, a prolific interventionist. Dr. Amrish is an academician as well, as a consultant cardiologist. So three are the moderators, and I leave the floor with you. And we have Dr. Abdullah Al-Hadri excused us. He could not record his presentation. So we have some springboard time. That is how we could delay last session by a few minutes. And we still have few more minutes extra in this session. So we can have discussions. I will continue to guide you about the timings. So let's go forward. And from here on, I invite you all to take on. Thank you.
Good evening, everybody. And it's a great pleasure to be with you all. And Dr. Mittal is a fantastically organized, as usual, all the meetings. And we have colleagues, Dr. Huai Tan, welcome to UAE. And our close friends, Dr. Jairam and Dr. Robert, also welcome from Poland. I've been to Poland, so Poland is a beautiful country. Many times I've been there. It's one of the really beautiful country. Yes, how are you? And we have our first speaker, unfortunately, the colleague of mine, which I was supposed to introduce. We work together, Dr. Abdul Hajri. He's not able to join us. So our next talk will be with our Professor Tan Huai Cham from Singapore. And my brother in Singapore is now they are controlling corona very well now. And he's going to speak on culprit or complete revascularization for primary PCI therapy for acute stimulation of my patient with the multivessel disease. This has been a controversy on and off for last quite many years. And pendulum swinging that we should only touch the culprit vessel, the pendulum swinging, we should do a multivessel PCI. And again, we went to the first side, and there are interventional cardiologists in this group which are dealing with this problem every day in their life. So, Dr. Tan, we will be very much glad to hear your opinion.
Good evening. Thank you for the opportunity to participate in the fifth annual conference of Shakeheart 2021. My name is Tan Hui Chim, and I'm here to speak on the topic of culprit-only or complete revascularizations for primary PCI therapy of acute STEMI patients with acute multivessel disease. So I'm going to start off the lectures by sharing a case study. This is a 40-year-old Chinese male with cardiovascular risk factor of smoking and family history of coronary artery disease when he was admitted with sudden onset of the chest pain. The resting electrocardiogram clearly showed an ST elevations in the anteroseptal leads with reciprocal changes in the inferior leads. And this is the angiogram which shows that there is a presence of proximal left anterior descending artery tendon stenosis. But really, the culprit lesions was that of a diagonal artery which was completely blocked here. So the operator went ahead and revascularized the occluded left anterior descending diagonal artery, and this was the post-stenting results. While the diagonal artery has been restored in terms of its patency, there still remains LAD stenosis. At the same time, the right coronary artery was also steady, and there was evidence of a significant high-grade stenosis in the mid segment of the RCA. So the question then now in the as we face is, do we just stay on with just doing the culprit vessel PCI of the diagonal artery, or do we go ahead and perform a multivessel PCI of also the LAD and the RCA artery? Or do we consider the third option here of a stage PCI during this index hospitalization? Or can this patient go home and have a stage PCI schedule after his hospital discharge? So when we look at the background of a primary PCI was first performed by Dr. Peter Rentrop in 1978. And we know that multivessel coronary artery disease occurs in about 30 to 65% of patients who present with STEMI. And this is associated with worse outcomes compared to patients with just single vessel coronary artery disease. Multivessel PCI pioneer Dr. Jeffrey Hassler was once recommended that any sort of a primary PCI ballooning procedure of a non-culprit lesion should really be done as a stage fashion, but this was in the era of balloon angioplasty. Now, in the primary PCI era currently, should we consider a revascularizations of the non-infarcted lesions? We know that even with a primary PCI, the STEMI has a high morbidity and mortality. And we know that complete revascularization is always better than the partial revascularization, for it improves the outcomes in patients with multivessel coronary artery disease. But the questions to be answered here is that the non-culprit lesions, are they really that stable? Because the presence of a STEMI pathophysiology could very well result in the inflammatory process and disrupt the stability of the non-culprit vessel plaque. And there's a second question here is, does the treatment of the non-culprit lesion alter the natural history of coronary disease after STEMI and result in the clinical benefits for the patients in future? For the proponents of the culprit-only strategy of primary PCI, they will argue that the ischemia and complications in the non-infarct-related artery will be very poorly tolerated because there's a significant potential for hemodynamic as well as electrophysiologic instability. Plus, the additional use of a contrast may result in contrast-induced nephropathy. Frequently, we don't know what is the status of the renal function in these patients. And also, when you operate in an acute STEMI milieu, there is significant systemic vasoconstriction and endothelial dysfunction. One may overestimate the IRA lesion severity and perhaps even undersize the stent as the vessel becomes vasoconstricted. And when you have an infarct-related artery that gives you a suboptimal perfusion result, and in the presence of a heavy thrombotic burden, all these are all going to increase the risk of interventions of a non-infarct-related artery in the same acute setting. Plus, the presence of a platelet activation and poor thrombotic state increase the risk of a patient developing stent thrombosis. Now, the proponents for patients who to go for multivessel PCI in the setting of STEMI will argue that the AMI represents a very generalized pathophysiological derangement of endothelial dysfunction, coagulations, and inflammations. And though such forces has the potential to impair coronary perfusion beyond the culprit lesion distribution and destabilizes plaques throughout the coronary vasculature. So there's no time like the present to perform a PCI of all the remaining non-corporate lesions. From a patient perspective, this is a captive audience. He's already on the table. He's already on antithrombotic. You will avoid the situations of the patient losing the follow-up if you let the patients go off without intervention at this acute setting. From a clinical effect perspective, there is a potential for improved hemodynamics, reduced ischemia, and prevention of reinfections and vessel passivation as well, and following a PCI. Certainly from a system of care here, you will have a fewer procedure and decrease the total cost of care when you do the primary PCI of the non-corporate lesions at the same time. Early evidence would suggest that actually a corporate lesions only strategy may be better than a multi-vessel PCI. This very early study, the orange bar indicates a lower risk of mortality at 1 year when you just do a multi-vessel, single vessel primary PCI. And this was some of the early meta-analysis conducted way back in 2014, suggesting to us that there is perhaps a improved long-term trend when the multi-vessel PCI is done during an index primary PCI, but the studies were really heterogeneous, and that most of which were rather registries than randomized controlled trial. So in the late 2013 onwards, we have a significant number of randomized controlled trials that were being performed. And here I just want to highlight to you the top 3 randomized controlled trials that everybody is familiar with: primary, corporate, as well as pre-multi. And all of these 3 randomized controlled trials has got one common findings, and that is the invasive arm of a multi-vessel strategy is far better than a conservative strategy, whether you perform it during the index procedure or during an index admission. And all of it shows a improved benefit with regard to a reduction of ischemic endpoint. Let's take just the corporate lesions or corporate trial and look at the primary endpoint. Clearly, we can see that there is a significant reduction of a composite of total mortality, repeat myocardial infarction, heart failure, and ischemia-driven revascularizations at 12 months. But what is more interesting for corporate trial is that when you look at the follow-up at 5 years, there was a significant reduction of heart clinical endpoints, combining all-cause death and myocardial infarction. So this is very significant. And the majority of the benefits continue occurs in the early phase and then continues during a long-term follow-up of 5 years. Then we look at the dynamic 3 pre-multi, which is a little bit different from primary and corporate in the sense that the operator actually based the decisions on intervention on the physiologic parameter of FFR. So FFR guided strategy was the determinant of need for intervention in pre-multi trial. And here we did not see a significant difference in occurrence of heart clinical endpoints such as cardiac-related death. Most of the benefit of a complete revascularization strategy was driven by a near 70% reduction in repeat revascularizations. And this was actually corroborated by the COMPARE acute trial, which also uses FFR as a differentiator for interventions versus medical therapy. And in this FFR-guided complete revascularization, there was again a major reduction in terms of a need for revascularization, but no significant reduction in heart clinical endpoint. Then we must look at the FFR assessment of non-corporate coronary artery lesions during AMI. Is it really that accurate? So this is a study that compared the FFR during the acute phase and then follow them up subsequently, and then comparing the FFR during acute phase and follow up and see if there's any difference. Here we can see that there was not much of a difference in the FFR of non-corporate lesions during the acute as well as a follow-up phase, which is a mean of 35 days. And so it suggests to us that the severity of the non-corporate lesions may be reliably assessed during the acute phase of ACS. So then we have to look at the complete trial, because complete trial enrolled both patients based on angiographic criteria if the lesion clearly is more than 70%. But if the lesion is less than 70%, between 50 to 70, then an FFR is required. Look at the complete trial is the largest randomized controlled trial of a single vessel primary PCI, corporate only versus a multi-vessel PCI strategy. There was a significant 2 primary outcomes endpoint here. there was a significant reduction in the composite of cardiovascular death or new myocardial infarction, a reduction in heart clinical endpoints here in this group of patients who were followed up for a median of 3 years. But when you look at the second co-primary outcome, including the ischemia-driven revascularization, the difference becomes even larger. So the complete trial also taught us one thing, that there was actually not much of a difference whether you do a PCR of the non-corporate lesions at the index procedure or during the index hospitalization. Also, if you were to discharge the patients and then to bring them back to do the intervention, there was also no difference in terms of the clinical outcomes. So suggesting to us that the timing is really up to the investigator, and we're still not sure when is the optimal time for intervention in this group of patients. So when you look at all these 5 different clinical trials, on the left side here will be this intervention arm, on the right side control arm, which is do nothing except just treating the PCI of the corporate lesions. You find that when we put it into a meta-analysis, the latest to be performed by the et al., you find that the multivessel revascularization strategy in patients with STEMI undergoing primary PCI was associated with no significant difference in all-cause mortality. However, a multivessel strategy do offer the benefit of a lower risk of reinfarction, cardiovascular mortality, and repeat revascularizations. There was no difference in the major bleeding, stroke, and contrast-induced nephropathy between the multivessel versus the corporate lesions strategy. So which one is better in terms of determination of the significance of a non-corporate lesion? Is it FFR or is this angio-guided? When we look at this meta-analysis, it would appear that the angiographic-guided PCI has got a much better improve mortality outcomes compared to a strategy where you rely on FFR. Herein lies the difference between FFR and angio-guided PCI. When you use FFR, you are actually predicting flow severity and subsequent risk of ischemia-driven need for ischemia-driven revascularization, as in the FAME-1 trial. But when you do an angiographic assessment of a lesion, you are actually looking at the complexity and perhaps even predict the vulnerability of the lesions. So now we have whole concept here of identifying lesions that perhaps will benefit from a revascularization, what we call a trifecta lesions, which were known to be associated with poor clinical outcomes. So when you have a lesion that has got a large plaque, or when you have a lesion that is rich in lipid core, or when you have a lesion that has a very tight or lumen area of less than 4 square millimeter, this 3 combination combined together increases the risk of subsequent cardiovascular event. And we now also know that it is possible that we may alter the natural history of a coronary disease with a angioplasty, mechanical angioplasty procedure, as in the ABSORB prospect trial. So on the left side, this will be the natural history of a atheroma progression in the patient's coronary artery. But when you put in a bioresorbable scaffold like an ABSORB stent, you find that you actually cause a gradual reductions of the scaffold with the endothelializations of the scaffold, and subsequently the scaffold actually disappear, and you find that the lumen actually increases. So from an effectiveness perspective, in terms of minimal lumen area during follow-up following implantation of bioresorbable scaffold, this would appear to be something that is promising. However, from a safety endpoint, there was really no difference between bioresorbable scaffold and normal stent. So more trials are coming in the way in the form of prime time trial. So this is a trial that is going to examine once and for all, is FFR guided strategy better, or is this an angio guided strategy better? Do we have to do everything during an inpatient procedure, or can we do it as an outpatient strategy, or could we just leave the non-corporate lesions alone completely? So this trial will add to a further literature in this particular matter. So let's look at some of the guidelines that were suggested by the International Society. The 2013 ACCF and AHA guidelines suggested there is a type 3, class 3 recommendations for the performance of a PCI in non-corporate lesions. However, this was changed in 2015, and now the Americans are saying that it is okay perhaps to do a PCI of a non-complete lesions who are hemodynamically stable, either at the time of primary PCI or as a planned stage procedure. It was class 2B. But the European says that this is a class 2A recommendations now based on all the published randomized controlled trial. So routine revascularization of non-infarct related artery lesions should be considered in STEMI patients with multivascular disease before hospital discharge, and this is a level A evidence. So what did I do for my patients? If you recall, this is the RCA. There's a lesions in the mid segment. So I did a FFR for this patient. The FFR was 0.89. This was deemed to be hemodynamically not significant. So this is the LAD artery. There's tandem lesions here as well as here. And the FFR was measured to be 0.76 at that time of the index procedure. So I let the patients go home and then come back again 2 weeks later where I repeated the FFR once again. The FFR of the right remains not significant, 0.84 compared to 0.89 2 weeks ago. And the LAD remains at 0.76. So go on to do a PCI, stage PCI of the LAD lesions and restore the FFR back to a normal level of 0.89. So in conclusion, it's not really a question of when to do a multivascular PCI in the patients with multivascular coronary artery disease presenting with STEMI, but it's really when it is not whether we should be doing the intervention, but rather when is the best timing for intervention in this group of patients. And secondly, we just know that the conservative management of patients with non-culprit multivascular disease is just not good enough. However, there are many questions that remain to be answered, whether we should do it immediate or stage PCI in the patients with multivascular disease. Should we do it during in-hospital or can we delay it to more than 30 days, like in the complete trial? We did not take into account for the complexity of the lesions in many of these trials. See, what about patients with CTO? Do they indicate a higher risk group of patients that we should be looking at? We also did not stratify by the evidence of ischemia. Is it a limited size of ischemia or is this a huge size of ischemia? And finally, we also did not consider some of the specific comorbidity that the patients may be having, plus his own personal preference, etc. So the strategy of complete revascularization should not be routinely performed, in my opinion, on an ad hoc basis, but based on an individual and careful patient and lesion assessment. So with that, thank you very much for your attention. So, so I'd like to go on to the next speaker. I'm going to introduce Dr. Robert Gill from Poland to now talk to us about contentious issues in the primary PCI. Dr. Gill, please.
Thank you very much for your introduction. I will try to share my my presentation. Okay, so thank you very much for a very kind invitation. I really appreciate to have opportunity to share my knowledge and experience regarding acute coronary syndrome problems. By the way, the topic is on one hand easy, on second not so easy. Contentious issues in primary PCI means some controversies, some problems, despite big development which was performed in this field. Let's start from the beginning. Since beginning of 21st century and meta-analysis of Keeley, we know that primary PCI is most effective method for treatment of STEMI. And of course, with intravascular visualization, we can optimize the results. We clearly know that it's worth to be done. that stents are more effective than classical old plane ballooning. And of course, I started to think how I should construct my presentation. And then I reminded a very nice presentation which I saw during participation a couple of years ago in TCT conference in the United States. And I remember that the presenter started saying about primary PCA, showing his 10 commandments for primary PCI. Then I thought that I can follow this way. And of course, we have to remember that time is muscle, and we should perform revascularization for STEMI patient as fast as possible. And of course, this is probably our individual choice, what kind of milestones, our own milestones we can bring to these 10 commandments. This is my proposal. And of course, there is no time to go through all of them. However, I would like to construct my presentation based on these highlighted points, because in these fields, due to the ongoing researches, published papers, we can think that this is not all, let's say, end of the story. We have to be prepared for improvement, for changes, because it's very bad to say that there is no other option to improve what we are doing right now. Let's start with pharmacology problem. So in the literature and guidelines by European Society of Cardiology and American Societies of Cardiology stated that aspirin and P2Y12 inhibitors should be used as a dual antiplatelet therapy, as for pretreatment and post-interventional. But if you look at the literature, we have to remember about Twilight trial results, and also quite recently published TICO STEMI, where two strategies were compared: ticagrelor based 12-month DAPT and ticagrelor monotherapy after 2 months of DAPT. And you can appreciate here that only for as treated analysis significant difference was found. But if you take into consideration the major bleeding, you can find that much more favorable for ticagrelor monotherapy was found. In terms of major adverse cardiac and cardiovascular events, there was no significant difference. And investigators of this trial stated that ticagrelor monotherapy after 3 months DAPT compared with ticagrelor based 12-month DAPT resulted in a reduced risk of major bleeding. As for major adverse cardiovascular and cerebral events, there were no significant differences between the two treatment groups, without significant interaction with clinical presentation in this study. So, in my opinion, this is another very important argument to wait for significant changes in the guidelines regarding antiplatelet treatment for patients with STEMI treated with primary PCI. Let's go further. The access. So radial first, based on many trials, it was stated that radial access is superior to femoral one. Therefore, not only European Society of Cardiology but also Americans recommended this access with class 1, and it was due to the fact testing in randomized trials with A, and this is it was very short to the sentence that radial artery access is associated with mortality reduction in myocardial infarction patients. So therefore, it should be performed in the first step. And of course, we know why radial access is so convenient for patients, for experienced operator. However, we have to remember about some problems, anatomical response of very irritable artery with spasms, some dissections, difficulties with anatomy. It's not so easy, especially in the situation of nerves and duty procedure just very late night, where operator is just on the one. Of course, there are some information about improvements of these techniques. This radial access with snapbacks access usage is also a very convenient, but in well-experienced people. I just wanted to say that this access is primarily chosen by many operators, and everybody believes that this radial access is much better than the femoral. With some doubts and surprises, we found Safari STEMI results showing that this superiority of radial access to femoral one is not so obvious. Here you can appreciate that the results used to show that there is no really big, let's say, significant difference. Also from time of procedure, timing of the primary PCI, fluoroscopy time, it's still femoral access is worth to be thought. So in conclusion, the investigators said that in Safari STEMI, they didn't find a difference in mortality or other clinical endpoints between transradial and transfemoral accesses. But of course, we have to stress the fact that this situation has to be associated with the high volume centers and operators very experienced in femoral access, also with the access to mechanical closure of arterial accesses. And also these investigators stated that in patients with STEMI referred for primary PCA, the best results are likely obtained in high volume centers where the operators are experienced with both radial and femoral access abilities. Next point, which I would like to bring to your consideration, this is thrombus. And we know quite well that in the guidelines prepared by European Society of Cardiology, also Americans, it's stated that routine use of thrombus aspiration is not recommended. But on the other hand, we have to remember about the mechanisms of mechanisms associated with acute coronary syndrome, how thrombus formation is going to appear, this difference between non-STEMI and STEMI patients, and where still thrombus plays very important role in a history, natural history of acute coronary syndrome. So we can say very strongly that STEMI is a thrombotic complication of unstable atherosclerotic plaques. So from a rational we should believe in that mechanical aspiration of the thrombus should positively improve the outcome of the patients. And of course, we have a couple of trials. I'm sorry for these busy slides. On one hand, tapas and taste trials showed positive results for aspirational thrombectomy. The others not so good. Recently published meta-analysis showed also that thrombus aspiration plus primary PCI doesn't reduce the risk of death, myocardial infarction, or stent thrombosis. So, but on other hand, if we look at the detailed results, for example, total trial, we easily find that high thrombus burden is a predictor of bad outcome of the patient. So this is a rationale allowing us to believe that we should do something more that we do up to now to let's say to fight with this thrombus. So of course, if we start to think about potential reasons of this failure with up to now aspirational thrombectomy, then of course there is a problem with volume of thrombus, which can be removed by with thrombectomes available on the market. That this is the problem of rapidity of removal, tractability of the lesion of interest, which is very often connected to distal and proximal embolization. The next problem is the maintenance of aspiration power without losing the thrombus. Sometimes fighting with the thrombus in circumflex artery, we can lose or deliver the material for LAD, for example. And of course, we need a new equipment which probably should be more efficient compared to the old ones. Here you can appreciate one of the proposal. I don't like to say that this is the only good and optimal one, but I would like to bring your attention to the power aspiration portion or model, which is connected to the traditional thrombectomy with a relatively bigger lumen, allowing us to believe that probably this device can be more efficient. As a conclusion, of course, we have to remember that still we have to remember about small balloon ballooning with small balloons. We should repeat predilatation even using higher pressure, combining it with manual thrombus aspiration. We have to take our time to restore antegrade flow. If this result is not adequate, we have to think about stenting, believing that stabilization of the lumen with stent improve the flow and change bad scenario of the situation. And of course, just additional advice, we have to remember about the other potential decisions about distal administration of adenosine to improve microcirculatory flow, administration of stronger antiplatelet drugs as cangrelor or GP2B3A inhibitors. There's also some belief that much more, let's say, stronger thrombectomy as an angiogetic in a certain situation with a huge right coronary artery or venous bypass graft, we can also use this device. Next point, which I would like to let's say to bring you to your consideration. This is a stent implantation, and of course, we all let's say believe that drug-eluting stents is over BMS for any clinical scenario. This is no doubt. We have confirmation in guidelines for myocardial revascularization, also for STEMI, for guidance on STEMI treatment. But on the other hand, it's relatively strongly stated that bioresorbable scaffolds are currently not recommended for clinical use outside of clinical studies. But if we look at the history already accepted, already published papers, we can say that this belief in idea, nothing behind the wall, because of this resorption of the scaffold, it's still alive. If we look at the 3 years results for ABSORB STEMI trial, you can appreciate that the results are comparable to at that time the best drug-eluting stents on the market. There was not significantly big difference. There was a trend towards better results for DES, but without let's say statistical significance. And of course, also in ISAR ABSORB, there was a quite similar situation. There was no really difference between these two chosen stents, everolimus eluting and bioresorbable scaffolds ABSORB. And of course, we have to remember that in majority of cases, STEMI presents in relatively young people. The lesions are located in proximal segments with plaque mostly soft, without a big amount of calcium and fibrotic tissue. So the plaque burden is rather smaller than in chronic stable coronary artery disease. So this belief that we need something better, which will be able to recreate the vasomotion, is really very interesting. And recently, quite recently,
sorry, Dr. Robert, can you hear me?
Yes.
Sir, we might conclude now because for the time management. If you can conclude now, your presentation.
Okay, just to conclude that unfortunately, in terms of angiographic efficacy, there was no found positive results for magnesium bioresorbable scaffolds. However, this is the first trial showing that with this device it was possible to return of vasomotion, and this is showing, at least for me, it proves that this is a very good direction. So complete revascularization was already already presented by the earlier presenter. I don't want to go into the details. We know that multi-vessel disease means independent predictor of bad outcome, especially for cardiogenic shock. We know that it's much wiser to let's say to be focused on culprit lesion only than for immediate multi-vessel PCI. But on the other hand, we have to remember that after these 30 days, these trends are changed. And also a very important issue that in terms of cardiac causes of death in this culprit shock trial, there was no significant difference between these two techniques, and for non-cardiac, much higher percentage of brain injury was found. So it means that we shouldn't stop our procedure just after culprit lesion treatment. We should also consider potential other our lesions treatment in terms of in situation where there is impaired flow. The same situation for STEMI without shock. It's obvious that this complete revascularization is superior to culprit.
Sir, can we conclude now? I'll be very thankful to you.
Okay, if you want, I can conclude that just a last moment that
yes.
We believe that we need something more to mechanical flow restoration. We need support for protection for myocardium. One possibility is a cooling as an adjunctive therapy to primary PCI. Here you can appreciate the results of cool myocardial in core trial. However, still hypotemia showed as adjunctive therapy to primary PCI as feasible, that can be implemented without delay in coronary perfusion. Hypotemia was safe regarding the incidence of MACE at 30 days. Regarding efficacy, there was no difference in fact, infarction size and left ventricular ejection fraction at 30 days that would suggest additional myocardial protection with hypotemia. Thank you very much for your attention.
Thank you so much. We have the next speaker, Dr. Jairam. Can you welcome Dr.
Sure. Next, good afternoon all, and thank you again to the two professors, Professor Tan and Professor Gill, for wonderful talks. We now would like to go on and introduce Dr. Waqar Gaba. He's a consultant in internal medicine and stroke, and he will be taking us through the tailored protection of cardiovascular patients, the role of NOACs in patients with venous thromboembolism. Over to you, Dr. Gaba. Welcome to the show.
Hi, good evening. Thank you, Shakeheart, for giving me this opportunity to talk about such an important topic. Thank you, Bear, and thank you, audience, for listening to me. The topic which I've been given, I slightly changed a bit to extended VTE treatment, choice, or necessity, and that's what we're going to talk about tonight. So objectives of my talk today, we'll first talk about a case, a real practical example, then talk about the extended VTE treatment and what choice we have. We'll then talk about VTE treatment guidelines, so what the guidelines suggest and whether we are following them. We'll then go back to our case at each step to tell you whether with our case, how we did. Then I'll leave some time for questions and answers. So let's take you to our real patient, but obviously the face is just fictitious. Antonio is a 67 years old gentleman who is obese. He has no past medical history. He had a recent long-haul flight from UK, bearing in mind this was pre-COVID area. He presented with breathlessness with these vitals. Now, as you can see, he is tachycardic. He has a normal blood pressure. He's tachypneic with SATs okay. He had normal examination. He had normal bloods except raised D dimers. We had no DVT clinically. So you can see where it's heading towards. We did the compression ultrasound and found no DVT clinically, and no surprises, we did the CTP, which has confirmed low bar PE on the right side. Now, there's no doubt this is an uncomplicated PE, you can say, because there's no hemodynamic compromise, there's no complications. We started the patient on rivaroxaban 50 milligram twice a day for 21 days, and then 20 milligram once a day for 3 months. Now, bearing in mind, this is the usual treatment dose for PE. So the question I have next is, for you guys, is this provoked PE? Is it provoked due to transient risk factor? Is it provoked due to persistent risk factor? Or is this unprovoked? So I would like you to, all of you, to actually pick up one of these A to D letters and post here in the comment section so that I know what you're thinking and you can pick one answer as well. And we'll talk about later in the slides. So this concept of provoked and unprovoked VTE is getting obsolete. Okay? The new concept has been, now we more talk about the transient risk factors, the persistent risk factors, or no risk factors. If there's transient risk factors, they also either could be major or minor, leading to them, or persistent risk factor like a cancer, which again lead to VTE, or no risk factor. Now, the ACCP guidelines recommend at least 3 months of BKA treatment after provoked VTE or longer after unprovoked. So this takes me to the next slide. This is an important but busy slide. So I'll take you through this. So this is from ESC 2019 guidelines, and it tells you that the recurrence risk of recurrent VTE is divided into low, intermediate, or high risk. And that depends on why they got the PE. So it's green, so less than 3% risk, if you have a major transient or reversible risk factor. So in other words, you had a major surgery with GA more than 30 minutes. You have been in the hospital with an acute situation, acute infection, illness, more than 3 days in the hospital, with bed immobility, and trauma with fracture. It's an intermediate risk if you have a transient or reversible risk factor. So like minor surgery, so not major surgery, minor surgery, you have been pregnant, you have been to the bed, but out of the hospital for greater than 3 days with an acute illness, out of the hospital, not inside the hospital, or you had a long haul flight, which comes our patient. So it's an intermediate risk for our patient. Or you have non-malignant persistent risk factors like IBD or active autoimmune disease, or you could not find the risk factor, you can argue in our case, apart from this, there was no other risk factor. The high risk is those who have obviously a cancer, those who have antiphospholipid syndrome, or had previous VTE. So why is this important? As you can see, old slide, but from Beglan in Lancet 2003. If you have a VTE provoked by major surgery, compared to when it's provoked by non-surgical risk factors, your risk of VTE, as you can see, goes up and up. And if it's unprovoked, what we used to call them, it goes up and higher. And look at this, at 3 months, how quickly here it starts to differentiate the unprovoked ones from the others. Okay, so the risk is high when it's unprovoked or due to transient risk factors. So going back to our patient, the question 2, I would like you to think about. Say this patient has been having this rivaroxaban, being compliant for 3 months, comes back again to you for review. And he asked you that, should I stop rivaroxaban at 3 months? Should I continue for 6 months? Should I switch it to aspirin? Should I switch to rivaroxaban low dose, which we'll talk about in a few slides, or go for injections after 3 months? So again, I would like you to commit on one of these A to E options, comment on the comment section so that we can look into it. And I'll answer that in a few slides. So for extended VTE treatment beyond obviously the initial treatment, we have several studies, starting with DEBI, Resonate, and Remedy, rivaroxaban, Einstein extension, Einstein choice. You have apixaban, you have aspirin, and you have celedoxime. So let's take you to the Einstein extension study. Now, as with our patient, the patient was given 6 to 12 months of treatment if they were randomized into two arms in this study. So the question was asked that if they were given extended treatment beyond that with 20 milligram once a day, is it better than placebo? Okay? And the question is whether they got more VTE or bleeding. Now, you will be amazed to see that 82% relative risk reduction of recurrent VTE, the ones who were given rivaroxaban. Okay? That come with some side effects, which is bleeding. Obviously, yes, for major bleeding, that means the ones who needed blood transfusion or with the drop of hemoglobin. But 3 were GI bleed, 1 were menorrhagia, so no critical bleed, no mortality. So yes, it comes with a price, but I think probably it's a good price to pay. So that takes you to actually the way the risk and the benefits. So on one hand, you have a patient who have a recurrence risk of VTE if you don't give them any further extension of care. Other hand side, you have a patient who has got, you stop the VTE, extend the treatment, you have a bleeding risk. But don't forget the patient's choice is very important. What actually the patient wants? Do they really want you explain them, explain their risk, and explain the bleeding risk, and see what they want? That takes me to the Einstein choice study, beautifully designed study, and try to answer the question that what if after having 6 to 12 months of anticoagulation, we already established that 20 milligram was better than placebo, but how about 10 milligram or now where did that come from? So 10 milligram came from the trials who've been done for orthopedic patients, and it improved use of VTE prophylaxis. And aspirin, again, for many years, there have been some studies proven that post-discharge, it has helped in these surgical patients, the aspirin after discharge. So let's see. So when Riva was compared with aspirin in 20 milligram dose, you can see the recurrent risk of VTE has gone 66% relative risk reduction, 17 versus 50 cases. And with 10 milligram, again, 74% relative risk reduction. Remember, this is not a comparison with placebo. This is now comparison with aspirin. Did that come with a price? Now, with bleeding risk, 20 milligram versus aspirin, you can see 6 events versus 3, and with 10 milligram, 5 events versus 3, not statistically significant. So yes, it comes a little bit more bleeding, but of course, the 10 milligram gives you good protection of the recurrent VTE with not much difference in terms of the profile versus aspirin. So what we just established in last few slides, that Riva gives you this opportunity. Starting with treatment, when you compare, we already know with Einstein study, when you compare with no molecular weight heparin, it's equal, better, equally efficacious. When it compared with Einstein extension with placebo, of course, it was better. Prove that. And when you have two choices, either 20 to continue or 10 milligram in Einstein choice, you obviously had the better choice of reducing the dose as required. About the bleeding profile, and as you can see, very comparable bleeding risk profile with not much difference and not much concern. It's just our patient going back, what do we need to establish? So we said that is this provoked due to transient risk factor. I think probably by now you have established that, okay? And that was the long haul flight, okay? What about the question 2? Those who clicked on D are thinking on the right lines, because we just established that switch rivaroxaban to 10 milligram after 6 months is the better choice. So is it just Riva? No, there have been other studies as well, likewise Amplify extension, trying to prove apixaban in the similar context. So apixaban 2.5 milligram twice a day and 5 milligram twice a day were also studied against placebo. And here you can see, obviously, definitely better than placebo. And in terms of bleeding, 2.5 milligram was comparable to placebo. Debbie was also compared with warfarin and also with placebo. And in terms of, again, bleeding, it was compared with warfarin and placebo. So Debbie has, again, proven to be better in terms of current VTE, but it comes with the price. Now, Aspire. So aspirin was compared in Aspire trial with placebo. And here is the meta-analysis by Timothy. And you can see the pool analysis with Aspire and Rafasa trial. In the pool analysis, you can see the diamond here on this side towards aspirin. So obviously reduce the risk of VTE, but again, comes with a bit of price for the bleed. So going back to our patient with question 3, I'm going to pose is, so patient continued with rivaroxaban 10 milligram once a day, and he comes back to you, let's say in 9 months or 1 year, and he asks you, do I really need to continue? Should I just stop because I don't need it? Should I switch it to apixaban because somebody said to me, well, we'll try another one? Or switch it to injections? Or switch it to aspirin, which is, in my view, maybe it's very benign drug, okay? Or there's another indication I'm taking aspirin anyway. So, see what the guidelines here. So, NICE, as you know from UK, 2020, quite recent, again said the same thing which we just talked about. It's a benefit versus risks. So, at 3 months, you have to discuss the extended therapy for unprovoked VTE, and at 6 months in patients with cancer. So if it's a provoked, what we call as major transient risk factor, then stop. Okay. If it's unprovoked or persistent risk factor, you extend the treatment with patient preference. This is very important. Consider using HAZBlood, but remember, HAZBlood has not been validated for these patients. Okay, it's been validated for AF patients. Okay, but if it's more than 4, consider stopping it. If the current treatment is not well tolerated, okay, so you have also a choice for switching apixaban if you've already been on other direct-acting anticoagulant other than apixaban. So for people who, for some reason, don't want to take anticoagulation, you can continue with aspirin. ESC, again, I'm relating this, what we talked about, provoked and unprovoked, is no longer supported, okay? And it's actually, they're saying, misleading. So for cancer patients, edoxaban or rivaroxaban should be considered as an alternative to heparin injections, non-liquid heparin injections, but with a word of caution for GI cancer due to bleeding risk. Another very busy slide. I want you to spend a few moments onto this, and I'll take you through this one by one. Some of these things which we already actually talked about. So if you have a major transient or reversible risk factor, like a major surgery, you stop after 3 months. Okay, so this. On the other hand, if you have a recurrent VTE or antiphospholipid syndrome, these are the indications where you should recommend to extend it beyond 3 months, definitely, maybe even lifelong. It should also be considered the ones who have no identifiable risk factor, what we use to call unprovoked, or a persistent risk factor, if it's like other than antiphospholipid, even it could be obesity, for instance. Okay, you should consider extending it beyond 3 months. But when you do extend it, you have choice of apixaban and rivaroxaban. Now, they also talked about minor transient or reversible risk factor. Forgot about. Okay, so essentially, you can extend it for no identifiable risk factor, for a persistent risk factor, or a minor transient or reversible risk factor. And you have choice. We just talked about aspirin or rivaroxaban, low doses. And the ones who don't want to take anticoagulation, you have choice for aspirin. So going back to our patient actually he said, remember, he was obese. He had a PE after recent normal flight. Okay, so he had definitely one minor transient risk factor, one maybe a persistent risk factor. But categorically, he said, I don't want to live in fear of having another PE and ending up in hospital again. And this is very important. So he hated when he had it, and he was really worried if he's going to get it. So he considered reduced dose for extended anticoagulation after with not much problem. So he carried on taking 10 milligrams of once a day, and that does go with actually the ESC guidelines. So that takes me back to the question 3, which we talked about. So he has an option of either continuing rivaroxaban at the same dose as or switching it to aspirin. In rare circumstances, he can actually choose for some reason to go to rivaroxaban if he's having some allergy or some tolerance issue with rivaroxaban. That takes me to the final slide of saying thank you again for this wonderful topic and stage to talk about. Happy to take questions now to answer some.
Thank you, Dr. Kaba, for the wonderful presentation. We wait for him to get in live so we can ask questions. Any questions from the audience? We've had a wonderful 3 sessions, and if I may direct one question to any of the 3 speakers. So what if we have a situation where we have a patient who develops an acute thromboembolic event secondary to after primary PCI with cardiogenic shock? What would be the therapeutic algorithm that people would follow?
Dr. Tan.
Yeah, perhaps I can just suggest. So you're talking about a stent thrombosis after a primary PCI. Is that right? A thrombotic complication?
No, sir. Actually, suppose there's this patient who presented with for primary PCI following, along with cardiogenic shock. Primary PCI, the presentation was complicated by cardiogenic shock, and let's say he was ventilated. We successfully stented his proximal LAD, and now, thanks to being on bed on a ventilator for 4 or 5 days, he develops acute venous thromboembolism. How would we approach this gentleman?
Well, I think we will have to start an anticoagulation therapy, just like any other sort of venous thrombotic, because this is a patient who has obviously a provoked situation, the ventilator is immobilized and so forth. So depending on the hemodynamic status of the patients, I would look and see whether there's a need for thrombolytic therapy, or could I just carry on with an anticoagulant therapy. And if bleeding risk is deemed to be too high, now we have a pulmonary embolism shock team, which may do a percutaneous thrombectomy as well. We're using angiojet. So much depends on the hemodynamic status of the patients then.
Dr. Jairam, if I take a question further, how common it is for a patient who came in a situation with an acute MI and he's got a proximal cardiogenic shock and proximal lesion, and not to be an anticoagulation, and for that matter, not to be any low-level heparin for DVT prophylaxis. So in that situation, if this patient is on anticoagulation and he for a few days, and then he was on a DVT prophylaxis with a fondaparinux or low-level heparin, how common it is such a patient develop a venous thromboembolism?
So in our center for the last 10 years, none, sir, none. Thankfully so, yes.
So I had a patient who was 88 years old lady, presented with acute entry wall MI, hemodynamically stable. We did primary PCI. She remained fine for 48 hours. Then she developed a proximal DVT. So though she was on dual antiplatelet, so once it proved that dual antiplatelet is not enough, and then we had an additional challenge in this 88 years old lady to give her anticoagulation. So all we could do is we gave clopidogrel and some small dose like AF, like we treat an AF patient. So we gave some rivaroxaban, and that's what we did. That was the only option we could do. But it was unusual. She is not completely mobilized in that sense. She was hemodynamically quite stable. Still, she developed. So it can happen, and your question has been excellent in that regards. Yes, it is a very complex situation.
Yes.
So we have people. We have
Sorry,
people from Dubai. We have people from Singapore, and we have people from another part of Emirates. How much would you like to continue full hemoglobin heparin after primary PCI? How duration? Because you have a patient with a primary PCI and you did a multivessel PCI for him in the primary set. What would be the duration of full anticoagulation for him inside the hospital?
Dr. Tan will tell his experience in this.
Is this complicated by DVT in this scenario or
no? No, in a general routine scenario.
If it's general, there's no anticoagulant therapy after the primary PCI in Singapore. So it's just dual antiplatelet therapy, sir.
I see. In our hospital, we usually give 48 hours because so it's like a patient with an acute MI. And even if you open the artery, we believe the thrombotic burden remains for this patient. So all patients they receive 48 hours full anticoagulation. And then till the time hospital discharge, which we usually 72 hours, they will receive a low dose prophylactic dose.
I remember long ago there was this trial called the Entices trial where they randomized patients to receiving anticoagulant versus no anticoagulant after a PCI, and it turned out to be no difference. And that's why routine anticoagulation is not something that is in any of the guidelines.
That is true, and that reduces a lot of other complications actually. So in the routine anticoagulation, Dr. Jairam, I can see some questions from the audience. Can you take that question?
Yes.
And present?
So Dr. Mishra has asked, with extended anticoagulation, for how long would you like to give it, sir? And would you like to give it lifelong? I think the question is for Dr. Gaba.
Yes.
So thank you, Jerem, for this question, and thank you, Dr. Mishra. I think probably what we are talking about, the extended VTE treatment, of course, if, like as I said in my presentation, the two things we have to remember. First of all, if it's a recurrent VTE, it's kind of lifelong treatment, unless there is a risk of bleeding, okay? Number two, if there is antiphospholipid syndrome, again, it's a lifelong treatment. Now, for any other conditions, if you have any other indication for anticoagulation, for instance, atrial fibrillation, you have valve replacement, for any other reason for anticoagulation, again, it's going to be lifelong as well. Okay. So now then we left with the patients who are very high risk. You have extended the treatment, whether the risk is persistent. So if the risk is persistent, as we talked about the cancer patients, for instance, okay, so the risk is still there. You still have an option of extending the treatment until their life, obviously life expectancy. The other patients are there. Somebody said about obesity. So obesity is a kind of risk factor which might be it might be transient, might be persistent. So if you lessen your risk by exercise and by diet and all that, then maybe you don't need to extend it for your life. Okay, so it depends on your risk profile in the instance. So at 6 months or at 1 year, you assess your risk again. There are some tools which I mentioned, like D dimers, you can check it as well at that stage. Okay. You can also do an echo. You can also check the weight of the patient and what's the risk profile of both the recurrent risk of VTE and the bleeding risk as well. And then assess whether you want to extend it further or not. I hope I answered the question.
As a follow-up questions to Dr. Gaba, so then what is the role of aspirin as a secondary prevention therapy?
So like again, like as I mentioned in my talk as well, so there have been some studies on the extended VTE treatment for aspirin as well. Okay, so I have shown in my studies that the DOACs have proven to be similar risk profile in terms of bleeding, okay, but better risk or better in terms of protection from VTE. So if at some stage, let's say 6 months, 12 months, or even after a few years, you find out that your risk of VT is not gone altogether, but you don't want to risk it by keep taking the DOACs, okay? you can go for aspirin as well. That's a personal choice. That's the choice which you would take, either to stop it completely or go on aspirin lifelong. Especially if there's an indication for aspirin for any other reason, I would say this is even more easy. So let's say you have a heart patient. We have eminent speakers here from the cardiology cardiology field. If you have an indication for aspirin, you might opt for, rather than going for aspirin plus DOAC, you just go for aspirin.
Or vice versa, you could just go for NOAC and or
Yeah.
DOAC and don't give aspirin. You know, the current
Because if you take both,
guidelines.
you might be increasing your risk of
Yeah.
bleeding.
I think what the European Society says that you have to assess the risk on a periodical basis, and
Yes.
minimum they said that every yearly minimum, and you have
Yes.
to assess the risk of bleeding. If the risk, like you said, is more than 4, then you will have to prematurely terminate it.
Absolutely, absolutely.
And if you developed, thromboembolic risk either in the form of deep venous thrombosis or a pulmonary embolism, sir, in a patient, let's say, who's on dual antiplatelets, this is a question for Dr. Tan. Would you want to change? Nowadays the standard of care is ticagrelor. Would you consider changing ticagrelor to, let's say, clopidogrel in these patients if you had to give them an oral anticoagulant, sir?
So in the patients that requires potentially a triple antithrombotic therapy because of a PCI and some other conditions like pulmonary embolism or DVT or atrial fibrillations, I need to know the event occurrence. So in the beginning part of after a PCI, I think the risk of thrombosis is higher. In the latter part after PCI, the risk of bleeding is higher. So I think if we can keep the antithrombotic therapy, triple antithrombotic therapy for a short period of time, particularly within the first 1 month, and then dropping one of the antiplatelet, which most likely is going to be aspirin, and then continue on dual antiplatelet therapy, you actually will be able to balance the risk of bleeding versus ischemia here. In this sort of situations where you want to add on an anticoagulant therapy, I think the potent P2Y12 of ticagrelor and prasugrel should not be used as in the ESC guidelines. So I will stick on with a clopidogrel plus one of the NOAC for patients who require anticoagulant and antiplatelet therapy after PCI.
Absolutely, which is what I think is being followed here too.
Yes,
Dr.
I think this will
Amrish?
Professor. Yes, thank you very much, Dr. Jairam. And we have received a signal from the organizers. Now the time is up for our show, and there are the next sessions. So really, I would like to thank all of you, each one of you, on the behalf of Dr. Mittal, Dr. Jairam, Dr. Wakargawa, Dr. Huai, and welcome to you to Singapore from Middle East. It's a very long distance. Now it's in Singapore is somewhere like 12 o'clock in the midnight. Yeah.
I don't know. It's 4 hours ahead of you. So
yes, it's a long time. Thank you very much for joining us.
Thank you, sir.
Thank you so much. Thank you, Dr. Tan. And Dr. Robert Jill, I think he was very busy, so he had to leave. He's not in the forum now. So I do appreciate all your efforts, all the moderators also. Personally, I thank you for coming up in a short notice. I only invited you a week before. So thanks for your participation. Thanks, Dr. Waka. Thank you, Dr. Tan. Really a pleasure to see you.
Thank you, everyone.
Thank you so much. Thank you.
Thank you also.
Bye-bye.
Thank you. Bye. Good evening. We are on to the next session, the second last session of Shakeheart 2021. And I wish to invite the moderators, chairpersons of this session. We have Dr. Pandey. Dr. Pandey is a well-known cardiologist in this region, in Dubai, in Sharjah, for about 2 decades, I would say. We have the second moderator, Dr. Samir Kaka, is my colleague, a friend, a wonderful cardiologist, my next door neighbor in the hospital, and a very lovely person. Welcome. And we are also expecting Dr. Haigriv Rao. He is a cardiologist, very senior cardiologist and electrophysiologist of excellence. He's in Hyderabad, and I am hoping to see him. I didn't see him yet, so he may be joining us soon. So now the floor is with the moderators and with the speakers. So I'll take off from here, and you will start off from here. Thank you. Dr. Pandit, can you invite the first speaker, Dr. Naveed?
Yeah.
Dr. Naveed.
Good evening, everybody. We have an important session on the lipid management, which is very essential for coronary artery disease. The cholesterol management, dyslipidemia management had changed over a period of time from the days that we were medical students, and now it is. At that time, we did not have any medications or this. At present, we have a lot of choice. However, the next presentation is by Dr. Naveed Ahmed, who is a specialist interventional cardiologist in Aster Hospital, Dubai. He will enlighten us on the role of non-statin therapy in dyslipidemia management, because many of our patients do come with side effects and this. So it is an important part of management of dyslipidemia. I hand over the mic to Dr. Naveed. I am sure he is going to do a great justice to this particular topic.
Hello, I'm Dr. Naveed Ahmed, interventional cardiologist from Aster Hospital, Dubai. I'll be talking on the role of non-statin therapies in dyslipidemia management. I do not have any disclosures. As we know, cardiovascular disease is the leading cause of mortality across the world, accounting for more than 1/3 of all the deaths. And amongst the death due to non-communicable disease, CV deaths is number one cause. And in 2013, WHO launched a program with the aim to reduce mortality due to non-communicable disease by more than 25% by 2025. And the CV mortality was the focus on this. If you see this diagram, over the last 2 decades, CV mortality either have been plateaued in most of the country or with a mild increase. But in China and in Southeast Asian countries, there has been persistent rise in the CV mortality. In UAE, more than 40% of all the deaths is because of CV mortality. The recent guidelines have been more stringent regarding LDL goal. The LDL goal have been reduced significantly. If we see this diagram, the different level of risk and different goals, the low risk, the goal as per the present guidelines is 116 mg/cent. And for very high risk, the LDL goal is 55. So as per the guideline, whatever is the risk, statin remains the class 1 indication, and the dose depends on the different level of the risk. So despite of statin, it has been clearly shown most of the patients, especially of very high risk, they don't reach the LDL goal as set by the guidelines. So it has been shown more than 80% of the population who are on statin, despite of statin, they don't achieve LDL goals. So studies also done in the Gulf shows 50 to 70% of the population, despite of statin, don't reach the goal. So it has been clearly demonstrated both from primary and secondary prevention trial. The lower the LDL, lower is the CV events. So statin definitely reduce CV events by up to 35%. However, leaving 65% of the residual risk likely due to LDL not at the goal, low HDL, high triglyceride, and other factors. Also, there are a subset of population who are not tolerant to statin, who definitely don't achieve the goals. So what is there beyond statin? As per the guideline, the population, the risk group which do not reach the goal despite of maximum statin dose or maximum tolerated statin dose, the first drug to be combined is ezetimibe. And in combination of statin and ezetimibe, if the goal is not achieved, then the next molecule will be PCSK9 inhibitor. So if you see this chart, there are different molecules which reduce LDL cholesterol, which include ezetimibe, PCSK9, bile sequestrants, fibric acids, and nicotinic acid. So ezetimibe inhibits Niemann-Pick protein on the brush border of the GI tract. This reduces cholesterol absorption, and when it is added to statin, it decreases LDL cholesterol by further 20%. And this was clearly seen in IMPROVE-IT study. It was a randomized study, compared simvastatin alone versus combination of simvastatin with ezetimibe, and it was followed for 2.5 years. It was clearly shown LDL was significantly reduced in combined arm versus simvastatin alone, and this was translated to mortality benefit and CV event reduction. Hence, the benefit of statin was extended to non-statin drug as well. Despite of this, still there is good population who require additional cholesterol lowering molecule, which include familial hypercholesteremia, high or very high risk population, and statin intolerant population. The next molecule is PCSK9 inhibitor. These are monoclonal antibodies. They target and inactivate PCSK9 in the liver, dramatically reduce LDL. So currently, alirocumab and evolocumab are the two PCSK9 inhibitors approved by FDA and available in use since 2015. So the chart clearly shows both the molecules have to be administered subcutaneously once in 2 weeks. And if we see the biology of LDL and LDL receptor, the message for LDL receptor synthesis enters from nucleus to Golgi apparatus, where LDL receptor is synthesized and it reaches the surface. And LDL receptors, when like LDL binds with this LDL receptors, internalized, and LDL is finally metabolized in the lysosome. LDL receptors are recycled back to the surface, again available for the LDL. So PCSK9 is another protein which is synthesized in Golgi apparatus and released into circulation. And this PCSK9, when it binds to LDL receptors, this directs destruction of LDL receptors, and hence the receptors are not recycled back, and it decreases the half-life of the LDL receptor, thereby increases the LDL in the circulation. So this PCSK9 monoclonal antibodies, they bind to this PCSK9 molecule. Thus, they prevent the binding and destruction of LDL receptor, increase the longevity of LDL receptor, thereby decreases the LDL in the circulation. So the effect of PCSK9 in addition to statin have shown clearly that it decreases LDL by further 50 to 60%. And the clinical safety and efficacy of PCSK9 has been clearly demonstrated in OSLER 1 and OSLER 2 studies. There are two important trials which addresses the CV mortality benefit of PCSK9. The first is Fourier trial. This trial uses this compares evolocumab versus placebo in addition to statin. So the population include ASCVD patients who did not reach the goal of LDL 170 milligram or non-HDL 100, despite of maximum tolerated dose of statin alone or in combination with ezetimibe. The primary endpoints were composite of CV death, MI, stroke, hospitalization, or coronary revascularization. So the chart clearly demonstrates that evolocumab had significant reduction in LDL as compared to placebo. The reduction started right at less than 4 weeks, and it maintained persistently. And this was transformed into mortality benefit and CV event reduction. The second trial is Odyssey trial, which utilized alirocumab compared to placebo. The studied population included patients with acute coronary syndrome or unstable angina in the last 1 year who did not reach LDL goal of 70 or a non-HDL of 100 despite of maximum tolerated dose of statin. And the primary endpoints were composite of death from coronary artery disease, MI, non-fatal MI, or unstable angina requiring hospitalization. So the chart clearly demonstrates there was significant reduction of LDL in alirocumab versus placebo, and the reduction started less than 4 weeks, and it persistently continued to maintain that way. And this was translated to mortality benefit and CV event reduction. So the next molecule is inclisiran. It is the first and the only molecule that utilizes small interference, siRNA, mechanism of action to lower LDL cholesterol. Inclisiran mimics the body's process of RNA interference to increase LDL receptor on the liver, thus increasing LDL clearance from the circulation. The mechanism can be demonstrated in this diagram. If you see PCSK9 messenger RNA, after synthesized in the liver, enters into Golgi apparatus where PCSK9 is produced and released in circulation. So inclisiran acts at a messenger RNA responsible for PCSK9. It interferes this, thereby prevents PCSK9 synthesis and increases the life of LDL receptors. This molecule has been studied across various trials, which is called as ORAN program, phase 1 to phase 3. The safety and efficacy has been clearly proven. So phase 3 trial ORAN 9, 10, and 11 include the population of familial hypercholesteremia, ASCVD, and ASCVD risk equivalents. These three trials is 18 months double-blind randomized placebo-controlled trials, which studied inclisiran versus placebo 1:1. So the subject received a drug or placebo at day 1, day 90, and subsequently every 6 months for 18 months. The primary endpoint studied were percentage change in LDL from the baseline. So in all the three trials, it was clearly shown inclisiran significantly reduced LDL. There are two relatively new FDA-approved molecules for familial hypertriglyceridemia, lometabide and mipomersen. Lometabide is MTP inhibitor. Mipomersen is lipoprotein B synthesis inhibitor. So if we see the VLDL synthesis and metabolism, ApoB proteins conjugate with triglyceride in presence of MTP, and VLDL is synthesized, released into circulation, which is ultimately converted to LDL, which is highly atherogenic. Lometabide inhibits MTP, thereby decreasing VLDL in the circulation and LDL. Similarly, mipomersen inhibits ApoB protein, again decreases VLDL and LDL in the circulation. So lometabide is indicated in homozygous familial hypercholesteremia. It's an oral molecule given at the starting dose of 5 mg once daily, increase up to 60 mg. So phase 3 trial have shown it reduces LDL by 50% from baseline. Similarly, mipomersen, it's given subcutaneously once weekly, and phase 3 trial have shown it reduces LDL by 20%. The most recent oral molecule is bempedoic acid, recently approved by FDA in February 2020. It is molecule which inhibits the synthesis of cholesterol, similar to statin, but at higher level, at ATP citrase level. By inhibiting cholesterol, it increases the LDL receptors, thereby increases the LDL clearance and decreases the LDL in the circulation. It is given at the dose of 180 mg once daily, either alone or in combination with ezetimibe. So the safety and efficacy has been studied in various trials. The most recent trial is CLEAR's trial, which is a randomized double-blind placebo-controlled study to assess the CV outcomes. And it is like by 2023, the trial is going to come out with the results. How about triglyceridemias? So different drugs which lower triglyceride include fibrates, nicotinic acid, omega-3 fatty acid, and statins. So hypertriglyceridemia is considered to be one of the most difficult lipid disorder to evaluate and treat. The reason being, it is mostly not monogenic, and acquired disorders are plenty. And triglyceride particles, the association of triglyceride and ASCVD has not been very clearly demonstrated. And if you see, these are the various trials, and which has shown reduction in overall MACE events by reducing hypertriglyceride level. So with this trial, what is the conclusion we can draw? So fibrates do not reduce CV events in high-risk groups. The impact of hypertriglyceridemia on CV outcome remains unclear. Post hoc analysis indicates that high risk with triglyceride more than 200 may be more likely be benefit, and the amount of triglyceride lowering may not predict benefit, but VLDL may be a better predictor. And what about the HDL trials? So definitive HDL cholesterol outcome, two important trials to mention is AIM-HIGH and HBS Thrive 2. So in AIM-HIGh, it was studied like two population with niacin compared with statin versus statin with niacin. So addition of niacin to statin, which increases the HDL, did not show any benefit in terms of CV reduction. Similarly, the second trial, HPS2 Thrive, studied a statin versus statin plus niacin and laropilprant. Laropilprant is an agent which decreases the side effect of niacin. So this did not decrease the CV events. So isolated elevation of HDL may not benefit. So most triglyceride lowering therapies are associated with the failed CV outcome. However, recently, omega-3 fatty acid is gaining more importance, which is demonstrated by two trials, JELIS and REDUCE-IT. So JELIS trial clearly demonstrated addition of omega-3 fatty acid, icosapentaenoic acid, to statin versus statin alone. There was significant reduction in CV events in the combined arm versus statin alone. So most recent trial is REDUCE-IT, which was which was released in 2019. And it also studied statin versus statin in combination with omega-3 fatty acid. So there was definite reduction in MACE events, CV death, and MI. So to summarize, statin remains still the first line of management for dyslipidemia and CV event reduction. However, there are non-statin based therapy which are also involved, which are also the next line of management for dyslipidemia, are also reduce the CV event, which include ezetimibe, PCSK9 with omega-3 fatty acid and fibrates plus minus benefit, and niacin, which has not shown any benefit. The most recent drug are in trials which are yet to prove the CV benefit by reduction in LDL. Thank you.
This was an excellent lecture by Dr. Naveed. Dr. Brajesh will now introduce Dr. Murali for his lecture. Dr. Murali is going to...
Dr. Samer.
Okay. Go ahead, sir.
Good evening, everyone. Hi, Dr. Brajesh. Hi, everyone. Hi, Dr. Abhay, Dr. Murali. Yeah. My name Dr. Samer from Midcare Hospital, Dubai. First, I would like to thank Dr. Brajesh Mittal for this really nice and organized event as usual. Dr. Mittal is a friend of mine, so I know exactly how much. Second, don't want to waste time. Dr. Murali, how are you? I came to know Dr. Murali since maybe 8-9 years in this town, in this city, and he was always a friend of mine. Always I was referring patients to him. Dr. Murali, I want just to introduce him. He is a specialist interventional cardiologist working in Dubai in Prime Hospital. Very nice to introduce you today. Always I was asking him how much we should reach the LDL level. Now I think he will answer this question. How much low we should go to to see the LDL. The mic with you, Dr. Murali. You are welcome.
Thank you. Good evening, everybody. Today, my topic for discussion in this important Shakeheart conference is LDL. How low should we go? We all know that the plaques in arterial walls of patients with atherosclerosis contains large amounts of cholesterol. And we also have very robust evidence in both primary and secondary prevention, but especially in secondary prevention, where we have enough and more evidence to prove that cholesterol lowering leads to a consistent reduction in the total mortality and recurrent cardiovascular events in men and women. LDL-C reduction is presently the focus in cholesterol treatment. The 2019 guidelines have incorporated more aggressive target LDL-C goals in high and very high risk populations. And we also know that now LDL-C reduction can be achieved with or without statins, with evidence for the new molecules. Now, the more aggressive target LDL-C levels were incorporated in the guidelines based on several new studies with new molecules, especially the PCSK9 inhibitors. Now, in secondary prevention, there is a significant reduction in cardiovascular events, cardiovascular deaths, and all-cause mortality in men and women. And it is also proven that aggressive lowering causes regression of plaques in coronaries or in other arterial walls. The numbers needed to treat to prevent a non-fatal MI or a CSD death was very significant, between 12 and 34 in various studies in the 1990s and early 2000s. In spite of treatment aggressively with statins, which includes very high doses like atorvastatin 80 mg and rosuvastatin 40 mg, we have what is called as a residual risk. You can see in this slides that in spite of a very robust decrease of 44% of total LDL in the Jupiter trial with rosuvastatin, there was a significant residual risk, or patients who were not at target who had their risk not mitigated by this amount of statin dose. The same is true with all the other statins. Now, what is atherosclerotic cardiovascular disease? It can incorporate the major risk factors like cigarette smoking, elevated BP, LDL-C, hemoglobin A1C, calculated 10-year ASCVD risk. It can also include diseases which includes stroke, transient ischemic attack, documented CAD, acute coronary syndromes, coronary or other arterial revascularizations, peripheral arterial disease with or without claudication, and aortic aneurysm. Now, it also incorporates the risk-enhancing factors, namely family history of premature atherosclerotic cardiovascular disease, persistently elevated LDL-C levels more than 160 mg/%, the metabolic syndrome, chronic kidney disease, chronic inflammatory disease, the high-risk ethnic groups, namely South Asians, persistent triglyceride elevation, increased CRP, lipoprotein A of more than 50, and ApoB more than 130, with an arterial brachial index of less than 0.9. Now, these incorporate the high risk and the very high risk categories. Now, it is these cohort, or it is this cohort, or these various cohorts of patients who need a very significant lowering of LDL. And how much low can we go? And what is the benefit? And what is the trade-off? Now, the European Society of Cardiology, I'll just briefly go through the main recommendations. The first and foremost is that we have a 1A level of evidence in secondary prevention, namely in secondary prevention for patients at very high risk. I'll come to what is this high risk. An LDL-C reduction of more than 50% from the baseline value, and it is not all, it is, and you should have a more than 50% LDL reduction. Also, the LDL-C goal of less than 1.4 millimoles per liter or less than 55 milligrams per deciliter should be achieved. In primary prevention, for individuals at very high risk, but without family history, again, it should be a reduction in LDL of more than 50%. Also, the goal of less than 55 milligrams per deciliter should also be achieved. In primary prevention for individuals with family history at very high risk, again, the same recommendation, but here the level of evidence is 2A, C. So with patients with atherosclerotic cardiovascular disease, which I enumerated in the earlier slide, who experience a second vascular event within 2 years, not necessarily of the same type as the first event, while taking maximally tolerated statin-based therapy. An LDL-C goal of less than 1 millimoles per liter or less than 40 milligrams per deciliter may be considered. So if a patient had a bypass surgery, say, within 1 year back, and if he had another event which warranted an angioplasty because of an acute coronary syndrome within the next 2 years, then his LDL-C level value should be less than 40 and not 55. And in patients at high risk, an LDL-C reduction of more than 50%, so it's very high risk I was talking about, is the 1A level of evidence. And for high risk, the level of evidence is less than 1.8 millimoles or less than 70 milligrams. Also, in individuals at moderate risk, you should maintain a value of less than 100. And in low risk, you should maintain a value of less than 116. Now, what are these low risk, moderate risk, high risk, and very high risk categories? The treatment goals for low density lipoprotein cholesterol across categories of total cardiovascular disease risk, which can be calculated using the European Society score or the atherosclerotic cardiovascular disease score. If it's low risk, the value of LDL should be maintained below 116. If it's moderate risk, you maintain the LDL below 100 milligrams. And moderate risk includes those patients who have a score of more than 5 and less than 10, and markedly elevated single risk factor, in particular total cholesterol more than 310 or LDL more than 190 with a BP of more than 180 by 110, and family history without any other major risk factors. This is the I'm talking about the high risk without any other risk factors, moderate CKD, the diabetes mellitus without target organ damage, and duration more than 10 years or other additional risk factors. And the very high risk has already been enumerated. The people who have the atherosclerotic cardiovascular disease who fall under that, who have a score more than 10%, who have a family history with another major risk factor, that is a strong family history with a high LDL more than 190, or a strong family history with a hypertension, or a strong family history with a diabetes. Severe kidney disease and diabetes with target organ damage and more than or equal to 3 major risk factors. Or if you have an early onset type 1 diabetes of more than 20 years duration, you automatically become a very high risk category. And then your target becomes 55 milligrams per deciliter. So the recommendations for pharmacological LDL-C lowering in these categories has already been enumerated. And the recommendations now include, in addition to statins, 2 other drugs, namely one is ezetimibe, which is an intestinal cholesterol absorption inhibitor, and in addition to statin, and also the PCSK9 inhibitors, which further reduce the LDL levels. So for the class recommendations are namely 1A and 1C for secondary prevention, as well as for the very high risk family history patients. Familial hypercholesterolemia patients with ASCVD or any other major risk factors. So in addition to statin, now we have ezetimibe and PCSK9 inhibitors to achieve these very stringent target LDL-C goals. I will just enumerate one study about the PCSK9 inhibitors because it is these studies where we found that we could achieve a very low LDL level safely, well tolerated by patients without the some issues of statins, and who had a very good long-term prognosis. Now, I'm talking about alirocumab. I'm just using one of these PCSK9 inhibitor studies. It's called the Odyssey trial. The hypothesis of this study was to compare assess the hypothesis that treatment with alirocumab, which is a PCSK9 inhibitor, compared with placebo, would result in lower risk of recurrent ischemic cardiovascular events in patients with ACS within the preceding 1 to 12 months, and with pre-specified elevated levels of atherogenic lipoproteins, despite high intensity or maximum tolerated dose of statin therapy. So the inclusion criteria was age more than 40 years, hospitalization for acute coronary syndromes. LDL was more than 170 milligrams per deciliter. And these were the groups who were randomized, and they already were on atorvastatin 40 to 80 or rosuvastatin 20 to 40. And it was the maximum tolerated dose of statin. The ACS patients were either randomized to alirocumab subcutaneous once every 15 days or placebo subcutaneous once every 15 days. The run-in period was 2 to 16 weeks on high intensity or maximum tolerated dose of atorvastatin or rosuvastatin. If they did not achieve the target LDL, they are supposed to be on this drug. The primary endpoints were CSC death, non-fatal MI, and there were many specified secondary endpoints. Now, the target of LDL was between 25 to 50, and the acceptable range of LDL was between 15 to 25. Okay, so all these patients who had a LDL level more than 70 were targeted to have an LDL between 25 to 50, and even the acceptable range of 15 to 25 were achieved by many. Below 15 milligram per deciliter of LDL was the below target level. Even that was achieved by many. The LDL-C levels over time compared, this was the placebo and this is the alirocumab, we could see that they had achieved even 38, 42, and 53 over the months since randomization. Okay, so they maintained a level below 50. Now, composite primary and secondary endpoints, you could see the p-values were significant in most of the secondary endpoints as well as in the primary endpoint. And the adverse analysis in patients who are already on statin with alirocumab or already on statin or other drugs with placebo, if you see the adverse effect analysis, there were absolutely no difference in any of the major side effects compared with placebo if you add alirocumab, and that too, and also if you reduce the LDL from above 70 to below 50. The laboratory abnormalities were also very much comparable. So this drug per se did not cause worsening of any of these laboratory parameters, which includes the liver enzymes, the total bilirubin, the creatine kinase. Also, reducing the LDL per se, the absolute value of LDL did not have any effect on these parameters. Also on these side effects, including neurocognitive and hepatic disorders. So the summary was that the main thing is that the absolute benefit of with respect to the composite primary endpoints on those patients who had a higher baseline LDL level was much more better than those who had a lower baseline LDL level. And the major thing is that the incidence of adverse effects was similar in both groups. So, as you all know, high intensity statin therapy is either the highest dose of atorvastatin 40 to 80 or rosuvastatin 20 to 40, and an LDL lowering of more than 50. Now, what are the concepts or takeaway from these new ESC guidelines and also the new data from these new trials? Even extremely low LDL cholesterol levels are associated with incremental cardiovascular benefit with no additional side effects. The cardiovascular risk reduction is driven by LDL-C lowering regardless of lipid lowering drug used. The therapeutic planning is crucial to achieve objectives. To attain new LDL-C targets require high-intensity lipid-lowering therapy, and the high-intensity lipid-lowering therapy may or may not include statins. We just a slide to tell you that how much you can achieve by a treatment with high-intensity PCSK with ezetimibe. It's almost an 85% reduction from the baseline of the LDL. And even a high-intensity ezetimibe itself causes 60. And high-intensity with PCSK9 alone causes a 75% reduction in LDL-C level. So in conclusion, lipid-lowering therapy remains the cornerstone for risk mitigation. The use of non-statin drugs are also very much acceptable because now the target is LDL-C lowering, absolute LDL-C level. And you have to consider the atherosclerotic to cardiovascular disease spectrum while deciding on LDL-C levels. In the very high and high risk, you may need to use the use of additional non-statin drugs, namely the ezetimibe or the PCSK9 inhibitor. Thank you very much.
It was a great lecture from Dr. Murli. Now I have pleasure to invite the chairman of this Congress, my dear friend Dr. Brajesh, who is the president of Cardiological Society of India Emirates branch, who is deputy director with the Aster Group, and he is an cardiologist par excellence. And a lot of credit goes to him for initiating academic activities. In last 10 years, he has conducted so many seminars. He is going to tell us about a non-ideal management mitigating the residual CV risk. He is an excellent speaker, and he will make us very, very add to our knowledge as usual. Dr. Brajesh, please.
Thank you, sir. Good evening, respected chairpersons, fellow colleagues, friends. This is my great pleasure to be in front of you once again. And I'm going to talk about non-HDL management and mitigating residual cardiovascular risk. We know about the global burden of cardiovascular disease and importance of LDL cholesterol lowering. We should look beyond it in the form of atherogenic dyslipidemia. The management of residual atherogenic dyslipidemia and non-HDL cholesterol is of utmost importance, which we want to learn through this short presentation, and the role of hybrid therapy, role of omega-3 ethyl esters, guideline reviews, and take-home messages. So we are all aware that cardiovascular disease is the #1 killer, and at least 45% mortalities in Gulf region also is attributed to cardiovascular disease. And despite achieving LDL cholesterol goals, patients remain exposed to a high residual risk of major macrovascular events, and lowering LDL cholesterol by 1 millimole per liter still with the statins reduce major cardiovascular events by 23%, and still 77% residual risk remains. In this CTT meta-analysis, it was shown that 22% cardiovascular risk reduction following statin therapy is achieved. So what about the 78%, which remains unaddressed? Even aggressive lipid lowering does not lead to further great decline in the major cardiovascular event rate. In TNT trial, it only changed from 11% to 8.7%. So there was not a very, very big further reduction in the 5-year major risk with between 10 milligram and 80 milligram dose. Macrovascular residual risk is even greater in patients with type 2 diabetics and those who had established cardiovascular disease. And this event rate for major coronary events in secondary prevention trials was in diabetic patients was shown to be much higher as compared to the placebo group. So based on so many statin trials, it was concluded that despite the benefits of LDL cholesterol lowering by statins, between 56 to 85% residual risk remained. So then we have to think and act differently, and we have to think beyond LDL also, and that is how the term non-HDL cholesterol comes into force. So what is non-HDL cholesterol? Any HDL cholesterol is, we can label it as anti-atherogenic lipoprotein, and rest of it is all atherogenic lipoprotein, which include LDL cholesterol, intermediate density lipoproteins, VLDLs. And to calculate non-HDL cholesterol, we just need to subtract the HDL cholesterol from the total cholesterol, which automatically include all atherogenic lipoproteins. So what are the advantages? Non-HDL cholesterol includes an assessment of all ApoB containing lipoproteins, which are considered to be atherogenic. And the practical advantage is that it does not necessarily require fasting. It can be easily calculated, and it is inexpensive. It is just an equation, and it can be used even in patients with triglycerides more than 400 milligram per dl. There is a clear importance of residual lipid risk, and we need to address it, and we'll need to look beyond LDL cholesterol. Triglycerides are an important contributor in macrovascular residual risk. In PROVE-TEMI-22 study, despite achieving LDL cholesterol less than 70, if those group of patients who were having more than 200 triglycerides versus those who were having less than 200 milligram triglycerides, there was a clear difference in the event rate, although their LDL cholesterol was well controlled and less than 70. So it means it was not enough only to get to the target of LDL cholesterol. And similarly, this also applied to HDL cholesterol. Even if you control your LDL to the target of less than 70, but if HDL is low, the event rate of major events in over 5 years remained higher in the quintile, which was having low HDL compared to those who were having high HDL. So after we complete our first target of LDL cholesterol, our first element, we need to look for triglycerides and HDL also. The expected clinical benefit of LDL cholesterol lowering therapies is incremental if you continue to increase the number of medications, though still it does not reach to the total or 100% level. So the question is it only about LDL cholesterol? Answer is no. The atherogenic dyslipidemia triad include LDL, small and dense, triglycerides, and low HDL cholesterols. The prevalence and importance of atherogenic dyslipidemia must be understood well. It is a highly prevalent condition. Despite statin therapy, the proportion of patients with triglycerides, high triglycerides, or low HDL cholesterol abnormalities in this disease study was between 25 to 35% or up to 44%, you can say. So atherogenic dyslipidemia is generally undertreated and under-controlled and not looked for properly. When we practice, we just see the LDL levels and we feel satisfied that LDL is controlled, so everything is fine. So we need to reduce risk beyond LDL cholesterol lowering, and there are evidences and recommendations for additional medications like fibrates and omega-3 ethyl esters. So these medications, especially the fibrates and long-chain N3 fatty acids we call omega-3s, they're especially useful in reducing non-HDL cholesterols, and they are useful in reducing the triglycerides, and to some extent also help in increasing the HDL cholesterol. Fenofibrate is one of the fibrates. It has lipid modifying effects. It reduces triglyceride levels. It increases HDL cholesterol levels. And besides, it also causes a change in LDL particle phenotype. It induces a shift from small dense LDL particles towards larger LDL particles. The combination of fenofibrate and statin improves complete lipid profile, and it causes a much better and greater reduction in triglycerides and a clear increase in the HDL shown by the Safari trial. And the combination improved goal attainments. The combination treatment reached to the goal attainments. Number of patients who reached to the goal was much higher as compared to the people on monotherapy. So combination also shown to improve cardiovascular outcomes in type 2 diabetes mellitus. In patients who were having high triglycerides and low HDL, the major cardiovascular events were lesser in the group who were additionally given fenofibrate as compared to the placebo where there was no change. So there is no safety concern with this particular combination, fenofibrate and statin being given together, and fenofibrate does not influence the metabolism or pharmacokinetics of statins. The next important group of agents are omega-3. So we know that there are 3 types of fatty acids in the body, and we are talking here about saturated, monounsaturated, and polyunsaturated fatty acids. So polyunsaturated fatty acids can be derived from the plant source or from the seafood, animal source, you can say. These are not very effective in day-to-day treatment, while the N3-PUFA means seafood-derived polyunsaturated fatty acids. They are of three types: EPA, DPA, and DHA, and these are the ones who are useful in the clinical value of reducing the triglycerides and increasing the HDL, besides other important actions in the form of membrane stabilization, anti-immunity, providing better immunity and resolution of inflammation. So adding EPA and DHA combination to simvastatin helped in achieving the triglyceride target much better. The baseline and end of therapy, there was 29.5% decrease in the group which was given a combination of simvastatin plus EPA DHA combination versus given simvastatin alone. Another interesting story with an interesting name is a romantic study in which EPA DHA 4 grams per day was given on the background therapy of rosuvastatin 20 milligram per day. It was also a randomized controlled trial, and the combination of N3 plus rosuvastatin reduced triglycerides to a far greater extent, and the non-HDL cholesterol was also reduced far better as compared to rosuvastatin alone. This led to impact on outcomes, and in other specific study of GC prevention trial, there was also shown a marked reduction in sudden cardiac deaths and all deaths besides cardiovascular, cardiac, and CHT deaths in the patients who were given EPA DHA 1 gram per day soon after the acute myocardial infarction. In this post-MI study, it clearly showed that primary outcomes were in favor of EPA DHA combination. And based on this criteria, it was indicated, it is in the guidelines, that all patients should be given EPA DHA 1 gram per day within 90-day post-MI. It causes a consistent reduction in all-cause mortality based on the GCP trial. Yet another very important landmark study was the REDUCE-IT trial, which came very recently, about a year and a half back. And this is known as reduction of cardiovascular events with icosapent ethyl intervention trial. In this trial, the primary endpoint of cardiovascular death, MI, stroke, and coronary revascularization, unstable angina, they were significantly reduced when the patients were given icosapent ethyl ester at a dose of 4 grams per day. And it was very significant reduction from 28 to 23%. So 25% reduction in primary endpoint was seen in REDUCE-IT trial, which was a huge reduction. And those all then came into the guidelines. So current recommendations in the European guideline, for example, is that patients with hypertriglyceridemia, the statin therapy is still the first drug of choice. But in high-risk patients, if their triglycerides are still high, despite statin treatment, they should be given an N3-PUFA, icosapent ethyl 2x2, means 2 capsules twice a day, over statins. And in primary prevention patients who are at LDL goal, you may addition, and with still high triglycerides, fenofibrate or bezafibrate may be considered in combination with statins. And in high-risk patients who are at LDL goal with triglycerides more than 200, again, this combination may be considered by adding a fenofibrate or bezafibrate. So omega-3 fatty acids for the management of hypertriglyceridemia was also came into the science advisory from the American Heart Association update. Prescription N3 fatty acids, EPA DHA or EPA only at a dose of 4 grams per day are an effective and safe option for reducing triglycerides as monotherapy or as an adjunct to other lipid-lowering agents. So friends, what are the take-home messages here and conclusions of this whole presentation? The cardiovascular disease is a major challenge. We all know that. We need to have a tighter LDL cholesterol targets, and we must achieve them by every means. And statins are the backbone of therapy. But we should look on non-HDL cholesterol also, which is a much better way of addressing the issue. And we should look for atherogenic dyslipidemia. Triglycerides have an important role in cardiovascular disease, and targeting the residual atherogenic dyslipidemia is gaining increasing interest as an essential component of anti-atherosclerotic therapy. So there are two main options to reduce triglycerides and to somewhat increase HDL are fenofibrates like fenofibrate and bezafibrate. We do not use and should not use gemfibrozil anymore, and prescription omega-3 polyunsaturated fatty acids. Both of these agents significantly reduce the added risk of fatal and non-fatal cardiovascular disease associated with residual atherogenic dyslipidemia. Many thanks for your kind attention. Thank you so much. Dr. Pandey, can you unmute yourself?
Excellent presentation, Brajesh, as usual. Heartiest congratulations. Now we have a great physician from and nephrologist from Delhi, Dr. Jain. He is a very senior nephrologist who has his own dialysis center. He's a great academician and one of the pioneers of nephrology in Delhi and India. He's going to highlight management of acute coronary syndrome in chronic kidney disease. With increase in chronic kidney disease, we have many more patients with acute coronary syndrome, and he will guide us how we should manage them. Dr. Jain, please.
Dear friends, good afternoon to all online delegates from different parts of the world. I'd like to thank the chairman and organizing secretary, Dr. Brajesh Mittal, for providing me the opportunity to discuss the management dilemmas of cardiovascular diseases in chronic kidney disease patients. As you all are aware, cardiovascular diseases are the leading cause of morbidity and mortality amongst the chronic kidney disease patients. Mortalities from cardiovascular disease in renal patients is approximately 3 times more than that in general population. As soon as the GFR decreases less than 60 ml, the probability of CAD increases linearly. This further aggravates with the increasing proteinuria at every stage of renal failure. This relationship is over and above the other CAD risk factors like diabetes mellitus and hypertension. Atherosclerotic cardiovascular events are more common than non-atherosclerotic cardiovascular events during early renal failure, and vice versa is also true. Chronic kidney disease and end-stage kidney disease masks the symptom of cardiovascular diseases at presentation. Only around 44% of the acute myocardial infarction patients presents with pain chest, neck, or arms in CKD patients, as compared to 72% in non-renal patients, making it very difficult to diagnose chronic coronary artery disease without having the high index of suspicion. Clinicians should look for angina equivalents such as shortness of breath or fatigue of unexplained origin. Intradialytic hypotension and myocardial stunning are hemodialysis specific syndromes associated with the mortality in patients of hemodialysis. Sudden shifts of intravascular volume, specifically in hypoalbuminic patients, sudden changes in electrolytes, and removal of drugs during the dialysis process adds to it. These are important reasons for non-atherosclerotic heart disease in advanced renal failure. Acute myocardial infarctions are more common than stable angina in CKD patients. And these acute myocardial infarctions are more of non-ST elevated type. And this pattern is thought to be due to the supply-demand mismatch, ischemic preconditioning of the myocardium, collateralization of blood vessels, and perhaps because of the high prevalence of left ventricular hypertrophy in patients with CKD that we can mask the ECG findings. In addition to these factors, there seems to be a lesser of the plaque ruptures with superimposed occlusive thrombosis as the reasons for non-ST elevated myocardial infarction in CKD patients. And after the kidney transplantation, non-atherosclerotic causes reduces in view of the stable and predictable hemodynamics and electrolytes. But in view of the use of immunosuppressants like steroids and calcineurin inhibitors, has more incidence of atherosclerotic cardiovascular diseases than in non-transplant patients. Whom do we screen? All patients upon initiation of renal replacement therapy, independent of the symptoms, should be screened for the CAD. Patients on the wait list for kidney transplantation, whether on the live-related donor transplantation or on a cadaveric kidney transplant program. Any changes in sign and symptoms, including recurrent hypotension, heart failure that is unresponsive to the changes in the dry weight, and hypotension that prevents the attaining of the dry weight, we must subject them to the screening of the coronary angiography. The modalities to screen the patients for CAD is same as that in the non-CKD patients. Cardiac enzymes. The appropriate use of cardiac enzyme in patients with renal insufficiency is less clear, since the elevations in cardiac troponins are commonly observed in patients with advanced renal insufficiency without acute coronary syndromes. This elevation may be indicated subclinical myocardial damage, such as transient myocardial stenting during the hemodialysis, myocardial hypertrophy. Regardless of the cause, higher baseline troponins are associated with increased all-cause cardiovascular mortality in CKD patients, and this is more strongly associated with the TROP-T than the TROP-I. Serial rise in the levels of troponins can be used to diagnose acute coronary syndromes, but the normal values may be sufficient to rule out the acute coronary syndrome. Statins. The controversy surrounds the use of the lipid-lowering agents in the patients with CKD. The benefits with the statin-based treatments become smaller with advanced renal failure and almost negligible or no response in CKD patients on dialysis. The KDIGO guidelines proposing the use of statins in CKD patients with more than 50 years of age, but not in the dialysis patient. These were based on the null studies in the 4D trial and Aurora trial. The recent studies has also shown that the PCKS9 also has a beneficial effect, that too in early stages of renal failure. We do not start statins in advanced renal failure, but if the patient is already on statins in early stages of renal failure, it is not recommended to stop these statins also. Other pharmacological management will be the same as that of a non-CKD patients. Heparin is to be used with caution because of the high bleeding risk patients the CKD patients have. The choice of medical revascularization, what are the indications for the revascularization? CKD and the choice of medical therapy alone or revascularization in a symptomatic patient with CKD and ESKD is controversial. As per the American Heart Association 2014 guidelines, revascularization is indicated in all patients who has present angina, even after optimal medical therapy, or in those asymptomatic patients who possibly have survival benefit from revascularization, like left main disease, 3-vessel disease, 2-vessel disease with proximal LAD lesions. Although observational study seems to support an early invasive over the conservative approach in early stages of CKD in non-ST elevated myocardial infarction or acute coronary syndromes. In the absence of dedicated clinical trials, all CKD patients presenting with ST elevated MI should undergo the same invasive approach as that for the normal kidney functions. Which revascularization method should be used, whether PCI or CABG? Usually we need to individualize either of the two depending on the patient, because each one is fraught with risk factors. PCI and CABG procedures are associated with the short-term risk of death, stroke, and AKI, much more than in a non-CKD patients. And these are more commoner with CABG than PCI. Long-term complications like risk of death, MI, and repeat revascularizations are more common in PCI than CABG. So we need to individualize each and every patient's which therapy is best suited for that person. We cannot have any straight rule for that. Both PCI and CABGs are associated with the higher risk of acute kidney injury among patients with CKD. Higher risk with CABG than the PCI. The take-home point is that in view of the almost negligible risk of producing contrast-induced dialysis-dependent renal failure, contrast-based diagnostic and therapeutic intervention should not be avoided in any stage of CKD, except in one circumstances, the CKD patient on peritoneal dialysis, where even a small amount of GFR is important in maintaining the good health. Recent guidelines from a randomized controlled trial endorses the transradial over the transfemoral access to reduce the bleeding risk. So CKD patients being categorized as high bleeding risk category, transradial approach certainly has the first choice for PCI. At the same time, radiocephalic arteriovenous fistulae are the lifeline for end-stage kidney disease patients who are on dialysis. And for them, it is as important as that having a good cardiac status, if not more. At the same time, radial artery grafts may also result in a better outcome than a saphenous venous graft in a CABG setting. So in view of all these things, we need to have a nephrocardio team to decide the right approach. For the PCI, if the cephalic veins of the upper limbs are patent, then we can go ahead with the dominant arm's radial arterial approach than the transfemoral approach. Radial artery of the dominant arm or arm without a patent cephalic vein can be used for grafting in a CABG settings. Limited data exists to guide the duration of dual antiplatelet therapy in CKD patients undergoing PCI. This is an important consideration because of the risk of ischemic and bleeding complications in the patients with CKD and warrants dedicated studies. Available data suggests that in the setting of advanced CKD, extended duration may be associated with the excessive bleeding risk and unclear benefits. There are also no studies, prospective or randomized controlled trials available to guide the management of antiplatelet or anticoagulation for CKD or end-stage kidney disease patient with atrial fibrillation undergoing PCI. The important highlights which I've discussed is that CAD is an oligosymptomatic in CKD. Only 44% of the patients present with these symptoms. All CKD patients need CAD evaluation, irrespective of the symptoms, before enrolling them for hemodialysis or transplantation. Pharmacological measures to treat non-CKD patients are also applicable to CKD patients. Contrast, if used with caution, will rarely lead to dialysis-dependent renal failure. Non-ST elevated MI, early risk vascularizations benefit only in early stages of CKD. ST elevated MI, revascularization, irrespective of the stage of CKD, as that in the patient without CKD. The choice between the PCI or CABG needs to be individualized. Transradial approach is preferred site for the PSI, even in the CKD patients. We did additional prospective studies focusing on diagnosis, prevention, and treatment of CAD and are needed in CKD. Thank you. Thank you very much for your kind patience and listening. Thank you.
This was a great session. All these speakers have done a great job. I would like to ask some questions, and if any other audio from the audience or the panel will, they can also come forward. When we are born, our cord blood contains a total cholesterol of 100 and LDL cholesterol of 30. Is that the goal that should be we should aim for? 30 of LDL and 100 of total cholesterol as seen in the cord blood.
Whom
Maybe
are you asking to?
Brajesh, Murli or
Okay.
Brajesh.
Right. Okay. So I will answer this question. Yes, you are absolutely right. This is what we should aim for. And the CTT meta-analysis we have seen with the 97,000 patients, which came out in 2002, it showed that when you continue to reduce LDL to whatever level, up to 25 or 30, you continue to reduce the event rate, both for the CAD as well as the strokes. So we clearly know that this is a safe value. And even if you see the PCSK9 trials and inclisiran trials, especially in PCSK9 trial, they were very consistent and they maintained the level. They did not change the dose. They did not reduce the dose when LDL was between 15 and 25. So those was still maintained. The dose was only reduced when it went below 15. So it is considered to be quite safe as well as effective to have LDL as low as possible of the birth level. This is my take.
Thank you. Thank you.
Definitely, the guidelines are also saying the same now. Almost
Yes,
they are.
and that topic was configured by me, how low to go for Dr. Murli. So that was the main idea, and he presented it very well that we should really go very low.
Can I ask if there is no other? Can I ask one more question? Recently, I had two ladies. One was a Filipino lady, 56-year-old, had an HDL of 71, total cholesterol of 155, and LDL of 116. HDL of 71. And another lady who underwent angioplasty, Indian, 42-year-old, HDL of 29, LDL of again 110. So how should we manage their LDL considering the difference in HDL levels?
Sorry, I will surpass. I will take this question because you have raised a very, very important point. We are all cardiologists, and we should know one thing: the high HDL sometimes can be very, very misleading. The HDL is also of two varieties, of the lower density and the higher density within the HDL. And I have some patients who have very high HDL and they are very, very symptomatic. They are really suffering from atherosclerotic cardiovascular disease. Unfortunately, in UAE, we do not have a subfraction study of HDL. So my idea will be that if you have a very high HDL, not always we should go by the going that we are safe. And second, the LDL target should remain the same, whatever is the amount of HDL available to us. Any other comment from Dr. Murli, Dr. Naveed? Dr. Naveed, you are muted. You can unmute yourself and you can take participation.
So one question is like, are we other than LDL, are we checking like ApoB levels or lipoprotein little a? As per the recent guideline, I think like once all of us commonly see, despite of LDL control, people are still having events. So what is our next approach? I mean, like, are we looking for lipoprotein little a as per the guidelines?
Well, I want to put forth one very important thing once again, that whenever we say the ideal levels and we achieve them, we have never even conclusively proved that best ideal levels have brought down the event rate to 0%. Yesterday in the morning, I had a patient who was very well treated by me, and I had to rush to the hospital for his primary. Remember, listen that he is a known CAD patient. His current LDL is 53. He is on a lower dose of rivaroxaban as per the guidelines. He is on aspirin as per the guideline. His HbA1c is 6.3, and he had another acute MI yesterday. So it is not 100% sure that once you have treated well, there will be 0% event. It has never been shown. Yes, we reduced the event rate. So the answer to your question is that we have to tackle the LDL, yes. Then we have to look for triglycerides if they are controlled or not. We don't have much control on HDL. We cannot do much for HDL, but at least we have enough control on triglycerides. So after statin therapy, we should look for fibrates. We should look for prescription EPA or a combination of EPA and DHA, whichever you prefer, but EPA certainly currently is in the vogue. So we should try to minimize other risk factors also, not just get going by the LDL alone. This is what I would think of. And then don't assure the patient that you are reducing the risk to 0%. That is never going to happen, even if you do your best. So Dr. Pandey, with your concluding last remark, or Dr. Samir, if you want to say some remark, we can close this session for the sake of the time. And personally from me, I will thank you all the speakers. Dr. Jain, you came all the way to appear from India, and Dr. Murli is a wonderful friend. Dr. Naveed is a very wonderful friend. Dr. Samir is my next door. So thank you so much. Dr. Pandey is a very respected senior of ours in Dubai. So Dr. Pandey can finally, or Dr. Samir can finally have one word each, and we can conclude.
It was a great session. I learned a lot, and this coronary artery disease we keep on learning more and more. Lipid management is an important thing, and it's important to prevent the future coronary events. All the speakers have done an excellent job. I congratulate them, and I thank them for educating us in a very simple and nice way. Thank you.
One very special take-home message from Dr. Ramesh Jain is that do not avoid a procedure for the risk of precipitating CKD in a patient. So this is a very important lesson for us. And Dr. Samir, final word, and we stop here.
Thank you very much, everyone. Thank you, Dr. Naveed, our neighbor in another hospital.
Thank you.
Really, we learned a lot of spotlights and enlightens of these topics, dyslipidemia, which is really everyday clinic. So thank you also, Dr. Brajesh, for this nice organization of this event. Thank you, everyone. Thank you.
Thank you.
Thank you. Thank you.
Bye-bye.
Good evening. This is my pleasure to welcome you all for the very last session of this 2 days proceedings. I'm very glad to have a wonderful faculty here, and I will introduce the chairpersons. We have Dr. Robert Gigliano. He is a master in the field. He is a researcher. He is a trialist in the TB. He's a professor in Harvard and in Boston, and we are very glad to have you here as a moderator as well as a chairperson. The other moderator is with us is Dr. Anil Kumar, a very wonderful friend. He worked a number of years in UAE. Now he's in India. It's a very talented doctor, very competent cardiologist. We have worked together very closely, and I respect him a lot. We also have the other moderator who should be joining us soon, Dr. Ravi Shakeheart. So from these words, I take you forward and leave in the hands of the moderators to carry on the session further. Thank you.
Dr. Robert, good evening.
Yes, good evening. Thank you. Pleased to be connecting with you.
Yeah, please start the proceedings.
Good evening, ladies and gentlemen. First of all, I would like to thank Dr. Mittal to ask to come to give me a talk on this very important topic. Actually, we all know that we are having a global pandemic of diabetes, and the latest data which we have from the International Diabetic Association shows remarkably that globally 1 in 10 patients have diabetes, and certainly data for the Middle East shows much more higher proportion of people having diabetes. But the more important thing is that the Middle East had the largest increase in diabetes over time. For example, we can see that over next 20 to 25 years, we are expected to double the number of people with the diabetes. The thing about diabetes is that it never comes alone. Along with diabetes come with constellation of other cardiovascular risk factors. For example, 90% people are obese, and nearly 70% of people are dyslipidemic, and similarly, two-thirds of the people have arterial hypertension, and thereby emphasizing the point that diabetes management is not alone. We have to really manage the diabetic patient as a whole. A big chunk of diabetic people have some form of cardiovascular disease, and it is believed that 1 in 3 people has some form of cardiovascular disease, and there is nearly 2 to 5 times more higher incidence of heart failure hospitalization, which we can see in our clinical practice, that practically all the patients which are admitted with heart failure have some form of diabetes as a background of them. Another important thing of diabetes is a strong link with kidney disease, and nearly 40% of diabetic patients have some form of chronic kidney disease. Further, diabetes and hypertension account for 80% of end-stage renal disease across the world. And when all this combination they occur together, obviously the morbidity and mortality increases dramatically. Further of all, is very clearly seen that whatever type of heart failure we take, whether preserved EF, mid-range EF, or heart failure with reduced EF, the cardiovascular complications, they actually increase by nearly 50% if the person has underlying diabetes. So just the presence of diabetes worsens the outcome of practically all form of heart failure. And that is why over this recent trend, there is a recognition that we should have a special branch or a specialist which deal with cardiodiabetology. The function of cardiodiabetology is to focus on the science and strategies to reduce and treat the cardiovascular consequences in patients with diabetes. And this we are doing by using old and newer therapies of control of glucose, cholesterol, and the blood pressure control, thereby causing a maximum reduction in the cardiovascular mortality and morbidity. And this we have to take from the evidence medicine, that means from the information which we derive from the clinical trial. So obviously the diabetes is concerned with elevated blood sugar. So initially the people focused a little bit more about control of diabetes, because all the clinical trials showed that more higher the average sugar or the hemoglobin A1C, there is more high risk of macrovascular or microvascular complications, such as the fatal and non-fatal myocardial infarction, stroke, and the microvascular endpoint related to the kidneys and to the eye endpoints. But unfortunately, tighter control of sugars or the intensive control of sugars did not yield the expected reduction in mortality. And you can see the curves or the graphs are around the unity. And in some of the trials, actually there was worsened outcome. We will not go into it. And this is presumably because we were using older generation of drugs in these trials, which were actually causing more intense hypoglycemia. For example, the sulfonylureas, which are very powerful blood glucose lowering agent, they actually cause worsened cardiovascular mortality. So was seen in the meta-analysis of nearly 17 trials, which include nearly 250,000 population, and they found that overall cardiovascular mortality increased by nearly 2.72 times. And thereby, all the researchers started focusing, can we have newer pathways for control of diabetes? For example, people started looking at the incretin pathways, which are small hormones which are released from the gut, and they are GIP and the GLP-1. Thereby, we started using the agents which can be given in injectable form or the oral form, which are called as the GLP-1 receptor agonist or analogs. And these agents, they actually cause increase in the incretin to supratherapeutic level. So the physiological levels are there secreted from the intestines, but when you give them in the medical forms, we are actually leaving the link to the supraphysiological levels, and thereby causing probably and a better outcome. So people started doing research in the area. And second area, people started looking at whether we can focus on the kidneys by thereby decreasing the absorption of glucose from the kidneys, allowing more amount of glucose to be excreted in the kidneys. And there are a class of drugs which is called as the SGL2 inhibitors of bond, which are actually inhibiting the absorption of glucose from the kidneys and causing glucosuria, and thereby causing loss of the calories and probably improving the cardiovascular outcome. Because what was mandated by the FDA and the EMA regarding the safety of the cardiovascular trial, dozens of trials been done over these years. So it appears that over a span of 6 or 7 years, we had nearly 20 cardiovascular trials which have been conducted involving nearly 150,000 patients. So these are the clinical trials, and you can see the yellow ones are the DPP-4 inhibitors, The blue ones were SGLT, and the pink was a GLP-1 agonist. And from these trials, we can derive some data which can actually help us to make some meaningful decisions. So one of the first trials to show benefit in the cardiovascular outcome was actually called as EMPEROR trial, which was with an SGLT inhibitor, empagliflozin, and this was published nearly 5 years back in New England Journal of Medicine in 2015. The trial showed that in the high-risk population, predominantly people with a cardiovascular disease, empagliflozin causes 14% reduction in the major cardiovascular cardiac event, causes an astonishing 38% reduction in the cardiovascular death, and nearly one-third reduction in the heart failure hospitalization, all-cause mortality, and the renal endpoint. So this is a very, very remarkable and the first time a cardiovascular trial was shown with the anti-diabetic agents to have such profound impact on the mortality and the morbidity. Next year, a trial was released, which was including a GLP-1 receptor agonist, liraglutide, a trial called as LEADERS trial, and the LEADERS trials had similar outcome, which shows 3-point reduction, MACE reduction of 13%, with a 22% reduction in cardiovascular death, but no effect on the myocardial infarction and the stroke, and the all-cause death was reduced by further 15%. There was a reduction in the microvascular complication, obviously not to the degree of SGLT2 inhibitors, and more importantly, it has some additional benefits. For example, not only it lowered the glucose, a powerful agent, but it also lowered the weight by nearly 3 to 4 kilograms, and we know that most of the diabetics are overweight, and this did not cause any significant hypoglycemias and had nearly same safety profile as the placebo. So when you take the evidence in totality across the SGLT inhibitors and the GLP-1 receptor agonist, and this slide I have put in such a way that you can see all the conducted trials with the SGLT inhibitors and the GLP-1 receptor agonist, there are certain trends which appears to be coming on. For example, all these classes of drugs, they reduce the MACE, and you can see that the MACE is reduced by all the trials. With some it is more, and with some this is less. This is because difference in the patient selection in the trial. Second of all, it was seen that the cardiovascular death was reduced by only 2 agents. One is empagliflozin and one is the liraglutide. And you can see the reduction with the empagliflozin is shown by the blue one, and the reduction in the leaders and the liraglutide is shown by the orange. And this is towards the benefit side of the unity. And other agents were towards the unity line, but none of them increase the cardiovascular death. Third of all is the heart kidney endpoint. And when we say the heart kidney endpoint, we are talking about doubling of the serum creatinine and or to the end-stage dialysis. This benefit was seen only with the SGLT inhibitor. So practically all the SGLT inhibitors causes dramatic reduction in the heart renal endpoint, whereas other ones, the liraglutide and semaglutide, had some reduction with the heart renal endpoints, but not to the degree of GLP-1 receptor, to the degree of SGLT inhibitor reductions for him. One important thing, like we discussed, is the heart failure hospitalization. The diabetic people, because of indwelling cardiomyopathy and the toxic effect of glucose, whereas causing the collagen deposition in the myocardium, actually causes a heart failure increase in the patient with diabetes. And in fact, all the clinical trials, whether we take of the reduced EF or preserved EF, 50% of 30 to 50% of patients are actually diabetic in these trials. So the people started believing what is the impact of these agents in the heart failure hospitalization, and the results showed that the tremendous benefit with the SGLT receptor inhibitors. And you can see whether we take empagliflozin, canagliflozin, dapagliflozin, all the trials, there is a big shift in the curves to the left, indicating benefits in this trial, whereas those with the GLP receptor agonist are actually neutral. This encouraged actually a lot of research to look what is the impact of SGLT inhibitors in the population with heart failure, whether they have diabetes and they don't have any diabetes. So the 2 clinical trials were released recently, and one was for the dapagliflozin, which came first on the scene, which were released in the New England Journal of Medicine in November 2019, and this was the DAPA heart failure trial. And the second trial was EMPEROR reduced trial, which was released few months back in the New England Journal of Medicine. So both the agents have a big trial, including for the patients with the heart failure, and these are the population with heart failure without diabetes mellitus. So the 2 trials, 2 molecules, but you will be astonished to see the results were nearly the same in the class. And one paper which published in European Heart a few months back, by Javed Butler and Zanat, they looked at the 2 major trials for the heart failure with the reduced EF, and they said whether it's the DAPA heart failure trial or the EMPEROR reduced trial, you can see that the risk of cardiovascular death or hospitalization with heart failure are reduced by nearly approximately 25%. And the first hospital heart failure were reduced remarkably similar by nearly 30%. More importantly, you can see that the heart failure patients, they have a propensity to develop further cardiovascular renal dysfunction. The renal endpoints were reduced by nearly 30% to 50% in the population with the heart failure. And so the cardiovascular death was reduced between all randomized patients. So it was actually a win-win situation for SGLT2 inhibitors and the heart failure hospitalization. So all this data which came out with these two classes of drugs actually impelled all the guidelines to change their trend. And now practically all the guidelines, whether we have cardiovascular outcome trial guidelines or we have diabetes guidelines, they actually talk about using these agents in the practice. So you can see whether we have diabetes guidelines or cardiovascular guidelines or heart failure guidelines, they are actually updated to incorporate the results from this new evidence you have shown just now. So if you take the typical guidelines which were released in 2019, and 2019 had two major guidelines released. One was the European Society of Cardiology guidelines of 2019 on diabetes and pre-diabetes and cardiovascular disease. And the second was a summation guidelines for American College of Cardiology and the AHA. They said the guidelines now use the recommendation for the use of SGLT inhibitors or the GLP-1 receptor agonist after metformin for the Americans, and the Europeans, they say without metformin in the treatment of diabetes, and the people in which we as a clinician, we believe they have a high risk or they have a background condition of renal disease or heart failure as a background. So all these patients, they actually deserve to consider these new agents in their practice. And so was the evolution of American Diabetic Association guidelines. We know that American Diabetic Association, every year they release a guideline. So from 2016, the American ADA, they were focusing on the glucose lowering. And as the time went by, they actually incorporated the newer evidence from the trials in their practice. In 2002, they said to incorporate agents which demonstrate cardiovascular benefit are recommended independent of hemoglobin A1C. So what is the level of hemoglobin A1C? You have to incorporate these agents in the practice. And another set of guidelines which were released few weeks back by the ADA, they said these agents should be incorporated and we should actually consider specific risk factors. And so that means you should include this agent and you should consider what are the background risk factors of your patient to choose which agents to come first on board. So their guidelines are actually very simple guidelines. They say the first line therapy is metformin, provided kidney function allows, and the compressive lifestyle changes. And then you have to look for indicators for the high risk, established atherosclerotic cardiovascular disease, CKD, and heart failure. And once you find for them, you can actually choose which agent to select. For example, if your person is having high risk of atherosclerotic cardiovascular disease, you can choose any of this agent, GLP-1 receptor agonist or SGLT2 receptor with a proven cardiovascular benefit, which as of now currently remains empagliflozin and liraglutide. If this population is having heart failure, then you can use SGLT inhibitors with a proven heart failure benefit. This includes dapagliflozin and empagliflozin. And if somebody's got a CKD, then you have to look whether he's got a albuminuria or no albuminuria. In the presence of albuminuria, obviously you will prefer SGLT2 receptor inhibitors over GLP-1 receptor agonist. When we focus on diabetic population with this agent, remember diabetes risk is a sum total of many risks, which includes blood pressure and the lipid profile. So we have not to forget to focus on the blood pressure lowering. It is very important to keep the blood pressure less than 130 by 80. And for this, all the guidelines, they recommend universally to use RAS inhibitors, CCB, and the diuretics. We have to keep their LDL cholesterol, which is a very, very important component of the risk reduction, to less than 1.8. And the European people say for the high-risk population, you have to even bring down to less than 55 milligram per cent by using statin, azacitidine, or PCSK9 inhibitors. And remember, lifestyle modification keeps on the base. So weight loss and smoking cessation is a very, very important component of risk management in the patient with diabetes. With this, I come to the end of my talk and say once again, the cardiodiabetology field is an emerging field for the management, and the new specialties and the old physicians have to really focus on this. There is a huge overlap between diabetes, coronary artery disease, heart failure, and renal failure for that matter, and other cardiac conditions. Of note is heart failure and cardiomyopathy is associated with diabetic remodeling of the extracellular matrix, causing fibrosis and causing preserved EF as well as the reduced EF. One important component is serious arrhythmias and increased atrial fibrillation risk, which I did not focus in my talk because we had focused on diabetes, are under-recognized feature in diabetes, often related to high glucose variability, hypoglycemia, or excessive hyperglycemia. Third of all, choice of drug for diabetes should be based on underlying comorbid conditions such as atherosclerotic cardiovascular disease, renal or heart failure, and the need for glycemic control. With this, I really like to thank the organizers and Dr. Mittal in particular for asking me to share my thoughts with you. Thank you very much.
Am I audible? Dr. Mittal, do we have some discussion or do we go ahead to the...
We will do the discussion at the end of all the 3 lectures.
So then I welcome Dr. Robert to give his talk on anticoagulation, NOACs in type 2 diabetes. Dr. Robert?
As usual, Dr. Amrish, your presentation was excellent, and we welcome Dr. Robert here.
Hello, my name is Robert Giuliano. I'm very pleased to be invited to give a presentation at this year's Shakeheart 2021 conference. And the title of my talk is Direct Oral Anticoagulants, or DOACs, versus warfarin and atrial fibrillation, latest data by renal function and in diabetics. I was a principal investigator for the ENGAGE-AF TIMI-48 trial, which studied one of the DOACs in atrial fibrillation, edoxaban, and am a senior investigator with the TIMI study group, a cardiologist at the Brigham and Women's Hospital, and professor of medicine at Harvard Medical School. Here are my relevant disclosures, mainly related to work in clinical trials and consulting and lecturing on novel anticoagulants. I want to start by just reviewing major advances in the DOACs and atrial fibrillation. For many, many years, 50 years or more, we had only one anticoagulant to choose from, a warfarin, and those data in atrial fibrillation derived from 6 trials in between 1989 and 1993. They were actually conducted in a small number of patients, fewer than 3,000 patients. Warfarin's effective. As you know, it carries some baggage, certainly a risk of bleeding, intracranial bleeding, drug-drug interactions, food-drug interactions, etc. And so we welcome the introduction of the DOAC starting in 2009 with dabigatran, which was studied in the RELY trial, and then practically on an annual basis thereafter. Rivaroxaban was studied in the ROCKET-AF trial. The Aristotle trial studied apixaban, and then edoxaban was studied in the ENGAGE-AF TIMI-48 trial. Notice that the number of patients in these trials was enormous and far dwarfed the experience with warfarin versus placebo, with between 14,000 and over 21,000 patients in the largest of the trials, ENGAGE-AF TIMI-48, were studied in the DOACs versus warfarin. It's important to note that there are differences between the 4 DOACs. I do not consider them the same. And some of the important differences are highlighted on this slide, shown in yellow. But for the first portion of my talk, we're going to focus on the difference in renal elimination, which varies quite a bit, with dabigatran being the most renally cleared at 80% and apixaban the least renally cleared at 27%. And since edoxaban is new and new to the region, I will share with you some very interesting data, both in patients with varying renal function, but also in diabetics, specifically with edoxaban. So let's start with a discussion of patients with in relation to renal function and outcomes in the trials. And I'll start with this pre-specified analysis by the estimated creatinine clearance in subgroups from the ENGAGE-AF TIMI-48 trial with edoxaban versus warfarin. And you see the top pair of bars are the outcomes of stroke or systemic embolism in patients either below or above a creatinine clearance of 50. To the left favors edoxaban, to the right favors warfarin, and you see that the hazard ratio was identical for prevention of stroke or systemic embolism at 0.87. So edoxaban at a 13% reduction of stroke or systemic embolism, regardless of whether the creatinine clearance was above or below 50. The next line shows you major bleeding. This is a little more interesting in that the hazard ratio was slightly lower, tended to be lower in patients with lower creatinine clearance, so worse renal function. The hazard ratio is 0.77, whereas in those with creatinine clearance above 50, it was 0.91. Now, the p-value for interaction wasn't statistically significant, but I think you can appreciate that certainly the patients with worse renal function, if anything, tended to do better. And then the last pair of bars is a composite endpoint of stroke, systemic embolism, major bleeding, or death. And we call this the primary net clinical outcome. They were very comparable between patients with lower creatinine clearance. The hazard ratio was 0.86. And patients with creatinine clearance of above 50, the hazard ratio is 0.91. So for each of these endpoints, efficacy, safety, and the net clinical outcome, the results were good in patients whether they had a creatinine clearance above or below 50. They were comparable, and if anything, the bleeding profile of edoxaban looked perhaps more favorable in patients with lower creatinine clearance. Now, I want to show you, dig a little deeper, a more sophisticated analysis performed by one of my colleagues, Aaron Bolukula here, that was published in Circulation that looked at stroke or systemic embolism by creatinine clearance, now chopped up more finely in deciles of creatinine clearance. So to the left are the patients with the worst renal function, creatinine clearance below or equal to 42.8. So that was the lowest 10th percentile. And then the various deciles going up until you have patients with creatinine clearances over 100 to the far right of the graph. This graph is showing a stroke or systemic embolic event rates. The primary efficacy outcome in green is warfarin, and in yellow is edoxaban. And you can see that stroke or systemic embolism, starting with patients with worse renal function to the left, was reduced with edoxaban. These curves tend to come together at around the 6th or 7th decile, creatinine clearance roughly 80, 85. And then they do cross, and actually the warfarin group looks a little more favorable at the very high end of creatinine clearance. And I'll come back to this in a moment. Here are the data for major bleeding now by decile of creatinine clearance. A different story. Here at each decile, the rates were lower with edoxaban, and the relative magnitude was very similar. So the curves are almost parallel between warfarin and edoxaban. So regardless of the creatinine clearance seen in the Engage AF TIMI 48 trial, and that spans from 30s to low 40s in the far left, all the way up to well over 100, edoxaban reduced major bleeding. And then pulling it all together, here's the net clinical outcome, like I showed you a few slides ago: stroke, systemic embolism, major bleeding, or death. You see that edoxaban is favorable compared to warfarin. Outcomes were better for the net clinical outcome in patients with worse renal function. And then at the very high end, maybe the 9th, 10th decile, they were pretty much equal between warfarin and edoxaban. Now, I want to focus on two extremes, patients with poor renal function, and then in a moment we'll talk more about outcomes in patients with very good renal function, or the hyperfiltrators. So this is an analysis from one of my former colleagues and friends, Kevin Chan. While he was at the Massachusetts General, he's a nephrologist. He was interested in how DOACs perform in patients with moderate CKD. And so he took the data in patients with creatinine clearance between 30 and 50 from the 4 major DOAC versus warfarin trials. And we're going to focus on the bottom 2 rows here, the efficacy results. So prevention from stroke, systemic embolism, were all favorable for each of the 4 DOACs compared to warfarin, with hazard ratios of 0.79 for apixaban, 0.88 for rivaroxaban, 0.56 for dabigatran. Perhaps that by eyeball looks a bit lower, although the confidence intervals are very broad, and 0.87 for edoxaban. And I would say here that all the DOACs compared favorably compared to warfarin in patients with moderate CKD for prevention of stroke or systemic embolism. Contrast this now with the next row, which is showing the safety outcomes, so major bleeding in patients with moderate CKD, DOAC versus warfarin. you see that in two of the trials and two of the therapies, apixaban and edoxaban, there were significant reductions in major bleeding with the DOAC versus warfarin in patients with moderate CKD, while the other two, rivaroxaban and dabigatran, had hazard ratios right around 1.0. In other words, no difference in major bleeding between rivaroxaban and warfarin or dabigatran and warfarin in these moderate CKD patients in their respective trials. And for this reason, frankly, when I am faced with a decision of which DOAC would I prescribe to a patient with moderate CKD, I tend to use either apixaban or edoxaban. Now let's talk about the other end. And I mentioned a few slides ago how the efficacy of edoxaban and ENGAGE-AF tended to decline as the creatinine clearance improved, as the renal function got better and better. And in the hyperfiltrators, the curves even crossed. This is a pattern that was also seen with the other two factor Xa inhibitors, rivaroxaban and apixaban. This is a slide that the US FDA showed back in 2014 at a meeting where there was a review of the data from ENGAGE-AF that ultimately led to then its recommendation for approval. And you'll notice here the data broken out. So there's creatinine clearance between 80 or above, and then 50 to 80. And the endpoint being shown here is ischemic stroke. And I want to just focus on two numbers here. The hazard ratio for the NOAC versus warfarin in the ROCKET-AF trial in patients with a creatinine clearance 80 or better was 1.07. In other words, the event rates were higher with rivaroxaban than with warfarin. That's statistically significant, but you see the same trend in patients with creatinine clearance 50 to 80. The hazard ratio is 0.82, favoring rivaroxaban. So we see the similar attenuation of benefit at higher creatinine clearance. And this also applied to apixaban in the Aristotle trial. The magnitude was even more dramatic here, a hazard ratio of 0.87 in patients with creatinine clearance 50 to 80. But at 80 or above, those patients had a hazard ratio of 1.35 for apixaban versus warfarin. In other words, warfarin had fewer ischemic strokes, as you can see, 0.51 versus 0.69 for apixaban. And again, as I had shown you earlier, there was the same adverse trend in patients with higher creatinine clearance seen with edoxaban in the ENGAGE-AF trial. So there's something about the 10A inhibitors seen in each of these three trials where their efficacy to prevent ischemic stroke is reduced relative to warfarin in patients with high creatinine clearance. Interestingly, this pattern wasn't seen with dabigatran and Rely. It would be nice to be able to compare these drugs head to head in a trial in patients with high creatinine clearance, but as of yet, we have no randomized data there. And the last part of this discussion about renal function, I want to share with you some very new data. These are yet to be published, but were presented at ESC 2020 regarding NOACs versus warfarin from the 4 trials, but in an individual patient-level meta-analysis by the combined AF investigators, of which I am one. We've pooled all the data from the 4 trials and did a patient-level meta-analysis. Here are the data for stroke or systemic embolism, the individual patient data meta-analysis from 4 trials. The first graph is showing the effect on age, the second on body weight, but let's focus on creatinine clearance. And you see here this same pattern, but when you pool in an individual meta-analysis, the outcomes are more favorable for the DOACs at lower creatinine clearance with a hazard ratio less than 1 compared to warfarin. But then when you get to very high creatinine clearance, added around 110 or so, the outcomes start to favor warfarin. And here's all-cause mortality, again, age, by body weight. And let's look at the third panel by creatinine clearance. All-cause mortality overall, 10% reduction across the trials, and you can see it's most favorable in patients with poor creatinine clearance, low creatinine clearance. And then as you get to very high creatinine clearance, maybe around 110, 120, actually slightly favors warfarin. So this is a signal that was seen in several analyses across the trials of less favorable outcomes with DOACs versus warfarin in the patients with very high creatinine clearance, but in patients with more normal, mild, moderate renal dysfunction, outcomes tend to favor the DOACs. The second topic I want to cover today is this nexus between diabetes, atrial fibrillation, and anticoagulants. There's a complex interaction between AFib and diabetes as summarized nicely in this review article by one of my former mentees, Anna Plitt, that we published last year. And you see that there's overlap between the conditions. They also are additive and synergistic in causing more thrombus formation and increasing thromboembolism and stroke. In the Engage AF TIMI 48 data, we published our results last year in the International Journal of Cardiology, stratified by diabetes. Diabetics are in blue, non-diabetics in red. And you can see that across the board, the patients with diabetes did as well as the patients with no diabetes for a variety of efficacy endpoints at the top, and then safety endpoints, bleeding endpoints in the bottom, and the primary net outcome at the very bottom, the last pair of bars that show you a combination of efficacy, safety, and mortality. None of these p-values for interaction are different, so we conclude that the efficacy and safety profile of edoxaban was preserved, favorable, whether patients had or did not have diabetes. Even more recently, in the European Heart Journal of Cardiovascular Pharmacotherapy, we published the results of a meta-analysis of 8 different clinical outcomes in over 58,000 patients across the 4 trials. This is a very busy slide. I'm just making the point that we had over 19,000 patients with diabetes in this meta-analysis and over 45,000 without diabetes. Looking at the endpoint of stroke or systemic embolism, you see that outcomes favor the DOACs over warfarin. However, and favor overall combined by 20%. However, only dabigatran 150 milligrams significantly reduced stroke or systemic embolism compared to warfarin. Here are similar data for major bleeding, and now slightly different story. You see that the results are neutral for apixaban, dabigatran, and rivaroxaban, and only edoxaban, the standard approved dose, significantly reduced major bleeding in patients with diabetes relative to warfarin. The hazard ratio is 0.79, so a 21% reduction favored edoxaban over warfarin. And here are data with intracranial hemorrhage. Each of the drugs, very strong reduction in intracranial hemorrhage. Overall, the rate of ICH was reduced by 49% in diabetics. With a DOAC versus warfarin, the effects were particularly large for edoxaban, a 60% reduction in ICH, and apixaban, a 51% reduction in ICH. And finally, with mortality, we only had data from 3 of the 4 trials, but you see a consistent 10% reduction in mortality, favoring DOACs over warfarin, whether patients had diabetes at the top or did not at the bottom. So in summary, in patients with moderate renal failure, all the DOACs are more effective than warfarin. Only apixaban and edoxaban, however, significantly reduced major bleeding. In patients with high creatinine clearance, the efficacy advantage of DOACs is reduced. It favors warfarin, actually, with the versus 10A inhibitors in patients with very high creatinine clearance. And in diabetics, compared to warfarin, DOACs tend to reduce stroke or systemic embolism by 20%. They significantly reduce mortality by 10%. Only dabigatran at the higher dose, 150 milligrams, significantly reduced stroke or systemic embolism. Only edoxaban significantly reduced major bleeding in diabetics, while both apixaban and edoxaban had very large and significant reductions in intracranial hemorrhage in diabetics. Thank you very much for your attention.
Thank you. It was an excellent talk, direct from the investigator.
Thank you very much for your attention.
Okay. So, Dr. Ravi, can you go on for the next speaker?
Sure. I think the next topic will be presented by Dr. Fikri. Dr. Fikri needs no introduction. He is one of a very pioneer interventional cardiologists in the Middle East, and with more than 25 years of practice. I just call upon him to talk upon one of the most common topic which we as a cardiologist face in everyday life, What is the optimal therapy for patients who have atrial fibrillation and associated coronary artery disease? It's whether it's a triple or a dual NOAC. Dr. Fikri, the stage is yours.
Hello, it's my pleasure to share with you some information about a very important topic in our cardiology field. The patients who have to go for angioplasty and stenting, having atrial fibrillation with the need for a triple thrombotic, antithrombotic therapy. These are a difficult group of patients, and I'm going to try today to explain the efficacy and safety of triple therapy in regard to thromboembolic and bleeding risk. I will go quickly over the guideline recommendation, and I will review some of the literature which try to answer this question. We, most of us, practice is to use dual antiplatelet after coronary stenting, and we use usually 75 to 100 milligram of aspirin and clopidogrel 75 for at least 12 months. Patients who have high risk of bleeding, we can go lower with 1 month after a permitted stent or 6 months after a drug-eluting stent. However, in 5 to 10% of our patients going for PCI, we face the patient who have an indication for oral anticoagulation, which most commonly is atrial fibrillation, or patient who have prosthetic valve. And this number is increasing because the population is getting older and the incidence of atrial fibrillation is getting more. And we don't have really a clear, defined, optimal management for those patients. We know from the studies that dual antiplatelet significantly reduce cardiovascular event after coronary stent implantation. And on the other hand, oral anticoagulation reduce cardiovascular event significantly over dual antiplatelet in atrial fibrillation. So if you have a patient who is going for angioplasty and stenting, and in the same time his atrial fibrillation, you will be faced with the use of dual antiplatelet plus oral anticoagulant, which of course has a higher bleeding risk. Then when we have to make this decision, we have to assess the benefit and the risk. And assessing the benefit, we should assess the global ischemic risk. So patients who are at higher ischemic risk are usually of older age, or patients presenting with acute coronary syndrome or history of MI, extensive coronary artery disease, diabetes, or chronic kidney disease. Patients who have increased risk of stent thrombosis, like patients presenting in acute coronary syndrome, again, diabetic patients, patients with poor left ventricular ejection fraction less than 40%, first generation drug-eluting stent, and if there's any issues about the stent placement and properties. On the other hand, assessing the risk is important. Patients who have high risk of bleeding are the patients who have previous history of bleeding or on oral anticoagulant. Female population are at a higher risk, advanced age, low body, frail patients with chronic kidney disease, again, diabetic, anemia, and patients who are on chronic use of steroids or non-steroidal anti-inflammatory medications. The guidelines here from 2014 of the American College, American Heart, regarding patients with non-STEMI is recommending shortening the duration of using this triple therapy for the extent possible to limit the risk of bleeding, and they recommended also use of proton pump inhibitors, particularly of patients with history of GI bleeding, and they recommended to keep the INR at a lower level between 2 to 2.5 to reduce the risk of bleeding. And the guidelines for the management of patient with atrial fibrillation based on the CHES-VASC score, particularly if the patient are presenting in acute coronary syndrome. If the score is 2 or more, anticoagulation with warfarin was recommended, but they did not have a firm statement about the duration or agent use of antithrombotic management. And they give an option to consider oral anticoagulation plus clopidogrel with or without aspirin. The 2016 guidelines came with similar recommendations. However, they recommended use Chase-Vasc score and Hess-Bled score to assess the benefit and risk for every patient. And accordingly, you try to minimize the duration of the triple therapy, make the INR at a lower level. They recommended clopidogrel as the inhibitor, the B2Y12 inhibitor of choice. Use low dose aspirin less than 100. And they also recommended the use of BBIs in all these patients, particularly if they had history of bleeding. Now, when we look at the literature and see what the studies tell us, the WOOS trial here is trying to answer the question whether patients who are going for PCI on oral anticoagulation, is the use of clopidogrel alone is different in the instance of bleeding or risk of bleeding than if it is used plus aspirin. So in this open label randomized trial, more than 560 patients were randomized either to double therapy with oral anticoagulation and clopidogrel, or triple therapy with oral anticoagulation, clopidogrel, and aspirin. And the primary endpoint was the occurrence of any bleeding within the first year follow-up. And the secondary endpoint was the composite cardiovascular mortality and morbidity, stroke, target vessel revascularization, stent thrombosis. Most of the population, as expected, were above 70 years old, and they were male. And most of the indication for atrial fibrillation was, for anticoagulation was atrial fibrillation. We can see that there was significant bleeding in the triple therapy group, 44.9% compared to 19.5% in the dual therapy. This, we have to, understand that, there was, this study was not powered for stent thrombosis, and also BBI was not used liberally in this trial, and most of the bleeding came from minor bleeding like GI bleeding and stuff like that. However, the conclusion was that the dual therapy had significantly less bleeding compared to the triple therapy, with no significant difference in thromboembolic event. The ISAR triple study looked at the duration of triple therapy, whether 6 weeks of clopidogrel therapy in addition to oral anticoagulant and aspirin is different than if we use it for 6 months. And the primary endpoint again was the composite cardiovascular mortality, morbidity, stent thrombosis, stroke, and TIMI major bleeding. Again, as expected, most of the population were elderly, 74, and there was no detectable difference between the primary endpoint in 6 weeks versus, 6 months. The study did not show any difference if the duration was short or was long. That trial, of course, was underpowered to assess smaller bleeding differences. When we look at the Pioneer atrial fibrillation trial, here a new oral anticoagulant, rivaroxaban, was used, and the patients, there was a big study, multi-center, open label, 3 parallel group randomized controlled trial in 26 countries. Over 2,200 patients were divided into 3 groups. The first group received rivaroxaban 10 to 15 milligram plus B2Y12 inhibitor for 1 year. The second group used very low dose of rivaroxaban 2.5 BD plus DAPT for 12 months. And the third group used the conventional therapy of warfarin DAPT for the same period of time. And the primary endpoint was to look for significant bleeding. We can see here that, in the rivaroxaban based strategy, patient with atrial fibrillation underwent PCI. There was much lower frequency of clinically significant bleeding compared with warfarin and DAPT. And there was no stent thrombosis difference among the 3 groups. This led to the 2020 American College guidelines recommendations in patients with atrial fibrillation, venous thromboembolism undergoing PCI recommendation. Again, triple therapy was recommended to be used for the shortest possible time. When combination of antithrombotic therapy is needed, clopidogrel is the drug of choice. Oral anticoagulant, new oral anticoagulant were put as a preference over the conventional vitamin K antagonist or warfarin. Patient with high thrombotic risk, the triple therapy should be used at least, for 30 days. And they put some standard duration of antiplatelet therapy along with anticoagulant. So for patients who are going for PCI with stable ischemic heart disease, clopidogrel should be used at least for 6 months post-PCI, followed by a single antiplatelet, either aspirin or clopidogrel, along with the anticoagulant for additional 6 months, and then after 1 year, anticoagulant should be used alone. If the patient is going for PCI in the context of acute coronary syndrome, the clopidogrel for 12 months should be used, followed by oral anticoagulant alone. So the decision about the treatment and duration of dual antiplatelet needs an individual, decision making, and that has to be done on your clinical judgment, in your assessing of the benefit and risk ratio, and of course, the patient preference should be put in consideration. One of the tools that can help you decide who are the patients who can benefit from dual antiplatelet therapy is the DAPT score, which, as you can see, has multiple variables with certain points. If you apply this to your patient and he scores 2 or more, then you know that this patient has more benefit than risk in using prolonged dual antiplatelet therapy. I expect in the future there will be more use of the novel oral anticoagulants like dabigatran, rivaroxaban, and apixaban, and we will see if one is better than the other, or there's any advance in this area. Also, the use of newer B2 Y12 inhibitors will play a role. The optimum duration of dual antiplatelet therapy will be more defined. And the evolution of stent technology, we know that we have stents now that are FDA approved for using dual antiplatelet for short time, like 4 weeks. And this type of stent will help us to treat this high-risk group of patients. I would conclude here, and I would like to thank you very much for your attention. I'll be happy to receive any question. Thank you so much.
Can you unmute yourself, Professor Robert?
Can you hear me okay?
Yes, please.
Yes, great. Wonderful.
So we'll love to hear your comments to start with, Dr. Professor Robert.
Sure. No, I mean, these are very, very good reviews of complicated areas where we have new therapies. It's very exciting. And I have the same question for Dr. Agrawal and Dr. LD, and that is, we have new therapies here that have been introduced, I think with high quality data, but not very good data comparing, in the case of the new diabetic therapies, comparing the agents head to head, or in little data with them in combination. And then with regard to the last talk we just heard, again, limited data comparing NOACs head to head. So how do you sort that out? And maybe let's start with Dr. Agrawal. In choosing, between the agents, and then what do we know about combining these two new classes of diabetic therapies?
This is a very interesting question. So both the big trials which we have done for the SGLT2 inhibitors and the GLP-1 receptor agonist, they were actually done comparing the standard therapies of diabetes versus the newer agents. So all these age people in the trial, whether they were placebo arm or they were the active arm, they had a basal therapy which included the standard care of diabetes, which was available at that time, which typically included the DP4 inhibitors, insulins, and sulfonylureas, and the metformin. In addition, they were giving this newer therapies, which are SGLT inhibitors and the GLP-1 receptor agonist, and they showed clearly the advantage of the newer drugs. So certainly, the newer molecules are better than the older molecules. Now the question goes about combination. Yes, there is certainly a very strong role of combination, but there is no head-to-head trial which compares the combination therapy of SGLT inhibitors and GLP versus traditional molecules. There is no reason, there is no interaction between the two classes of drugs. GLP drugs act on the incretin pathway, and the SGLT inhibitors act on the renal pathway, and there is no theoretical interactions between the two molecules. So we use in our hospital routinely anybody admitted with a cardiac MRI. He was a diabetic, he goes on a GLP-1. He is not a diabetic and he's got heart failure. He actually goes on SGLT inhibitors right away, whether he is diabetic or not diabetic.
And do you find patients where you may consider using both, a diabetic
Yes.
with heart failure? Yeah.
You can say 25 to 30% of patients, they use both. The limiting points are two. For example, for the people who are using SGLT inhibitors, we cannot use for the creatinine clearance less than 30. Before it was 45. With the newer guidelines, they have come with 30 for diabetes management. And for the heart failure, dapagliflozin has an indication for GFR creatinine clearance up to 15. So for certainly 30, we can go both the agents. So this is one of the limiting factors. And for the GLP-1, the limiting factor is usually nausea. So the tolerability for GLP-1 is not that easy. There are some patients who just couldn't tolerate it, and there are some patients who become acclimatized to the medicines over time, and they become neutral. So, and the second is the reluctance of the patient to take an injectable form of the medicines. As you know, the GLP-1 is all injectable except the oral semaglutide, which is going to come. It's not yet come, but this is only downfall of it.
I have a question from Professor Robert. Your presentation brought out a very, very important point, which at least I never considered before, that people with high creatinine clearance do not do fairly well with dogs. So my question is it because of the more clearance of the agent? And do we think that the higher dose could have done better?
Yeah, that's a great question. It's not really known because, you know, what we're looking at are hazard ratios. So there are two possibilities. One is that maybe the DOACs didn't perform as well in patients with high creatinine clearance. The other possibility, and there's some evidence, is that warfarin performed even better in patients with high creatinine clearance. That warfarin is the thing that's changing, because remember, a hazard ratio has a numerator and a denominator. I can say that we in our data with edoxaban looked at drug concentrations, and we do see above about a creatinine clearance of 80 is maybe a 20% lower drug concentration at the high creatinine clearance. So that could be part of the story, but it's not so simple because of the four DOACs, dabigatran has the highest renal clearance, 80% renally cleared. Yet that was the only DOAC that was still better than warfarin in the high creatinine clearance group. So if it was all to do with creatinine clearance, then why did dabigatran fare well? So it's not known. But I would say this, the DOACs in the high creatinine clearance patients overall are more similar to warfarin. And so you still have the other advantage of the DOACs, right? That they don't require frequent monitoring. They have fewer drug-drug interactions and fewer food-drug interactions. So you still may choose a DOAC, but your advantage in preventing ischemic stroke isn't there at the high creatinine clearance.
Thank
I think Fikri cannot see or hear, and so shall I put a question for Amrish? Amrish, about the SGLT2. There was a fear that cardiologists might hijack the SGLT2 from the endocrinologists. So it might even come as a heart failure drug in the non-diabetics. My question to you is, in acute illnesses also, are you comfortable starting SGLT2 when they come in with acute heart failure? Our endocrinologists had a little worry. Maybe you should stabilize them, get them out of ICU, and then start. Your thoughts on that?
Yes. So there are two components. Now the drug companies are actually marketing two preparation of SGLT inhibitors, identical molecules, identical doses, different labeling, different packing. So DAPA has got already a molecule, has got a packing in UAE, which was diabetes. And the DAPA H is the formulation which will come out of the heart failure. Identical molecules, but the product insert is different. For example, for diabetes, they have a creatine clearance of 30. For heart failure, they have even as low as 15 or 10. So this is one part.
Dosing is the same?
Same, identical, no difference. The same tablet shape is like same they do Viagra. They are sildenafil, the market for the pulmonary hypertension and the market for erectile dysfunction.
Right.
Slight differences, but the molecules remain the same. The second part of the question is that how soon in the heart failure patients you will start SGLT inhibitors. There are a lot of people who are proponent. For example, our friend Dr. Javed Butler and Zanat, they are the proponent that they should come for the patient with heart failure with the reduced EF after diuretics and just after beta blocker. Even they are saying even before you start this patient on ARNI, you have to put this patient on SGLT2 inhibitors. But your question is very precise. Your question is that what about hospitalized patients with an acute decompensated cardiac failure? When are you comfortable in starting SGLT inhibitors? The key in this patient is the kidney functions and the hemodynamic stability and the fasting. If some person is intubated, ventilated, and is not taking anything orally, then I will be little bit reluctant to start SGLT inhibitors. The reason is that the mechanism of action is from the kidneys. They require certain amount of volume deliverance by the kidney to be fully effective. So if somebody is not making adequate diuresis, you want to hold for a few days.
Dr. Fikri, I just have a small question. I know like we have a lot of patients who present with on a newer oral anticoagulant with atrial fibrillation, presenting with an acute MI or with an NSTEMI. What is your take on with the anticoagulation during the PCA in these people, and what do you keep the level of the ACT in such patients actually?
Dr. Fikri is on mute. Can you come on?
Dr. Fikri, can you unmute yourself? So, Dr. Ravi, I think you will ask the question offline later.
Oh, okay, sure. I think that's fine.
So Dr. Fikri is not able to unmute himself, it seems. He's not able to hear us, probably.
All right. Okay.
You are muted, Dr. Fikri. So perhaps he did not hear also your question.
So my worry
there is some connectivity issue with Dr. Fikri, I suppose, right from the beginning. So I think the chairpersons can conclude the session.
Okay, can you hear me now? Can you hear me?
If we can hear you, one
Yeah,
very quick comment you can give now.
Can you hear me now?
We can hear you now. If you can give just one quick comment, because we are going to finish this session immediately.
I have some technical issues. I'm sorry about that.
Yeah. So Dr. Ravi asked you a question that patients come with already oral anticoagulated and they are coming for PCI. So very quick comment.
I just want to say that, because we do. Okay.
So I'm sorry, there is a connectivity issue with you, yeah. Dr. Fikri. So may I request the moderators and chairpersons to please conclude this session. And personally, I thank you all.
Thank you, Dr. Mittal. I think getting people from all around the world and getting all of you to listen to us from here in India and
as we do most of our.
Great. Dr. Robert, any final comments before you wind up for the day? Dr. Mittal, thank you for inviting me. Dr. Robert, yes, please come on.
No, I think it was an excellent session. It's an exciting time to have these new and better therapies for managing patients with diabetes and as anticoagulants. And there's an interesting intersection between those areas of atrial fibrillation and diabetes as well. And I think it's a good idea for the healthcare providers to become familiar with these new classes of medications. There are nuances and differences between them. And we look forward to more studies, in particular to help guide the clinicians of which ones do you choose, because now we have almost too many choices. So thank you all for allowing me to participate in this session.
Thank you, Dr. Mittal. I think in this challenging time, you've arranged a very nice meeting, and it was very informative. And I am suppose like all my colleagues would have learned a lot and very interesting sessions. And more important, like we kept on to time so that we could complete and have a good discussion as well. Thanks once again for being part of it, actually.
Thank you so much. So first of all, I will thank you all the existing last session members, because you are in face, I can see you all, we can interact together. So I can't thank enough for all of you to come forward. Meeting is not done by one person. Meeting is a conglomeration of, there were 30 lectures, there are 45 faculty members, there is a backstage team, there are sponsors, there are contributors, there are partners, there is family who supports right and left in the endeavor which you do. So I'm so pleased that all of you supported me very well. I just worked as an anchor. I just worked as a platform to bring all you together. It went very well. I hope it served the purpose to so many attendees and to all of us who can gather or who could gather at least 1 point for lecture. Then also it's a lot. You get 30 extra points. Like I never thought that DOECs are not so good in in high creatinine clearance. So we learn every time something new. So I am very much thankful to all the speakers who are offline, online, those who have contributed since yesterday. I'm thankful to everybody who supported me in this meeting with this great note, with a kind appreciation for all of you. We conclude Shakeheart 2021, and we hope to see you, and we hope to continue this endeavor next year, maybe bigger, larger, better, Shakeheart 2022. And I hope all of you, the existing faculty members, would actually be automatically coming forward and be part of it. Thank you so very much. Many thanks. Just wait for a video as a last conclusion. Thank you. Thank you.
Good night.
Thanks.
Good.
Good night, everyone.
Good night. Thank you.
Okay. Good night, everyone. Bye-bye.
Good night. Thank you. Bye. And good morning.